Hello, 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 hello. Good morning, everybody. Today is the day of beginning our 7th LIVERCON 2024. Hepatitis Foundation of Tripura proudly announces the beginning of LIVERCON 7. This is a 3 days long conference on liver disease. And it is conjoined with Padma Ganga Gomati Liver Conference. So, in these 3 days, we will have a lot of discussion, lot of science, lot of entertainment, and lot of excitement. Be ready for that. And I would like to announce that this whole program will be shown, will be streamed live in our YouTube channel, Voice of HFT. And if you just click 7th LIVERCON, you will get it directly connected. Or we have given the connection to as many people as it is possible. So those, you can ask your friends, those who are not attending the conference directly, live, they can see it virtually. Without further discussion, we would like to start our LIVERCON 7. And this conference will be inaugurated by none other than Dr. Jyotirmoy Pal, a very good friend of Hepatitis Foundation of Tripura and Tripura as a whole. And we are very happy that he has been elected as the National President of Association of Physicians of India. And probably this is one of his very beginning program at the national level. We have got a lot of other dignitaries, senior faculties of the country, Bangladesh and Nepal. We welcome all of you. To start out this program, I request Dr. Jyotirmoy Pal to please come on the dais. I also request our President, Dr. N.L. Bhaumik, our Technical Director, Dr. Ajit Ranjan Chaudhary, and our Scientific Chairman, Dr. Abhik Chakravarti, to please come on the dais. Sir, please. I request all of you to please take your seat. Thank you very much. Now, floral welcome on behalf of Hepatitis Foundation of Tripura and on behalf of the organizing committee. I request Dr. Abhik Chakravarti, Chairman Scientific Committee, to please welcome all our dignitaries on the dais. Now we would like to listen from Dr. Abhik Chakravarti. Yes. Before that, just 1 minute. Dr. Priyabrata Sinha will welcome Dr. Abhik Chakravarti. On the right, yes. Our very dynamic scientific chairman, who has planned and designed this whole conference. Welcome Dr. Avik Chakraborty, and this is the time, the inaugural speech of Dr. Avik Chakraborty, and it will be followed by the inauguration by lighting of the lamp. Dr. Yes, we should have a very good photograph. Very nice. And all of you can see that it is already streamed live. Yes, very nice, very nice. So you have got a big technical team who is streaming it live directly on YouTube. So Dr. Avik, please have your words, and after that we will have the lighting of the lamp by Dr. Jyotirmoy Pal and all other dignitaries over here. Avik, please.
A very good morning to all of you. Respected Professor Jyotirmoy Pal sir, President-elect of Association of Physicians of India, President of Hepatitis Foundation, Dr. Renal sir, Dr. Ajit Ranjan Chaudhary sir, the Technical Director of Hepatitis Foundation, respected guest faculties, the luminaries in the field of hepatology all over the country and from Bangladesh and Nepal who has come all over to the place of Tripura. I welcome you all in this scientific extravaganza of as a part of LIVERCON, 7th LIVERCON and 5th Padma Ganga Gomati International Liver Conference. Though Tripura is located as one of the small states in the northeastern, but as a vision, it started the LIVERCON as one of the pioneer program of only about liver in this part of Northeast from the year around 14 years back. So it is the vision of Hepatitis Foundation that to start a liver-specific program so that the doctors who are there in the Northeast, especially in the Tripura, get enlightened by the newer scientific developments from the various eminent hepatologists of the country and also from the international speaker. I, as a part of scientific committee, once again welcome you all. We tried to amalgamate both the newer and the prevalent topics of hepatology. We'll be starting with the postgraduate presentation. There will be 2 cases, one from the Agartala Government Medical College and another from the Tripura Medical College, followed by the scientific session by the various luminaries in the field of hepatology. I welcome you once again in this scientific program. Thank you all. Please enjoy the program. Thank you.
Light represents knowledge. Knowledge that spreads from teacher to student, from person to person, from book to everybody here. So right now we shall proceed with the lighting of the lamp. I request our dignitaries on the dais to please come forth and grace us with the lighting of the lamp.
Shubham karoti kalyanam arogyam dhan sambada Shatru buddhi vinasaya deep jyoti namastute, which means salutations to the light of the lamp, which brings auspiciousness, health and prosperity, which destroys the inimical feelings. Salutations to the light of the lamp.
I request Dr. Jyotirmoy Pal, President-elect of Association of Physicians of India, to please inaugurate our scientific program.
Dr. Chaudhuri, Dr. Abhik Chakraborty, Dr. Bhaumik, Dr. Pradeep Bhaumik, all my friends, students, ladies and gentlemen. It is really a privilege to be present almost in every year in the inaugural session of Hepatitis Foundation of India. This is called LIVERCON. Name is given Ganga, Padda, Ganga, Gomoti. Dr. Organizers, Dr. Bhaumik very nicely touched the Bengali emotion. But Ganga and Padda hillside is available. I don't know in Gomoti hillside is available or not. So, Tripura is a small, very small state, like a district of our West Bengal, maybe one district. Population is very less, but I am really admirer of the people of Tripura and then observe their keen interest, their activity, and their enthusiasm for the academics. I have come here for API program, for ICM program, for RSCGA program. Now we are coming for the LIVERCON. Focus on a particular subject of focus, only on liver. This is very amazing. Only, I think only the big mega cities can do such type of focus program, particularly one organ. And whenever I have come for different program, API, ICM and these, I have seen the keen interest of the student. There are only 2 medical colleges, hardly 14 to 15 PG together, I think, per year. But I have seen almost every, last year I have shown an API program, almost every 100% postgraduate present their cases. This is very really amazing. I definitely, I wish all the success of the students. And regarding this Hepatic Foundation, it is running almost 20 years. And last year I came to know there's almost 40% population, highest percentage of population in our country was vaccinated with hepatitis B. Hats up to Dr. Bhaumik and your team. This is really a Herculean task to almost cover almost near about the 50% population with such a vaccination. And as a president API, when I was the dean, I always feel that organizational work should not be only the academics. Whatever we are doing, whatever we are discussing academics, why we are discussing? Because this can be translated into better medical practice. So that ultimately people become benefited. So everything, whatever we are taking breath, what we are eating, what we are smelling, everything for the people. So organization should not be confined only in a 5-star hotel with only such academics. Organization have to reach to the people. And Hepatic Foundation, I think, is ahead of even the larger organization like API. Many larger organization, API, CSI, many organizations, we have failed to reach to the people to the grassroots level. But Hepatic Foundation of India is very successful with the leadership of Dr. Bhaumik, Dr. Chaudhuri. You have reached to the almost 50% of the population of a state. And this should be the model to all organizations of the country. So I wish all success of such an initiative, one side from academics and another side to the public awareness program, including public benevolent program. And I wish every year such type of program will motivate and will bring new colors and invite and motivate all the new generation doctors to be involved in the Hepatic Foundation of India. And I wish all success of this program. Thank you. Thank you.
Thank you, sir, for your words of wisdom. I would also like to thank the dignitaries for gracing us with their presence. Now we will slowly proceed to our scientific program part of this conference. I would request all the dignitaries to please take their seats on the audience. Thank you, sir. Thank you all for your patience. So we are slowly going towards our scientific program.
Slide down.
May I call all of your attention for the first session of LIVERCON 2024 organized by Hepatitis Foundation of Tripura. This session has been named as Master Class on Hepatology.
Slide দিয়ে দাও। Change করতে হবে।
May I take this honor and privilege to call on stage Dr. Premashish Kaur, Dr. P. N. Rao, Dr. Akash Roy, and Dr. Godas Choudhury, sir, to chair this session. To present the first case of the day, I'd like to call on stage Dr. Manodip Mondol and Dr. Prithvijit Kole.
Shall we start? আমি জাস্ট বলতে চাই যে প্রদীপ তোমরা অ্যাটমসফিয়ারটাকে খুব ইন্টিমিডেটিং করো না, এমনিতেই ছাত্র, তারপরে পরীক্ষা তো দিতেই হবে, তো ওই জন্য উইল মেক ইট ইনটু আ ভেরি ইনফর্মাল ডিসকাশন, ওকে? উইল স্টার্ট উইথ ওয়ান অফ ইউ হুসএভার প্রেজেন্টস। রিমেম্বার যে প্রেজেন্টেশনের মেন পারপাস হচ্ছে নট টু গেট টু আ ডায়াগনোসিস বাট টু আইডেন্টিফাই আ প্রবলেম। ঠিক আছে, দুটোর মধ্যে কিন্তু ভেদ আছে। ডায়াগনোসিস তো আলটিমেটলি যেমন টেস্টে বেরোবে, বাট আইডেন্টিফাইং আ প্রবলেম, আ ক্লিনিক্যাল প্রবলেম, ঠিক আছে? তো উইল গো উইথ আ ভেরি ব্রড বেসড অ্যাপ্রোচ। এখানে তিনজনেই যারা আছে খুব ডেঞ্জারাস লোক, হ্যাঁ, আমি এককালে খুব ডেঞ্জারাস ছিলাম, কিন্তু এখন আই এম দ্য সফটেস্ট, ওই জন্য তোমাদের ভয় পেলে আমাকে কথা বলবে। অল দ্য বেস্ট, ইন্ট্রোডিউস ইউর সেলফ অ্যান্ড লেট স্টার্ট। এদের চেনো তো? ডক্টর প্রেমাশিস কার হচ্ছেন, রিটায়ার করেছেন ফ্রম মৌলানা আজাদ মেডিকেল কলেজ, অনেক বছর প্রফেসর, অল ইন্ডিয়া ইনস্টিটিউটে ছিলেন, আর তারপরে উনি ডিন ছিলেন, তো ওই জন্য উনি অ্যাকাডেমিক্যালি খুব সাউন্ড। আমার থেকে উনি 2 বছর না 3 বছর সিনিয়র ছিলেন অল ইন্ডিয়া ইনস্টিটিউটে। ডক্টর পি এন রাও আমার থেকে সিনিয়র। পি এন রাও ইজ নাও ইন এশিয়ান ইনস্টিটিউট অফ গ্যাস্ট্রোএন্টারোলজি, খুব লিভার ফোকাসড এক্সপার্ট। অ্যান্ড আকাশ ইজ আর নিউ kid on the block, but excellent. আমি লাস্ট 1 মাস আগে আকাশের একটা কেস ডিসকাশন শুনলাম কলকাতায়, fascinating, and you made people think, which I really enjoyed. Okay, chalo, all the best.
Good morning, respected chairpersons and my teachers, my colleagues, seniors and juniors. I am Dr. Manodip Mondol from AGMC GBPH from Department of Medicine, and there is Prithvijit Kole with me. So today we are going to present a case. One 45 years male patient who is a shop owner came from a rural part of the Tripura, that is Khwai, was admitted in our hospital on 23rd May and 2024, and we we examined the patient on the same day. So patient present before us with the chief complaints of fever for last 1.5 months and yellowish discoloration of his eyes for last 1 month. So history of present illness. Patient was apparently well 1.5 months back when he developed high-grade fever which was insidious in onset and intermittent in nature. It was gradually progressive for the first 2 to 3 days and subsided on taking oral paracetamol. It was associated with anorexia, fatigability, but there is neither day-night variation of the fever not associated with chills and rigors during febrile episodes, nor the night sweats or appearance of rash. The patient visited the local hospital for same illness. Following that, fever subsided and patient returned back to home after 5 days. After 10 days, the patient developed similar kind of fever, but of mild grade again. This time he was associated with yellowish discoloration of eyes, which is gradual in onset and slowly progressive in nature. It gradually involved oral mucosa, generalized skin. This has been persisting for last 2 months. It is also associated with yellowish discoloration of urine. There is no history of distension of abdomen, swelling of limbs, passage of black colored stool, red or coffee ground color vomiting, altered sensorium, significant weight loss, pain abdomen, clay colored stool or itching of the body. He visited local doctor for his illness and took medications at home for last 1 month. Now the history of past illness. The patient is a known case of chronic hepatitis B for the last 18 years and has been under regular medication for last 3 years. The patient was diagnosed as hepatitis B when he was undergoing pre-operative checkup for cholelithiasis. Subsequently, he underwent laparoscopic cholecystectomy. There is no previous history of jaundice prior to this episode, and there is no history of diabetes, hypertension, tuberculosis, thyroid disease in the past. Family history. The wife of the patient was diagnosed as a case of chronic hepatitis B 22 years back during first childbirth in 2002 and had been under antiviral medication for the same duration. Her children are vaccinated properly as per the schedule. Further, the brother of the wife was incidentally diagnosed to have chronic hepatitis B for 7 years and had been under medication for the same duration. So personal history. The patient is married and 12 plus. His dietary habit is mixed diet. The patient is a non-smoker but chronic ethanolic and consumes 40 grams of alcohol 1 to 2 days per week for last 18 years. He took last ethanol, that is 40 gram ethanol 7 days back prior to the first episode of fever. The bowel habit was, the patient is occasionally constipated. The bladder habit was normal. There is altered sleep cycle and daytime sleepiness was present. The appetite decreased and there is no significant travel history or there is no high risk sexual behavior. Treatment history. Patient was operated for cholelithiasis 18 years back. The patient was diagnosed to have hepatitis B that time and was on regular follow-up but started on antiviral medication for last 3 years. Patient was never treated with blood products. There is no significant drugs, herbal or alternative medicine intake and no allergy history noted. From the history, our differential diagnosis is acute on chronic liver failure, viral hepatitis other than hepatitis B virus, and alcoholic hepatitis.
You know, I'll tell you, this is supposed to be a liver clinic, but let us step back. We shouldn't be biased at a liver clinic, we have to think in terms of liver. Tomake jodi ekta patient, you want me to talk in English or Bengali, whichever is comfortable with you. See, if a 45-year-old person comes with high-grade fever, which lasts for a fairly longish period of time, mane 2-3 din hole to viral bola jeto, it's been going on for a while. So what would be the thoughts that cross your mind? I mean, forget the hepatitis B with the family history and all that. I mean, they are important, but let's look at other common issues first before we jump to a diagnosis. তোমাদের এক্সপিরিয়েন্সে তুমি তখন এমডি করছো তো,
Yes, sir.
তো যদি কমনলি কোনো লোক আসে 45-year-old ম্যান আর তার খুব হাই গ্রেড ফিভার চলছে 5-7 দিনের ওপরে, what are the thoughts that cross your mind?
What is suggesting to you, what are the causes of febrile jaundice?
Sir, it may be viral hepatitis due to.
না তোমার প্রথমবার যখন জ্বর হয়েছিল জন্ডিস ছিল?
No, sir.
হ্যাঁ, তো let's
Sir,
go a
this
little
may
bit.
be-
No, it came in the second episode. So first one was a long episode of fever, and the only thing he took was paracetamol and possibly some antibiotics given by a doctor. So as Dr. Pal very rightly mentioned, that we have to be on the ground and look at what are common factors before we jump to rare issues. So সেই দিক দিয়ে একটু ভাবতে চাও?
Sir, yes, sir. There may be any type of viral fever may be there, or no, sir. Means during the first few days, if it is presented the 5 days, 5 to 4 days, maybe viral infection, maybe some bacterial infection, and like pneumonia can be there.
Sir, leptospirosis can be considered, brucellosis can be considered. Sir, it can be tuberculosis with no jaundice.
Anybody from the hall?
So it can
Maybe.
be malignancy if it's. Sir, leptospirosis, viral like CMV hepatitis, Epstein-Barr virus hepatitis, if any hematological malignancy, malaria, severe malaria. Yes, sir. Malaria scrub typhus. Yes, sir.
Malaria and typhoid, I would include in the list because you know, লম্বা fever, 45-year-old person, out of the blue জ্বর শুরু হয়েছে, কিছুতেই নাপছে না, প্যারাসিটামল খাচ্ছে, ঠিক আছে? আর তোমাকে নেক্সট কোশ্চেনটা জাস্ট জিজ্ঞেস করছি ফর অ্যাকাডেমিক পারপাসেস, এই যে দুটো পসিবিলিটি হলো ম্যালেরিয়া বা টাইফয়েড, ক্যান দে অলসো এফেক্ট দ্য লিভার অ্যান্ড প্যারাসিটামল? তো এই তিনটে ফ্যাক্টরস যদি থাকে, তো হাউ ডু ইউ থিঙ্ক ইউ উড লুক অ্যাট দ্য হোল হিস্ট্রি নাও? ফাইনালি কি বেরোবে সেটা আলাদা কথা, কিন্তু
Sir, in case of malaria, we should take the fever with chills and rigors, maybe the paroxysmal episodes may be there, or sometimes that discoloration of the urine, red color urine can be there, or altered sensorium may be there, pain abdomen may be there. In case EOLO is rash and subconjunctival hemorrhage can be there.
Patient can be a farmer, sir.
Rodent, yes.
Rodents, rats in the paddy fields, rice fields, it's more common, sir. Exposure.
I'll just give you a hint. Hint means, and see, whenever you are faced with any situation, think of three things. One is that it is related to the underlying disease, whatever it is there. Second thing is that it is not related to the underlying disease, this is something new has happened. Third thing is, it is iatrogenic. In iatrogenic, you got two things. One is a drug-induced iatrogenic problem, another is interventional induced iatrogenic problem. Here the first thing, as you said rightly, do not jump to conclusion of the previous whatever has been happening. First thing is to decide what is the cause of an acute febrile illness in this patient. That's the first one, causes list. Then if you are not satisfied with that one, if you think that underlying disease is there, then bring into other causes which we'll discuss later.
What is the history? What is the other description which you have given? What goes against the diagnosis of viral hepatitis in this patient?
Sir, actually in viral hepatitis, the jaundice and fever, they means there is no that such a gap between fever on onset of the jaundice, first one, and again, sir, pain abdomen is not there. Sometimes patient may feel pain abdomen.
No, if you look into the natural course of a patient of viral hepatitis, once the jaundice appears, the fever disappears.
Disappears.
So whenever the fever continues beyond the appearance of jaundice, it is something which you have to think is unlikely to be viral hepatitis. It may be some other causes which is leading to the persistence of jaundice along with the fever. So we need to really rule out all those conditions where fever continues even after the appearance of jaundice. What are those conditions? Where fever continues even after the appearance of jaundice? You said typhoid fever.
Yes, sir.
Agreed. You said leptospirosis.
Leptospirosis,
Fine.
brucellosis.
Agreed. Any other condition which we see in the community, like amoebic liver abscess?
Amoebic liver abscess.
This is a condition where
Yes, sir.
fever and jaundice, this thing can, the jaundice is not very common in amoebic liver abscess, but it can happen in 10 to 15% of the patients. Then, what about cholelithiasis? Cholelithiasis with choledocholithiasis, the fever would continue even after the appearance of the jaundice. Tuberculosis, granulomatous hepatitis, fever would continue even after the appearance of the jaundice. So you have to see this is an important point which distinguishes from viral hepatitis, continuation of fever even after the appearance of jaundice.
It's a very cardinal point, as I think Professor Pal was also pointing out. Whenever you have anybody who you're suspecting to have viral hepatitis, natural history says as soon as the jaundice appears, your fever disappears. If the fever persists, there can be two ways out of it. A, your viral hepatitis is complicated by something, like you develop a UTI on top of a viral hepatitis. You can have fever persisting. You develop a secondary infection. Your fever can continue. You develop a complication like a systemic inflammatory response syndrome, something like an HLH. Fever can persist. So that's when viral hepatitis is there. And what the other part is, sir, is saying, when it was never a viral hepatitis, that it was always something else, where you'll put all these DDs into your account. So you should start like that and bring in those common things first before going on to very broad liver specific differentials like alcoholic hepatitis and all. I think we'll come to that as time goes on.
Yeah, but I'll tell you, I think the points the others have made, we are all slightly older people. Always start with common things first and broad base. Never try to focus into one or two very narrow entities, because then, there was a person in our batch, Randhir Sood, all of you know Vedanta. One thing that I admired about him from All India Institute days is that he never made a blunder. So he always kept his differential diagnosis very broad. And I think that's the good trait of a good physician. If you make a narrow possibility, then it's easy for somebody to say, see, you got it wrong. Okay? So all these infective causes we would look at first. And since there was a history of cholecystectomy, whether there was ongoing cholangitis is a possibility, although pain was not a significant feature. But hepatitis B, from what you described in the history, that he was given medicines, he was on medications for 3 years. There was a family history. In fact, tomorrow in my talk, I'll show you several families where 6 people are all affected. But it's not necessarily that everything that happens is due to B. And that is where you also have to be a little alert. Okay? So, by the way, how many cases have you seen of brucellosis?
I have seen 3 to 4 cases, sir.
Oh, that's very good, because I hardly see brucellosis except in the patients who come from overseas. And leptospira, yes, we do see on and off.
In your history, I just have one question. You mentioned there is an alteration of sleep-wake cycle with daytime sleepiness. Is it his normal way of sleeping, or this is something which is nuanced?
Something in the last part of his course of his illness, he developed this kind of features. And he was at home for last 1 month. And gradually he was referred here in Agartala.
The other thing is that, the alcohol, if your history is right, 40 ml of alcohol that he took 1 week ago If you want to link it with his fever and jaundice, it means either the history is wrong or we are getting it wrong. Because no, that's not a dose. I mean, that way I guess that after Pradeep Bhaumi's party, every other person will have a chance of getting into alcoholic hepatitis. So, I mean, what I'm trying to say is that everyone who takes a relatively small drink and 1 week later gets fever, you have to be cautious in linking it because these labels often tend to stick, which may be a little dangerous. Okay?
Thank you. But I think one has to also remember that if you have fever, person is taking alcohol and within his 1 week or 10 days exposure of the alcohol, he has developed jaundice and the fever persists. That is something which does not happen in viral hepatitis, but that can happen. Persistence of fever and the damage of alcohol leading to acute alcoholic hepatitis. The fever can persist even after the appearance. Severe alcoholic hepatitis, fever can persist even after the appearance of jaundice.
On general physical examination, patient is conscious, alert, febrile, and oriented to time, place, and person. The patient is of average build and had a BMI of 23.4 kilogram per meter square. The patient is in decubitus of choice. The findings in general general physical examination is patient was having tachycardia, blood pressure was bit lower side, and the temperature was raised, pallor and icterus was present. Other examinations revealed no significant abnormality. In the systemic examination, the inspection of gastrointestinal system was normal. On palpation, the temperature and tenderness, temperature is normal and tenderness absent. Liver was not palpable. Spleen was palpable 3 cm below left costal margin, which is firm, non-tender, smooth surface, regular border, and splenic notch was felt. And there was no fluid thrill or shifting dullness, no other lump or organomegaly noted. And the other system examinations revealed no abnormality.
When we come to the investigations, these are the investigations which were done.
No, so what is your working diagnosis now? So you know the clinical impression leads us to what is called as a working diagnosis. If suppose you had found multiple lymph nodes, you might have thought about lymphoma, for example, or a reticular malignancy. You can't feel a gallbladder because it's post-cholecystectomy, okay? But your liver was also not enlarged, okay? There was no evidence of decompensation, no ascites, no pedal edema. You know, when you mentioned pallor, in this case, it's very important to tell how significant was the pallor. See, this is a habit. Most of the rural patients we see, we write pallor 1+. 1+ pallor, now you have to understand, if it's malaria you're thinking of, it will be significant pallor after so much time. Because RBCs are destroyed, you know. So was it significant pallor or just mild pallor? Mild pallor. So, you know, these small little things, because you have a spleen there.
Yes, sir.
So obviously malaria can't be discounted. But usually if you have malaria going on for about a month or so with jaundice, which indicates that there is some degree of RBC destruction, then I would expect the pallor to be fairly significant. Okay, so clinical bedside decision making is very, very crucial. So what's your working diagnosis now?
Sir, ACLF, acute and chronic liver failure.
What is the definition of acute and chronic liver failure? I'll pass it on to my other.
No, the first thing which I'll think is that there is a syndromic diagnosis, sepsis. It's a very clear evidence that there is a sepsis here.
Sepsis.
As you said rightly, SARS, sepsis, severe sepsis, and septic shock. Right? That is the primary diagnosis. Because once you put into acute ACLF, that's an entirely different thing. You know, that you are connecting to the past events and then trying to say that this is it. But first our primary diagnosis should be the sepsis and sepsis. Here obviously it appears to be septic shock.
Yes,
so for that we have to find out the reasons for that one and connect the previous, whether cirrhosis is there or hepatoma is there or anything else.
The most important.
The last is liver failure, na?
Yes, sir.
So what is the evidence of liver failure here?
So
Patient, in a case of chronic liver disease, it may be the patient may be compensated or decompensated, or cirrhotic patient or chronic non-cirrhotic patient. If there is, means according to the Asia Pacific guideline, the central part of the definition is the dysfunction of the liver. So if the dysfunction of the liver is suggested by increased bilirubin more than 5 milligram per deciliter, and along with INR more than 1.5, and it is complicated by the ascites, encephalopathy, or both within the within 1 month, that is 4 weeks after the first diagnosis of the first presence of the complaints of the patient. It is called ACLF.
There is no ascites. There is no encephalopathy.
Encephalopathy was there.
No, but your central nervous system examination was within normal limits.
Yes, sir.
Can you come back to that slide?
Sir, actually, patient was admitted on 24th, and we, at the later part of the examination, sir, we found that the patient was getting disoriented. So at the later part, initially on the first day we examined the patient, that the patient was like oriented.
No, whatever your diagnosis has to be, it should be your cumulative examination. This is if you're presenting these findings. Based upon this, what sir is asking is, what is your diagnosis? As of these findings, there is no encephalopathy.
No, sir.
As of these findings, there is no ascites.
No, sir.
This is not ACLF. Okay. You started off with saying that it's a febrile illness with jaundice, and we differentiated it as either it is a purely hepatic related illness, which is a primary hepatic disease, or it's a systemic manifestation. With your clinical examination, have you got any wiser? Have you ruled out some other causes or ruled in some other causes? I saw you put alcoholic hepatitis as one of your differentials.
Yes, sir.
What sort of a liver you usually get?
Yes, sir. Sir, no previous signs of chronic liver disease. Okay, sir.
See, your two important physical signs are there, no?
Yes, sir.
One is the fever, jaundice, and splenomegaly.
Yes, sir.
These are three important findings in your case.
Yes, sir.
You have to correlate these three important findings with the course of the illness. What are those conditions which can satisfy the continuation of the fever, jaundice, and splenomegaly? Isn't it? This patient has undergone cholecystectomy.
Yes, sir. 18 years.
Isn't it?
Yes, sir.
So it's possible that there could be biliary stricture or a retained CBD stone, maybe
Yes,
there, which is giving rise to cholangitis. That possibility is there. It has to be considered, isn't it?
Yes, sir.
Then, of course, the other thing which you have to also think of is whether there is any possibility of any granulomatous lesion in the liver
Yes, sir.
or in the spleen.
Yes,
The spleen also. Because sometimes you can have splenic tuberculosis also.
Yes.
Possible. You have to think about that.
So it can be tuberculosis, sarcoidosis, like disorders like.
Sarcoidosis is this is not the mode of presentation. Sarcoidosis. Tuberculosis can, the tuberculosis in the spleen can happen.
Yes, sir. A tropical splenomegaly, it can be there, sir.
Tropical splenomegaly is not to be considered because the size of the spleen is small.
Let's see.
In fact, आजकल diagnosis तो कम गया but the main definition was the person has a very significantly large spleen with anemia, Dr. Pal Wilson. Fact is that, এখানে তো see, if you have been having fever for almost any cause for 1.5 months, to get a 3 centimeter splenomegaly is not unusual at all. When I'm just to confuse the picture, suppose I believe that it's some kind of a bacterial infection going on, almost any infection for about a year, about a month, can give rise to splenomegaly. Typhoid is a typical prototype case, you know. So what I'm trying to say is that don't jump to be very liver specific in your diagnosis. Be a little broad-based, because otherwise you'll miss a larger chunk of what the humanity suffers from. So that's what I'm trying to say. Okay?
Okay, sir.
What you're saying may be right when the investigations come, but let's wait till then.
We had gone for the CBC first. As we can see, the hemoglobin levels on the day of admission was 24th was 9.1, which progressively decreased from 8.5, 7.2, 5.1, and came down to 5.3. The TLC levels were on the normal range for the first 10 days, of approximately 4,000, 5,000, 7,500, and it spiked on the last 2 days, 10,000 and 14,900. The platelet count also showed thrombocytopenia, 60,000, 30,000, 25,000, which spiked on 4th of May, 1 lakh, and 6th of May, 1 lakh. So these were the trend of mainly the CBC and platelets, where we can see that the hemoglobin has persistently gone down. There is a spike in platelet count because we had given fresh frozen plasma and whole blood to the patient. That's why there is a spike. Otherwise, there was a continuous down trending of platelet count. Now we come to the LFT. As we can see that progressively both the AST and the ALT levels were more than 2 to 3 times the upper limit of normal, and which kept on increasing. On 24th April it was 123 and ALT was 165, which progressively increased to 245, 324, and on the last few days it reached around 400, 389, 365 and 480, 499. The ALP levels were approximately normal for most of the examination except on the last 2 days. The total serum bilirubin unconjugated and conjugated both were raised from the first day itself. On the first day it was 12.69, unconjugated was 7.88 and direct was 4.81. Both hepatocellular and cholestatic patterns were found. It kept on increasing to about 17.8 unconjugated bilirubin. Total bilirubin went up to 27 and direct bilirubin went up to 9.27. The protein remained approximately on the normal side, but albumin, there was hypoalbuminemia present throughout the course of illness. As I said, the transaminitis was present. When we did the coagulation profile, the PT and INR we repeated every 2 to 3 days. On the day of admission, it was 18.3 PT, 18.3 seconds, and INR was 1.61. It progressively increased to 19.7, 21, and on the last day was 31. INR also increased from 1.6 to 1.7 to 1.8, 2.3. There was persistent hyponatremia during the first week of the hospital stay, 121, 128, 129. Then after correction, it came up to 143, 144, and then went up to 163. The potassium was normal for the almost whole course of hospital stay. The urea create was also initially on the higher side, 78, 2.12, 29 April shows 95, 2.81, and it came down to normal, and then the patient finally developed raised urea levels and creatinine levels, and it went up to 215 and 2.56 creatinine. The CRP was high for the whole of the hospital stay. The blue line shows the total serum bilirubin, the orange line shows the unconjugated, and INR was also raised in these patients. So when we did the liver specific investigations, HbSAg was negative, IgM anti-HbSAg was negative, HBV DNA was 1904 international units, hepatitis B surface antigen was 203, HBeAg was negative, IgM anti-HBeAg was also negative, anti-HCV was negative, and other hepatotropic viruses, HIV, HEV, and hepatitis D was also done, that was also negative.
The only thing is that in a case discussion like this, you should not project the entire thing, whatever the entire course has happened. and the time of admission, after your examination, what were the findings. Then you have to arrive at and tell the course, because you'll be biased otherwise. So at the time of admission itself, his albumin was, how much was the albumin when he came?
Sir, 2.9.
What was his platelet count?
Sir, 60,000.
So what is your analysis of it with respect to any acute illness or anything chronic which has been going on? That should be the first one.
Yes, sir.
Right, some unusual find. There are two things,
Yes, sir.
That means albumin is low already.
Hypoalbuminemia.
So
Yes,
was
sir.
he having an edema, ascites on examination?
No, sir.
So then you have to think either a nutritional problem or an underlying liver problem.
Yes, sir.
And platelets also same thing. Is it related to the acute events which can cause thrombocytopenia if they are excluded? Then you have to think of the chronic one. So should not completely tell the entire thing in a case discussion like this.
Yeah, also now what happens is that, see, after all, a patient comes to you in the hospital with a problem. You're not going to wait for 2 weeks to only study what has happened to him. You have got to intervene. Na? So the question that come to mind, see, this was 24th of April.
Yes, sir.
And then it became 7th of May.
May 7th.
So in between, apart from the tests which you sent, what else did you do? For example, did you do a blood culture? Did you do a Vidal? Did you do any other radiology? Number 3, did you give him a course of an antibiotics because his fever was persisting? If so, which one? So those are the things, because see, ultimately we have to help the patient.
Yes, sir.
So those details would have been very useful.
Sir, we have it in the subsequent slides.
Can you just show the day-1
Yes.
at admission liver function tests and overall
Day-1.
tests?
Yes, sir, this is the day-1 function of CBC. And we go to the LFT. This is the...
Other things that you did.
So can you just interpret this once? Because your residents will be asked to interpret this, say, first day or second day liver function test.
Sir, there is transaminitis because AST and ALT both are above 2 to 3 times the upper limit of normal. ALP is on the normal level, sir, 50 to 280. Serum bilirubin unconjugated direct all are raised. That means most likely a hepatocellular with a cholestatic pattern, mixed pattern type of jaundice is going on, sir.
So
and
I'll stop you there. So you are saying this is your lab value of alkaline phosphatase, upper limit is 260, which is very
Yes.
important. This is normal.
Yes, sir.
So this is a predominantly hepatocellular jaundice, but this is conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia?
Conjugated, sir.
So what is the definition of conjugated hyperbilirubinemia?
Sir, if the conjugated bilirubin is more than 15% of the total percentage of bilirubin, that is conjugated hyperbilirubinemia.
It's more than 15%.
15%.
So you've got somebody who's got a hepatocellular picture
Yes, sir.
with conjugated. So
Yes,
that then you proceed with this. So every LFT you should have a objective assessment of its interpretation.
Yes, sir.
Is there any evidence of ongoing chronic hemolysis in your patient?
No, sir. There was LDH levels were normal. ALP levels only peaked at the last level, sir. Retic count was also normal. There was no
But
evidence.
your platelet count is low,
Yes, sir.
hemoglobin is low, total count is low, no?
Total count is normal, sir. Platelet is
Bicytopenia is there,
Bicytopenia is there, sir.
isn't it? So
Splenum,
how you link that with your differential diagnosis?
Sir, thrombocytopenia might be linked to splenomegaly, which was there, which was ongoing, and anemia.
No, but the cause of splenomegaly must be there, no? Something you have, some clinical disease must be there, which is responsible for the splenomegaly.
Most like
Myelodysplastic syndrome can be there.
Huh?
Myelodysplastic syndrome can be there.
Viral?
Myelodysplastic syndrome, MDS, can be there.
So how many of myelodysplastic syndrome present with jaundice?
But no, unlikely.
So don't put differentials which have got no consequence.
So hepatitis B leading to chronic liver disease, which is causing portal hypertension, which is causing splenomegaly, can be linked to thrombocytopenia. And anemia, it's an anemia of chronic disease, it can be, sir. If the patient is having chronic liver disease already, the
Yes.
interleukin 6 and cytokines.
Can this be explainable on the basis of reactivation of chronic
Yes.
hepatitis B?
Yes, sir. Yes, sir.
Leading to the continued transaminitis,
Yes, sir,
and
it can.
also can that be explained on the possibility of reactivation of chronic hepatitis B?
Yes, sir. Reactivation can be there.
Can be there, sir.
See, as you said, first analyze the symptoms, whatever you have it. Alkaline phosphatase is absolutely normal, isn't it?
Yes, sir.
Then in which case, all the causes of a biliary stricture, anything related to the past that retained stones can happen. We have seen many times, asymptomatic stones presenting for the first time with an obstructive jaundice. Right? Even without an ultrasound happening here, you can safely say that this is not a cholestatic disease, so your all gallbladder or any obstructive elements are out, even though you have not done the ultrasound so far. Then comes to the AST, ALT, is a conjugated. Yes. So there is no hemolysis, right? Although anemia is there, yes, but doesn't appear to be hemolysis. That is the second thing. Third thing is AST, ALT ratios here. Here AST is less than the ALT. So your alcoholic hepatitis is out. Right? Yes, so sir. This is how you have to progress, right? Each analyze the symptoms, recognize the importance. I'll ask you, in which cases are ASTs more than the ALT?
Anyway, two informations we would be looking at. One is the ultrasound and upper GI for varices.
Yes, sir. USG whole abdomen which was done showed that liver, there is evidence of diffusely increase in echogenicity of both lobes of liver with poor visualization of periportal outline. The size was normal, 13.9 centimeter, shape was normal. Intrahepatic biliary radicals were also normal. Spleen, the size, shape, echogenicity was increased, and there was splenomegaly measuring 15.14 centimeters in diameter.
Endoscopy was not done.
Increased echogenicity does not necessarily indicate that it's liver cirrhosis. I mean, we don't hear about the portal vein size here. And was there any mention of ascites there?
No, this much of USG reports are available in the report.
No, I agree with you. So what I'm saying is that, you are trying to fit it into acute and chronic liver failure. So that part we are not quite getting on the investigations. That's the issue that I'm saying.
Taking alcohol, it could just be the fatty liver.
Yes, sir.
The most important thing is your intrahepatic biliary radicals are
normal, sir.
So that rules out
obstructive causes.
Surgical obstruction.
Surgical obstruction, yes, sir.
Isn't it?
Yes, sir.
See, with this is your index ultrasound, or there was ultrasounds after this?
No, sir.
Did he ever develop clinical ascites or radiological ascites?
Only the hepatic encephalopathy that
So only hepatic encephalopathy, but we are not sure whether it is hepatic encephalopathy or there is uremia, your creatinine had gone up, he's having some sepsis, it can be a septic encephalopathy, there can be all of those things. We don't know whether it's hepatic or not. What the point I'm making is, 1.5 months of history, progressive disease, severe SIRS, blood pressures dropping down, tachycardic, no ascites with jaundice, makes the possibility of an underlying severe chronic liver disease quite unlikely. Usually whenever you see such patients, they would tend to by this time develop some degree of ascites. He has not developed ascites. Encephalopathy, we are not sure. There used to be some entities called SHF, which was late onset acute liver failure. But usually in clinical practice, somebody with so much of things going on by now, if he had cirrhosis or severe chronic liver disease, should have developed ascites. So I'd be very skeptical with an ACLF diagnosis right now.
Sir, it can be an acute flare of hepatitis B or reactivation of hepatitis B. Although the patient is on medication, but
so
maybe the
both flare and reactivation have definitions, which has got a virological definition and a definitions of enzymes. Yes, so does it meet those criteria?
Flare, sir, in case of flare, there is ALT is raised, so there can be.
What are the limits that you need to cross?
5 times, more than 200.
Was this crossing? Yes, it is crossing. But your DNAs are only 1800s. So you do need a virological cutoff of log increments?
Yes, sir. One log increment means 10 times.
At least somebody is on treatment in a background, at least 1 to 2 log increments of biological.
Yes, sir.
So we can put it, but it's very odd that somebody has been on hepatitis B treatment, somebody develops a flare or a reactivation.
Can I flip the question the other way?
Yes, sir.
If a person has been unwell for 1.5 months with high fever, catabolic state, is there a possibility that he can develop encephalopathy? And if that is so, my question is, what are the causes of encephalopathy beyond hepatic encephalopathy?
So low muscle mass sometimes can cause encephalopathy because this ammonia is also utilized by the muscle.
No, you're going on the ammonia story. No, that is not the issue. The question is, do you know, if I asked you in MD medicine, if Dr. Pal was an examiner, tell 5 causes of encephalopathy. Encephalopathy means...
So it can be febrile encephalopathy, it can be uremic encephalopathy.
Very good.
Hepatic encephalopathy, in this case it can be, sir. LFT, sir. LFT, this one, sir. Hypernatremic encephalopathy, sir, at the last, it can be due to dyselectrolytemia, hypernatremia. And
the bedside teaching has to be that here you have been able to identify encephalopathy. Encephalopathy means the brain, there is a diffuse dysfunction. If you want it more specific, you have to put probes, you will get those slow waves coming all the time, diffuse, both sides. Now the encephalopathy doesn't make it only hepatic encephalopathy if a person is jaundiced but having fever for 1.5 months. So that's what a good astute clinician should do, that you should be able to think, could it be due to any other cause? And how did we try to correct them while he was in your hospital for 2 weeks? That was the issue.
so because the patient has ultimately developed SIRS, it can be hypoxic encephalopathy also. The patient is not coming.
See, don't put in terms, see, hypoxic. HIE is a very specific diagnosis, happens when you've got a documented event of hypoxia. You don't have such events.
No, sir.
This is a sitting, walking, talking patient, right? Who
Yes,
is
sir.
going into a end stage event clash.
Yes, sir.
So,
Anyway, tell us what was the final outcome, time is up.
Case summary, Mr. Triplex, 45 years, male, presented fever, yellowish discoloration of whole body, diagnosed case of hepatitis B under medication, febrile, pallor, icteration, splenomegaly was found, and patient had transaminitis, hyperbilirubinemia, and direct coagulation profile during the course of stay, which ultimately resulted in HRS, AKI, and MODS. So we diagnosed the case as a case of acute and chronic liver failure secondary to acute flare of hepatitis B infection during ongoing treatment, complicated by HRS, AKI, and MODS.
He died?
Yes, sir. He ultimately succumbed.
I'll tell you, the outcome, whatever happens, that depends on God Almighty. But I'm a little concerned about the approach, because, I tell you, when we became gastroenterologists, we were accused by physicians that, we have tubular vision. And I actually think that as we grow older, we realize that this tubular vision is a dangerous thing. You must be able to look at it from a much larger perspective, because remember, at the end of the day, you are a MD medicine first and then a gastroenterologist if you become one. And here I thought there were a lot of loose ends which didn't fit into what is your view, Akash?
yes, there are a lot of loose ends. Your workup is broadly incomplete. I didn't see a bone marrow. I didn't see a liver biopsy. There are hardly these things. And even the initial workup, none of those parameters were there. And the diagnosis, you cannot come to this diagnosis of acute and chronic liver failure at all. Because again, you said the encephalopathy was terminal.
Yes, sir.
He's been for 1.5 months. And you only said the definition is jaundice, coagulopathy, ascites and or encephalopathy within a period of 1 month. He has no ascites, encephalopathy is terminal, possibly due to some other cause. This is not ACLF. This is not HRS AKI. Patient never had even ascites. HRS AKI is a completely different story. So this is a cause of jaundice which ultimately remained unsettled. There are a lot of investigations that Sir said the workup is incomplete.
I think the ongoing jaundice and the continuous deterioration in the liver function, patient not responding, a liver biopsy would have been more informative, would have been able to clinch the diagnosis, liver biopsy. And even if you would have not done the liver biopsy, while he was here, even a post-mortem liver biopsy could help us to see where we have gone wrong.
Endoscopy
For varices.
Yes, sir.
Esophageal varices थे नहीं थे?
No, sir. It was not done.
It was not done. कोई बात नहीं. I mean, don't take it otherwise. You're just in the learning process. Okay. One life has gone. Never mind. The issue, I'll tell you. The end of the day, you should go back and look at every patient. Step back and look at it from a non-gastroenterology point of view first. Broad-based. I think that's what Dr. Pal's agenda for the API should also be. I think more lives are saved by broadening your vision. And may I ask Dr. Sudhanshu here, he is falling asleep. Sudhanshu, ek tumse baat ye hai ki there was a time when we were very avid readers. Most of the trials and studies came from Nepal for typhoid studies. How is typhoid going around in Nepal, and do you see typhoid with jaundice, typhoid with encephalopathy? Do you see typhoid deaths? How is typhoid doing in Nepal right now?
Yeah, actually in this case also, if I had to put differential diagnosis, I would have put enteric fever with enteric hepatitis in the first. Because we usually get these type of cases in which the old means their prior disease was hepatitis B, but they are complicated by enteric fever, which is very common. We still have this disease and we still get this type of disease. So if I go back in this case, I would have put enteric fever with enteric hepatitis as my first differential.
Absolutely. So this is a very educative thing. And let me tell you, you can have normal WBC counts. Counts can be on the lower side because typhoid doesn't have high counts, okay? Unless you do a blood culture or if you do a Vidal after 2 weeks. But Vidal is not very reliable. It's impossible to diagnose it.
So screening for the scrub typhus, malaria, typhoid. Also from our microbiology department, we did HSV and CMV virus. IgM antibody, ELISA, was negative, absolutely negative for the patients.
So I'll tell you, it all depends on the timing.
It's just during the first day we did the fever profile for the malaria, typhoid, dengue is very prevalent here, so dengue and Widal test was done, and after subsequently we did CMV, HSV, non-hepatotropic virus test was done, but it came normal.
I agree, but dengue I don't normally see jaundice much.
No, sir. Actually, as a fever panel sometimes, because sometimes if there
is referral from here to there, CRP was 70. He found that I'm not getting any relief, so he took a flight and came all the way. He could afford it. On the very first day in the emergency, luckily the resident took a blood culture. After that, all tests were done, including Vidal and typhus, the blood test, the IgM and all that. All came negative, but we empirically just high-grade fever. And the first blood culture report taken at the emergency, 4 days later, it came out to be paratyphoid A. And we gave the antibiotics according to the the sensitivity. The fellow got well, he thinks no end of ourselves and he's cursing Melbourne. So I'm trying to tell you common things first. So remember that, very, very, very important. Okay?
See, if you would have done a Widal test in the beginning and you would have followed up, a rising titer of the Widal test always raises a very strong suspicion of enteric fever.
Close up, but homework for you, read up today what are the liver involvements in enteric fever. There are at least 5, it used to be in our time. If you don't remember, ask Dr. Sudhanshu, he is the expert. And you must know that any person with fever in jaundice need not necessarily be hepatitis. See, hepatitis B surface antigen positive can at times be a red herring. So always be careful about that. It's still possible, but watch out for that. Any other comments from anybody? Dr. Pal? Any comments? Chalo, all the best. Thank you so much. I hope you enjoyed it.
Thank you, everyone.
While the next person comes, just advise. Another thing is, whenever there is a fever is prolonging, jaundice is increasing, think of HLH also, because we burnt our fingers. First two, we lost the cases, then we become, just do the ferritin, triglycerides, and then fever, jaundice, prolonging. Initial event may be different, but prolongation may be because of the HLH. And that's where the bone marrow also comes a picture. And when you treat them with the steroids, sometimes very, very miraculous improvement will occur. Just simple examination should be done. Triglycerides, ferritin, fibrinogen.
Thank you.
All the best.
অডিয়েন্স বোর হচ্ছে না তো?
Thank you, speakers.
অডিয়েন্সে তোমরা বোর হচ্ছে না তো? তোমরা সব চুপ হয়ে বসে আছো, তোমরাও কোশ্চেন জিজ্ঞেস করতে পারো, ক্লারিফিকেশন চাইতে পারো, কোনো অসুবিধা নেই। হ্যাঁ চলো।
Thank you, speakers. Thank you, sir. We will call upon our next case presenters, Dr. Neel Padmini Debbarma and Dr. Moushumi Das.
Oh, thank you.
যতক্ষণ না হচ্ছে, লেট মি এন্টারটেন ইউ উইথ ইন্টারেস্টিং স্টোরিজ। হ্যাঁ, একটা কথা আছে কি, রেয়ার ডায়াগনোসিস in a place where it does not normally occur, you should never make that diagnosis. ঠিক আছে? তো আমি যখন পিজিআইয়ে ছিলাম, I remember there was one of the best worked up cases of primary hepatic sarcoid. It's very rare. Sarcoid, you know, না এখানে তোমার retrosternal mediastinum হবে, but it was primary hepatic sarcoid with jaundice, biopsy টাইপসি করে, but you know there is no biomarker for sarcoid. তখন ওই ভিম টেস্ট বলে একটা হতো, এটা চণ্ডীগড়ে হতো. So they rejected our paper because they said it's a very uncommon disease in India and that too an uncommon manifestation. ঠিক আছে? তো আমি তোমাদের যেটা বলতে চেষ্টা করি যে ডাক্তারিতে we are always made to think of rare possibilities. You should know the possibilities. But on the bedside, don't overlook the common possibilities, because more often it is an uncommon manifestation of a common disease rather than a common manifestation of an uncommon disease. এইটা তোমাদের ডিকটাম অ্যাজ এ ফিজিশিয়ান মনে রাখা খুব দরকার। ওকে? তোমরা এমনি বলতে চাও? You've got your slides on? তা নাহলে এমনিও বলতে পারো if you are comfortable. In fact, in an exam, you usually have to just present your case. So you can start off, we can have our discussion. ঠিক আছে, এসে গেছে।
A very good afternoon, respected dignitaries, all present delegates, and my seniors and juniors. My name is Dr. Nilpadini Debarma. I am from TMC Hapania, and I'm third year PGT in medicine department. And I have my friend Dr. Mosomi Das. Today we are going to present a case presentation on jaundice. Our patient, Mr. XYZ, of 48 years old male, hailing from Bisalgarh, Sipaijala, Tripura, who is self-employed by occupation, was admitted in our hospital on 23rd of April 2024, and we have examined him on the same day of admission. He came with a chief complaint of yellowish discoloration of eyes and passing of yellowish urine for 10 days and distension of abdomen for last 5 days. And history of presenting illness. Our patient was apparently alright 10 days back. Then the patient himself and his family member started noticing yellowish discoloration of his eyes and passing of yellowish urine for last 10 days, which was acute in onset, associated with malaise and occasional nausea, feeling of feverishness. However, he doesn't complain of any chills and rigor. It does not associate with itching on the body, and it remains same throughout the day. And he did not complain of any change in his stool color, and there is no history of bleeding from gums, nose, and any ecchymosis. Patient also complained of he also noticed tightening of his clothes around his waist and abdomen, and there is also abdominal discomfort for last 5 days, which was gradually increases, and it is associated with occasional nausea, increases on taking fatty foods. However, it is not associated with pain in abdomen, vomiting, changing in his bowel habits, and there is no change in urine volume. History of past illness. He was diagnosed a case of fatty liver disease for last 1 year. For that, he was advised to discontinue alcohol intake, increase physical activity, and under diet control. There is no similar complaint in past. There is no history of hypertension, diabetes, dyslipidemia. There is no history of any blood transfusion. There is no history of any major surgery, and there is no history of any recent travel. Also, there is no history of any intake of any Ayurvedic or herbal medication, and there is no history of any intake of over-the-counter medication. Personal history: he is on mixed diet. He is a chronic smoker, which is 10 pack per year, and he is also chronic alcoholic for last more than 20 years. He consumes around 100 grams of alcohol on regular basis in the form of Indian-made foreign liquor. For the last few months, he also gave a history of binge drinking. He is married for last 20 years. There is no any high risk sexual behavior. There is no history of any IV drug use. There is no history of tattooing. His sleep is normal. His bowel and bladder is normal and regular. In family history, there is no history of any hereditary disease among the family member, no chronic liver disease among the other family member, and there is no history of jaundice, and there is no other significant systemic disease. So in my case summary, a 48 years old male, non-hypertensive, non-diabetic, chronic alcoholic with significant amount of alcohol consumption, presented with history suggestive of medical jaundice and ascites. So we put the differential diagnosis of alcoholic hepatitis, acute viral hepatitis. On general physical examination, our patient is conscious, cooperative, well oriented to time.
Just pause you for 1 minute, beta. You said he's got history. So what is the definition of binge drinking?
Oh, sorry, it is more than 4 drinks in case of female, and it is more than 5 drinks in case of men with over 2 hours.
Very good. And you said that acute viral hepatitis. So can you put this entire picture into an acute viral hepatitis, or you want to break it down further, or do you want to bring it something else? Do you want to bring in any other causes, or these are your only 2 possibilities?
Sir, from the history of point of view, as the person have acute onset of jaundice, and there is also fever, but it is not high grade, so I put only 2, and history of significant alcohol consumption.
What I want to ask is, how would you put your ascites based upon your differential of acute viral hepatitis?
Sir, viral hepatitis, there is no ascites.
But still it can be acute viral hepatitis?
It could be.
How?
Sir, jaundice and fever.
Let me help you. Simple acute viral hepatitis, ascites coming so quickly does not normally occur. That's the point, Akash, you're trying to make. So, my thesis was on subacute hepatic failure. That was the term we used long time back. Even that required 5 weeks. So, if it happens so quickly, and it is virus, you presume it's virus, then the definition or the diagnosis needs to change a little bit, and that is what Akash is hinting at, that instead of saying either this or that, can it be a combination? That is the point he's, I think, trying to make. What is that entity called? I think your predecessors made that diagnosis.
Exactly.
I'll explain things to you, just for you as well as for the audience. So, normally if it's a healthy liver and the person develops acute hepatitis, B, A, E, usually the liver does not decompensate with ascites before 5 weeks. 4 weeks er aage jodi hoy, it presents with encephalopathy, it's called acute liver failure. But ascites presentation usually takes more than 4 to 5 weeks. Suppose now you imagine that this liver is not a healthy liver on which the virus has come. So it was already a partly compromised liver which was just compensated. And tarupore it has got into a crisis with a hepatitis, say E virus or A virus. Then it can decompensate very fast. Within about a week or 10 days, you can have ascites. So that is called, you're muttering right, have the guts, just jor se bolo. Nobody will hit you here. So underlying,
acute on chronic.
Very good, very good. So if at all you have to bring that into account, how to explain? So it's called acute on chronic liver failure. And incidentally, for most patients who have liver cirrhosis, the commonest cause of acute on chronic liver failure or decompensation is a superimposed hepatitis. Which virus?
Hepatitis E.
Jor se.
Hepatitis E, sir.
E. Right. E or A as the things are moving. In the Western world it's A, but in our country it's E. So that's absolutely right. Go ahead, Akash.
On general physical examination, our patient is conscious, cooperative, well-oriented to time, place, and person. He is febrile, icterus was present, pedal edema is present, pallor, dehydration, colononuclear cyanosis, edema are absent. His BP was 92 beats per minute and regular rhythm, normal volume and character. It is synchronous bilateral, all other peripheral pulses are pale normally. And BP was 118 by 70 millimeter of mercury in supine position in his right brachial artery. And his body weight was 60 kg, height is 173 centimeter, and BMI is 20 kg. Mid-arm circumference and thigh circumference are normal. On head-to-toe examination, here is normal. There is no temporal hollowing. Pallor was absent. eye is icteric and parotid gland bilateral swelling was there. No neck vein distension and engorgement, no palpable lymph node, and there is no spiral nevi. Abdomen was distended, bulging of bilateral flanks, and there is no visible veins. Umbilical was everted, and there is no hernia. No proximal muscle wasting was there. Paromal erythema was absent. Deputins contracture also not there, and pedal edema was present bilaterally up to ankle. On systemic examination of GIT system or examination of oral cavity, it is within normal. Per abdomen examination, on inspection, it is uniformly distended. Flanks are full. All quadrant moves equally with respiration. Skin are normal, and there is no striae or any scratch mark. There is no engorged vein, no visible peristalsis or pulsation. The umbilicus is everted, and it looks displaced downwards, and there is no hernia. And there is the head rising test is normal. There is no all hernial orifices are normal. On palpations or on superficial palpation, the abdomen is not warm and not tender. There is no rigidity or guarding. Abdominal guard is 105 centimeter. The spino-umbilical distance is 20 centimeter bilateral. G4 and umbilical distance is 24 centimeter, and distance from umbilicus to pubic symphysis is 19 centimeters. There is no palpable lymph node around the periumbilical region. On depalpation, the liver is palpable, and it is tender, firm in consistency. It is 4 centimeter below the right costal margin in the mid-clavicular line, and there is no brow and no pulsation. Spleen is not palpable, and there is no other abdominal mass palpable. On percussion, percussion of liver, the upper border is palpated. Percussion, the upper liver dullness is in the right fifth intercostal along the mid-clavicular line on full expiration. The percussion of spleen by the Castelli method, it is dull node in the 9 intercostalis space on the left anterior axial line, and the trough space was dull on percussion. There is shifting dullness is present. Fluid trail is not appreciated. Auscultation, the bowel sound is normal and present, and there is no bruit or hum. There is systemic examination like CNS examination. Patient is awake, well oriented to time, place, and person. There is no focal neurologic deficit present. There is no flipping tremors, no other abnormal movement. Cardiovascular system, S1, S2 is heart. There is no murmur. There is no other additional sound. Respiratory sound system also normal vesicular sound, heart, equal bilateral air entry. There is no other added sound. So we put the probable diagnosis, a case of alcoholic hepatitis.
Can you just tell us why you made the diagnosis of alcoholic hepatitis?
So from general history point of view and general physical examination, from history, the person gave a history of fever, yellowish discoloration, which is sudden in acute in onset, and also fever is low grade, and again there is distension of abdomen, which is suggestive of hepatic decompensation.
See, why you didn't think that this patient could be having a pre-existent silent chronic liver disease, and because of a superadded acute liver injury,
yes,
in the form of a acute alcoholic hepatitis,
yes,
or in the form of a viral hepatitis, that has led to decompensation.
Sir, there is no
because
sign
your
of
patient has also spleen is your trough space is dull, isn't it?
Sir, yes, on percussion.
And the liver is also palpable.
Yes, sir.
Right. normally it is difficult to make a diagnosis of cirrhosis in presence of enlarged liver or palpable liver unless the patient is alcoholic, right? So I would have thought that more possible that the patient has a pre-existing liver disease and an episode of jaundice, which could be due to acute alcoholic liver injury or could be because of acute viral hepatitis, which has led to the decompensation.
Yeah.
That is one thing. Second thing is the possibility of any acute or chronic liver failure. That could be another differential diagnosis in this patient.
See, what is hinting at you, know the absolute definition of alcoholic hepatitis, right? That's what he means actually. And it can be, we don't call it as an acute alcoholic hepatitis. Actually, we call it a severe alcoholic hepatitis because never acute, although the presentation can be acute, right? You know, there's no entity called acute alcoholic hepatitis. It's called a severe alcoholic, ascites, severe hepatitis. A is that this is only severe alcoholic hepatitis. B, cirrhosis with some kind of an infection already pre-existing. That's what ACLF we are coming to, right? And third thing is that is same thing, underlying condition with alcohol exposure and therefore is presented with the ACLF. So since the presentation itself is ascites, what Dr. is saying is that you should not diagnose at significant ascites clinically. Mild ascites can be there in ultrasound in any severe alcoholic hepatitis. Severe clinically palpable ascites will not be there. So you should not diagnose as alcoholic hepatitis at that stage. That's what it means, right?
And always when you've got such presentation, there are two ancillary things you should always remember. One, if he's had a chronic alcohol intake, so you're assuming that he has chronic liver disease, is the development of HCC, okay? And second is the development of portal vein thrombosis, which with or without the alcohol intake can itself manifest as a jaundice along with worsening of ascites. So these two should also be there in your mind.
Sir, rest will be presented by Dr. Mosumi.
Now, laboratory investigation of this patient.
Before laboratory, just my hint again, what I said in the last case, you know, keep your diagnosis broad. Okay, so acute alcoholic hepatitis is a narrow diagnosis. So if I ask you, if this person had to have a liver biopsy, either ante-mortem or post-mortem, do you think there would be fibrosis in the liver or not? Just think, it's been going on for a long time.
Maybe, sir, fibrosis may be present.
Maybe or will be?
Will be present. Sir.
Will be present, very good. So that's why now what people have started doing now is that they use a broad term. It is called alcoholic liver disease, in which you qualify that recent decompensation could be either due to alcohol or something else, okay? So I think go with a broad base rather than make a very narrow specific diagnosis. That's the point, okay?
His initial blood count shows hemoglobin 11.8 gram per dl. His total count is 13,800. In differential leukocyte count, neutrophil is 80%, was 80%, lymphocyte 12%, monocyte 7%, and eosinophil 1%. His mean corpuscular volume shows 104 FL. Platelet count 1,15,000, and his peripheral blood smear shows macrocytic normochromic picture along with leukocytosis with neutrophilia. His PT is 22nd and INR 1.8 international unit. His liver function test shows total bilirubin 14 mg%, direct bilirubin 7.5 mg%, indirect 6.5 mg%. His SGOT 180 and SGPT 102, and total protein 6.3 gram%. Albumin is 3 gram%, globulin 3.7 gram%, LP 110, GGT 500 international unit per liter, serum urea 27, and serum creatine is normal. Serum sodium was 130 millimole per liter, and serum potassium 3.9, and serum magnesium was 1.2 millimole per liter. His serum vitamin B12 is quite reduced, that is 112 picogram per ml. His viral markers, that is HBsAg, anti-HCV, HIV, anti-HAV IgM, and anti-HEV IgM shows negative. His blood culture and urine culture, there is no growth, and urinary there is no abnormality present. His ascitic fluid analysis shows total protein 1.8 gram per dl, albumin 0.9 gram per dl, sag ratio is high sag, that is 1.2, and cell count is 40 cells per cubic mm, which was lymphocytic predominant, that is 70% of lymphocyte, and neutrophil 20%, and AD of ascitic fluid shows normal. Upper GI endoscopy, there is portal hypertensive gastropathy was present. In radiological investigation, X-ray chest, there is no abnormality, and this ultrasonography suggests hepatomegaly with increased echogenicity and mild surface nodularity and early fibrotic changes with dilated portal vein along with moderate ascites and mild splenomegaly. Now, in this case, the scoring system of alcoholic hepatitis, the matrix discriminant function shows 41.6 points, MELD score 23 points, and Glasgow alcoholic hepatitis score shows 7 points, and the Child-Pugh score shows 11 points, that is class C CTP score. Now, my final diagnosis is a case of severe alcoholic hepatitis. Now the management part. We manage this case first of all counseling the patient to abstaining from alcohol, then the nutrition therapy. The optimal nutrition goal is 1.2 to 1.5 gram of protein per kg and 35 to 40 kilocalorie per kg of body weight. We as per in form of milk, vegetables or egg white. In this case, we advise this patient 70 gram of protein and 2,100 kilocalorie diet every day. And micronutrient supplementation like injectable thiamine initially was given, followed by we continued orally. Then oral folic acid tablets was given. Then vitamin B12 injection initially given, followed by we continued orally. And oral zinc supplementation 50 milligram per day was prescribed. And oral magnesium 250 milligram per day was prescribed. Syrup lactulose was given in the 15 ml twice daily in this case, and oral pre-probiotic we given. Then definitive therapy, steroid therapy is we initiated in this case, because in this case the MELD score shows 23 points and MDF is 41.2, such as severe alcoholic hepatitis. Then we started oral prednisolone 40 milligram per day, and we did 7 day, on the 7th day after initiation of steroid, we did the liver function test, which shows reduction of total bilirubin from 14 to 10, and the reduction of liver enzymes. As per Lilly, on the 7th day, the Lilly score shows 0.106, that is less than 0.45. So hence we continued the steroid for another 28 days, followed by tapering dose over next 2 to 3 days. After finishing of the steroid therapy, we asked the patient to come to our hospital for follow-up, and we found the patient is clinically improved. His jaundice and ascites was subsided. Thank you. Yes, sir. Yes, sir. Yes, sir. Yes, sir. But
taking the clinical picture, portal hypertensive gastropathy and the jaundice together, what should be the diagnosis?
Portal hypertensive gastropathy along with jaundice, he's having preceding chronic decompensated chronic liver disease along with presented with severe alcoholic hepatitis. Maybe he's having underlying decompensated chronic liver disease, because he's having history of 20 years of alcohol intake, which may causes his liver decompensation. And because of there is also history of having a binge drinking for few weeks, and preceded infection, which may increased his counts, there may be acute insult which may cause severe alcoholic hepatitis.
Yes, it's reasonable. You can develop portal hypertensive gastropathy in the absence of cirrhosis also.
Yes, sir.
In ACLF, there is an acute portal hypertension with its cause. Just another point, you had tapered off the steroid dose from in the 4 weeks. So in the original trial protocol, there is no tapering. But I agree with you, this is the way clinics should be, that in real world, would be tapering it gradually. But if you see the original studies, they were continued on 28 days in the same dose and then abruptly stood.
Yes.
Very well managed.
Any questions, Dr. Pal?
Thank you, sir. Yes.
Why?
Because of ascites, the weight maybe
Right,
increased.
so it's fallacious because the ascites is contributing to the weight. But since Dr. Pal started this line of questioning, as an examiner, I'll ask you, never put out information on which a bad-tempered examiner can catch you. For instance, you mentioned the thigh diameter. What is that meant to be? Because the next question, if Dr. Rao is in a bad mood, he will ask you what is the normal thigh diameter in a person of his age with that background, and then what would be your answer?
No, I was surprised at the Thai conference because
48 years, sir.
No, because Thai circumference does not figure in the nutritional assessment of the alcoholic cirrhosis. MAC is okay. And for metabolic syndrome, you have got a thigh and then the hip and then abdomen and hip circumference, right? Thigh circumference comes in by orthopedicians. It is used to see quadriceps atrophy in comparison to the contralateral one in knee injuries. I have not heard thigh conference. I do not know. Somebody should correct.
So I'll tell you the issue. Issue is if you give a numerical number, then there is a possibility of an examiner asking, okay, what is the normal range? And there are so many variations, you can never know the normal range. So on the bedside, if you're talking about long-term protein deficiency and so on and so forth, I still think that it's good to say that there is muscle wasting, thinner and hypothinner eminences and so on and so forth. So stick to the bedside part rather than the numerical part, because there it can be a bit of a trap. Okay. Second point, you said you gave B12 injections.
Yes, sir.
Was the B12 low?
Yes, sir.
It was?
Yes, sir.
It was? In this case? Oh, that's good. I'll tell you why. Because in Germany, the high B12 levels are usually associated with alcohol intake. So usually B12 deficiency in alcoholic liver disease or hepatitis hardly ever occurs. But if it occurred here because of a background nutrition, perfectly understandable. So what you did was right.
Yes.
The third question is, how did you manage his withdrawal symptoms if he had any?
If during presentation, sir, it don't have any usual symptoms, but if he developed, then we clonazepam.
What did you look out for? You brought him into hospital, or some people brought him, you put him in the ward. So on the bedside, what would you have normally looked at that can happen for acute alcohol withdrawal in a person who has been a regular drinker?
Sir, the altered irrelevant behavior, then reduced sleep, then patient may have violent behaviors.
Very good.
That
what are the names for those? Korsakoff psychosis?
Psychosis, yes.
Okay.
Yes, sir.
And the question is, he can go into delirium tremens. Some people, because they're very, very timid physicians who wouldn't give them benzodiazepines, they often go into seizures. And, we have had patients who have died because of intractable seizures. So you have to be very careful tiding them over the first 48 hours or 72 hours just to be alert that this can happen.
Yes.
Okay? But in general, I thought they presented quite well. Great. Round of applause. Where are the previous two boys? you know, I still would say thumbs up to both of you because you took a more challenging case and where the answer was difficult and the outcome was not so. But it's good. It's when you make mistakes that you learn. I mean, you take on more challenging cases, then you learn better. Sorry, there was somebody who wanted to make a comment. Somebody put up his hand. Yeah.
Sir, actually, first of all, we corrected the nutrition value because nutrition is also important to if patient. However, in this case, we don't have any hypoalbuminemia. His albumin level is 3, but it is quite normal. So first, we give proper nutrition is very important. First, we titrate the nutrition. Then after giving steroid, the symptoms subsided day by day. Because of steroid and proper nutrition, the ascites was subsided, and it took around 1 month after finishing of the steroid. He came, and we got this. The ascites is also there is no ascites and no pedilydema and jaundice.
We thank all the presenters, and I request the prior two presenters, Dr. Monodip Mandal and Dr. Prithvijit Kole, to please also come on the stage. So we would like to have the opportunity to give Dr. Gauradas Chaudhary's book, Health Adda, to all of our presenters today. I request Dr. Gauradas to please grace our speakers with his authorship.
With this, we come to the end of our first session. Now we would like to start the second session, Word of Wisdom. In this session, the topic would be do's and don'ts in cirrhosis of liver. For this session, our moderator would be Dr. Ovik Chakraborty sir, Dr. P.K. Datta sir, Dr. Subrata Bhaumik sir, and the speaker for this session would be Dr. P.N. Rao.
Very good afternoon and very warm welcome to Agartala P.N. Rao sir. Professor Dr. P.N. Rao is a doyen in hepatology as far as this region of subcontinent is concerned. To get a chance to listen from him about one of the very crucial part of care in hepatology is a lifetime opportunity for many of us. Sir, Rao do not rather need any introduction or goodies from people of this place so overwhelmingly. What we need to know, learn more from sir about our clinical care parts, and the burning topic is do's and don'ts in care of cirrhosis. With these few words, I request Professor Rao sir to go with his deliberation. Thank you, sir.
Right, thank you very much. I'm very privileged and delighted to be here on this forum today. I've been coming almost regularly for most of the previous HFT sessions, and the wonderful work, the societal work which the HFT is doing is really amazing, this one. And for this, I would like to thank Dr. Pradeep Bhaumik and the entire team of HFT for making me stay here and then know about more and more about what is happening in this part of the country. Thank you very much. Well then, what I try to say is that, what is the role of the physician when the patient comes back to or on treatment for cirrhosis of liver with them? Our aim is, nowadays since the transplants are going up, being done in the most of the part of the country now, is to keep him in a fit condition as much as possible, as long as possible. Whether he receives the transplant or not is a different thing, and especially if they are prone for the transplant, because nowadays everybody is asking, the moment you come there now, unlike previously, patient has not shattered when you mention the word of a transplant nowadays, right? And nowadays they are accepting it, and also they are trying to see whether they can go for it, So in this situation, our job is, the physicians or whoever is taking care, the primary care physician or hepatologist or a gastroenterologist, is to see that they will not have, we don't commit any mistakes in the management. That's what I am trying to do here. And because once the cirrhosis is there, he dies of the complication of a cirrhosis because of the hepatocellular failure, right? And these are the things which we have to look in these people. And there are many pitfalls that may occur during the management, either from the primary disease or from the complications or from the comorbidities, diabetes, cardiac problems, right? Obesity. These are the comorbidities which are associated with this one. The first thing is that, we have been discussing today about the ascites, delaying paracentesis in patients with the ascites, right? Because SBP is associated with a very high mortality, 30-day mortality, and it is, if it is not treated, up to 20 to 30%. On the left-hand side, you see that refractory ascites and then non-refractory ascites, we should allow the patient to go into the refractory ascites at all. That's the first thing. But having gone into the refractory ascites, you can see that the lining there is that the survival probability drastically comes down once he goes into the refractory ascites. You refer to the what is meant by refractory ascites, I will not go into the details there. And once the ascites or refractory ascites develops, he is a candidate for sure to be candidate for the liver transplant. And then a repeated LVS in the absence of other management here, albumin and the intravenous at the rate of 8 grams per liter, per liter of water removed, you must give 8 grams of albumin intravenously. right? And must make an early diagnosis of SBP because, as you can see on the right-hand side panel, a new onset ascites, admission to the hospital, symptoms are some vague pain in the abdomen, colicky abdominal pain, fever, some loose motions, that's all. It comes as any kind of a gastroenteritis which you've been coming up. But in a patient of a cirrhosis, that is a very significant, and you must suspect an SBP here. And renal function, in an unexplained encephalopathy, these are the things. Contraindications, practically none. On the left-hand side, you see that uncooperative patient, abdominal skin infections, pregnancy, very severe clinical coagulopathy, right? And severe bowel distensions are the only contraindication which that we don't come across at all very frequently, right? And despite these recommendations, paracentesis is often delayed because sometimes, the clinicians, they consider that they do not consider SBP in the absence of a clinical symptoms, right? They may come with an unexplained encephalopathy, as I told you, or a deterioration, or a sepsis, a severe sepsis comes there, and then you find that he has an SBP when you tap the ascitic fluid. And also, concerns about the safety and the invasive procedure also delays the paracentesis in these patients. And we should never give non-steroidal anti-inflammatory drug to these people because of a high risk of developing sodium retention, hyponatremia, and precipitating an acute kidney injury, HRS, AKI, whatever you want to call at this point of a time. We have a study, 2014, there was a study which shows that what they said that, doing before 12 hours and then after 12 hours, they said that the longer hospital stay, significant high mortality in these people, and mortality increased by 3% per hour every day. That is the time which you have to say. And in another article followed, a very large article again, followed in 2015, again is that timely diagnosis of SPP is crucial, and each hour in delay is associated with a twofold increase in the in-hospital mortality, right? So message is that do not miss SPP, right? And safety of paracentesis in patients with cirrhosis has proven large proven data that it is a very safe one. And only thing is, it's better it is done in ultrasound guidance because whatever the hemoperitoneum has occurred mostly is in patients where it was done without ultrasound and then there was an inferior epigastric vessel is there behind and then that results in this one. So preferably it is to be done with this one. Or some kind of a lighting and then see whether you can see in the absence of an ultrasound is done. And there is no really, unless it's a clinical coagulopathy or technically people say that less than 50,000 platelets, you should be cautious about that one, right? So ascites are present on admission, perform diagnostic paracentesis, don't delay for just an elevated INR or a thrombocytopenia unless it's very severe, like less than 20, and start intravenous antibiotics. Give albumin. It's been shown that the recovery is faster in these, mortality is low, 30 days mortality, 90 days mortality, low in these patients if you give an albumin, although it is an expensive one. And if the patient is not improving, do the aspiration again in 48 hours to show the lowering of the total count, in the ascitic fluid. That's otherwise we'll be missing some other conditions like a secondary peritonitis. And don't forget to prescribe the long-term antibiotic prophylaxis in these patients after the first episode of an SBP. We all start about the non-selective beta blockers in these patients. We know that it's got an effect and then some counter effects are also there. And when to stop is that there is what is called a window period is there. When advanced cirrhosis with a lot of ascites, child C, you try to withhold the non-steroidal non-selective beta blockers. But how to give is one of the things. People normally when you give these beta blockers, you are supposed to see every time, when the pulse, most of us we don't do. But nowadays with the COVID importance, I always tell them because they got a stick with them already, oxygen sat stick. And therefore I tell them that you see the pulse also and then let me know, and the blood pressures also should be known. And there is how to give the propranolol, how to increase. But only thing is, our patients do not tolerate very high doses of the propranolol, right? And then mostly, most of the time, I have not gone beyond 40 or 60. After that, they develop the hypotension. and some kind of a loss of libido in the people with in the males. And carvedilol is being given now, and again you have to see the dose. And most important is that you must have a follow-up with them. What is happening to the blood pressure? Sometimes they come after that, I am very weak, they say, and they ascribe it to salt restriction, right? It may be because of a relative hypotension in these people because of the drugs. So every time when they come, these two parameters has to be seen, whether you are giving adequate or you are giving the excess, or patient has been responding more for the same doses. Next is insufficient management of the nosocomial infections. And it's been seen in this large study, 18 cohorts, 2,000 patients are also, and mortality is higher in people who have gotten infections. And also we know that the infections cause mortality by 4-fold increases is there, 30% within 1 month and then 30% with the die by the end of 1 year. And not only that, not only single infection and multiple infections. You can see here the graph here on the left side, lower is one is where there is no infection, the probability of a survival is better, and the patient did not have a more than 1 to 3 episodes. And the right side top is the no infection, then middle is the 1 to 3 episodes, and the last one is a more than 3. That means that if the patient, who is the best patient who is going to the transplant, the best patient is who has never been admitted actually. He just walks in, results are excellent. And the patient who admitted repeatedly with the infections is the worst patient, because he carries bugs with them. With each admission, he carries the bugs, and therefore he would result in MDR infections. And therefore, treatment of the infections is absolutely important. What are the infections? Occult infection is only urinary infection, where they can be asymptomatic. Asymptomatic infection is an occult one, right? Especially in diabetics. That may be the onset, and it can result in SBP, right? Another is cutaneous infection. Cellulitis is very obvious for you. Respiratory infections are very obvious unless is very old and unable to cough, and therefore SBP should be the first one. Urine examination, and think of an SBP in a patient with the cirrhosis of liver, especially with ascites. What are the risk factors for infections reported? Bilirubin more than 3.2, platelets low, and protein level of a less than protein level, not albumin level, remind you, less than 1.5 again is a risk factor for the infections. And CPT, MELD, these are of course understandable. Use of PPIs again is associated with the infections, and then we know how we use and then abuse the APIs. We'll come to it a little bit later. And then previous long-term antibiotics again is a risk factor. Acute varicose hemorrhage, always you must prophylactically, you must give them intravenous antibiotic at the time just before doing an endoscopy. Right? And this is again another one which highlights the importance of starting the antibiotics in these patients, and see what happens if you give it less than 1 hour, what happens if you give it for the more than 3 hours. The cumulative incidence of mortality goes up with each hour, and therefore is of utmost importance. But before starting antibiotics, do the screen for this sepsis. Send the blood culture. Get the urine examination done. If possible, you can do procalcitonin where it is available. And then get an X-ray test done. Rule out the respiratory infections. Because to know the antibiotic, which antibiotic you have to go depends upon these factors. He can be relatively asymptomatic when he comes with only mild cough. So these things have to be ruled out. Infection screening has to be done before giving an antibiotic. So suspected varicose hemorrhage, do the endoscopy and give the antibiotic, and later of course you follow on with the subsequent program of what to do with these patients, starting the steroid NSBBs and also the protocol for EVLs. And this is an epidemiological work done all over the world, and then unfortunately India stands, particularly in India. MDR bacteria infections were high in Asia because use of the antibiotics 3 months before hospitalization. These are the risk factors. Prior healthcare exposure, that means previous admission, that's what I tell. More number of admissions of the patient is not a good candidate for this one. So we have to keep in mind that infections are treated as an outpatient itself, this one curtailed as an outpatient itself, you can treat even SBP as an outpatient. It's not necessary that SBP has to be admitted, right? If you see that, the patient, he's got to develop a fever, if you're suspect, if he's got ascites, in the absence of other features of infection elsewhere, you can tap it and then see and then start the oral, antibiotics in these patients also. Neglecting the role of hyponatremia, right? Our first patient had a hyponatremia, and that is one of the single factor, is a prediction of the outcomes are bad, is isolated factor has been noticed. Is an indicator of a portal hypertension in these patients. It is well known to be associated. We know that MELD NA. Why did we add NA later? Because of the importance of the MELD and then MELD NA. I would like the residents to go through what is the importance of a MELD sodium. And severe acute hyponatremia, no problem. He comes with the symptoms. Encephalopathy will be there, right? And it may be because of a hyponatremia-induced encephalopathy rather than the hepatic encephalopathy in that sense. And therefore, the hyponatremia should not be neglected. Chronic hyponatremia is mostly asymptomatic at the first sight, and hepatic encephalopathy can be worsened or might even triggered by the hyponatremia. So it itself can cause an encephalopathy, or it can trigger an encephalopathy. Usually triggering of an encephalopathy happens in advanced disease, whereas in child B, child A, it itself can cause encephalopathy in these patients. Should not be mistaken for hepatic encephalopathy at this juncture. It should be properly identified and then treated like any metabolic encephalopathy, right? You can see here SBP, encephalopathy and HRS. The cause or effect, this one, they are associated with the hyponatremia. So hyponatremia can trigger in the SBP, can be associated with the hepatic encephalopathy, and can also be associated with the HRS, And again, one important is that if the patient is in hyponatremia and it is dilutional hyponatremia, usually it happens. Usually depletion does not occur. You got a clear history that vomiting, diarrhea, or this one will be there. SIDH is a little bit unusual. So what usually comes with it, they come with a dilutional hyponatremia in these patients. And mostly they restrict the fluid restriction is only necessary in this hyponatremia associated. Otherwise, most of the clinicians, they restrict the fluids also. They tell them that take only 1 liter, don't take more than 1 liter. Unless there is a cardiac indication to reduce the fluid intake, unless there is ascites with hyponatremia is there is no need to restrict the fluid restriction. Salt restriction is more important than the fluid restriction itself. Fluid restriction, only 2 conditions. Cardiac, fluid overload, underlying cardiac condition, and ascites with the hyponatremia, where you have to temporarily reduce and then it comes back again. And then use of hypertonic saline, sometimes we just get a knee-jerk reaction and then start hypertonic saline in these patients, 3% hypertonic saline. It should be restricted to be rare case, some presenting with the life-threatening complications in the ICU areas is there. And at the present, Vaptan should be limited to only controlled studies, because very tendency to use the Vaptans immediately, there's been a hyponatremia is there. And just now told about the nutrition. The second resident who has presented, has very clearly, she said about the nutrition is the most important thing. And you don't have to wait for child C to develop a nutritional problems. Especially in alcoholics, even in child A also is being shown that at least 30% of them will have a nutritional problems in these people. And what is important, some of the simple things can be done if they are hand grip strength, if it's available, it can be done to see the strength. And more, if you don't have a strength, we know that 6 minutes walk test is there, which can be done very easily in any clinic also, and then see. That's ultimately what is important is that patients' performance status is very important, because suppose if I tell you that the Hong Kong, the algorithm for any transplantation starts with the ECOG status, first ECOG status, performance status. Then only the other things they talk about that one. And even in BCLC, in other classifications also, you know that the performance status is very important, and therefore we must keep that the performance status is good in these patients, both by terms of exercises, physiotherapy, and nutrition. And here, what are the do's? And as I said, that increase the high protein intake. Although recommended high protein intake we can never give. As far as weight is concerned, it is impossible to give that much amount of protein. But you must see that the adequate proteins are given to them. And nowadays, you know, if the patient is affordable, there is some kind of an indication that if you keep them by giving the periodic albumin, and the transplantation requirement also can be prolonged, and also they will be in better status to receive the transplant if it is affordable. I am not taking it up because it's very expensive. A month's treatment, a week albumin for 4 weeks costs about 30 to 35,000 rupees, right? But we must encourage more in the dietary protein in these people, and also avoiding the hypomobility, again very important. You must say them, they must be physically active to whatever they were doing it. And simply not being mobile, again, has been known to be associated with the outcomes, post-transplant outcomes are very bad in them. So, nutrition and the physical status, physical status of these patients is very important, which we neglect. We don't do this kind of a thing. And don'ts. What are the don'ts in nutrition? Unjustified delay in the lifestyle restrictions. We got all, you know, somebody says don't take this, don't take this. If you take this, brinjal, don't take brinjal in the patients with the liver disease. And these kind of things are going on. These food fats, and we must tell them that, I tell them, you can take anything. If the patient has got in ascites and edema, I said, what you require to do is only salt restriction, which usually is not done. I advise this, what is salt restriction? 2 grams. Most of the people confuse between 2 grams of sodium, 2 grams of sodium chloride. Actually, it is sodium chloride, which is given in salt form, is to 4 to 5 grams. That is 1 level teaspoons. What I advise is that, which normally we write salt restriction, tick it one, and then give it to him. What I tell in my practice is that, do not add any salt. Take the food given to the patient, person, before adding the salt. And for 1 day, the quota is 1 level teaspoon of sodium chloride salt, which is 4 grams, which amounts to 2 grams of sodium. Because sometimes what the people do, they give only 2 grams of sodium chloride, which is less. Right? And they go into hyponatremia ultimately. So this is again very important. Salt restriction is important. The only treatment which we will have is only two things we have in cirrhotic patients who come to us. 3 things actually. One is that ascites is there, salt restrict. Take a more protein, don't restrict the protein, even in grade 1 encephalopathy also. Sometimes they come with a confused state. They say one day it confused and then it goes off again. Then people restrict the protein in these patients. You should not restrict the protein in these patients. Third thing is physically be active as much as possible. There's only 3 sutras, which you have to follow in this one. Nutrition, mobility, salt restriction. And these will do wonders in these patients. Well, then we talked about, Akash has told about the portal vein thrombosis. The significance is that, if anybody, cirrhotic patient, otherwise stable, comes to you suddenly with an ascites, suddenly decompensation. There is no precipitating factor. There is no infection. There is nothing has happened. Suspect the portal vein thrombosis in these patients, right? And why should you suspect the portal vein thrombosis? What is the clinical significance? And there is a 3-fold higher risk of a failure to control active variceal bleed. Suddenly they start bleeding. Hitherto he was only grade 2, and when the portal vein thrombosis, because the pressure increases and then they start bleeding. And also they take a longer time to achieve the eradication, because they will take about 4 or 5 times to reduce rather than 3 times if it doesn't have a portal vein thrombosis. And it's a clear marker, as Akash has said, that decompensation without any reason, think of portal vein thrombosis, refer to his previous ultrasound when it was done, to decide whether it's an acute, recently happening thrombosis, or it's been thrombosis already chronically because there's a development of a portal cavernoma, hard thrombosis has already occurred. That's not important. The important is recently acquired, a soft thrombus, a partial thrombus. Ultrasonographer will tell you that there is a partial thrombus. Very important to recognize at this stage because anticoagulation helps in these. Because we are afraid of anticoagulation in the patients with the cirrhosis of liver. Of course, banding has to be done. We have taken care of before that. That's another aspect about that one. And also, any patient, although it used to be absolute contraindication previously for a liver transplant, now it's not, but definitely it's a slightly headache for the patients, for the transplant surgeon to see that this portal vein is thrombosed. Right? We must give them a clean portal vein for the good success of the transplant. So portal vein thrombosis has to be seen. Simple thing is by the ultrasonographer, ultrasonologist who tells you, compare it with the previous, whether it was there already, whether it's new one. So somebody done this one. Suppose if you give the anticoagulation before itself as a prophylactic agent, although this has not been approved by all, but this particular study is one of the studies which has been very often quoted. When you want to prevent that, 1 year he has given and is shown that the probability of a portal vein thrombosis where it's not given is much less, decompensation is much less, and survival is prolonged. Although it's not come into any kind of guidelines to give the prophylactically, that means is itself, it is still, but I am telling you the importance of anticoagulation in patient. But having said that, there's a meta-analysis which says that after having seen that there is a acute portal vein thrombosis, suppose if the patient is there, they can present with an acute pain in the abdomen also, in which case, if you see the thrombosis, he must be followed for any kind of a superior mesenteric vein thrombosis is an extending one. That becomes an emergency and then he has to be admitted. Right? As such, acute portal vein thrombosis, extending or not extending, should be admitted to the patients, right? And then start anticoagulation. And here it's been clearly shown in the meta-analysis, although it's a small one, but there is some evidence in that one that the complete recanalization can occur if you start them early, and progression of thrombus is also lessened, and variceal bleeding also will be lessened, and your surgeon will be very happy if he sees that there is no thrombosis in the portal vein at the time of surgery. Especially patients who are going for the transplant, almost it becomes a must, because sometimes we are afraid of starting anticoagulation in these people because we know that the cirrhosis is both coagulant and then anticoagulation. Both are there in this one. This meta-analysis says that one, but and this indiscriminate use of the proton pump, I don't have to tell you that our prescription starts top, right, as if the patient has got a very large duodenal ulcer or he's bled recently, and that's how it starts, So you should, so in this last study it's been found out that, almost all, not only here, all over the world. It's not that we are only committing this kind of a PPA abuse. All over the world, people are committing this abuse. It's been shown that the cirrhotics are, and without any appropriate indications, more than 50 to 70% of the people are on PPIs, right? And a new one has come now for us, one is on, right? Then our practice is a fashion practice, our medicine sometimes, whichever comes new, we start that one. And in this last study, veteran corporate study in USA, I'm not talking about in India, the 76,000 of which 23,000 had a PPI, the other did not have and it clearly shown that the decompensation-free probability, survival, infection-free probability are more in people who did not have PPIs. So injudicious use of the PPA should be curtailed unless there is a very clear indication, right? And then underestimating the impact of the comorbidities in the clinical course, right? And you know that with the NAFLD and then other things coming on, obesity and then NAFLD and alcohol and these people, diabetes is now become almost every fourth or sixth person is a diabetic in our country. Country is a diabetic capital, right? And in these people is very well known that whether it's an alcoholic liver disease or it is a non-alcoholic liver disease, and the people with the diabetes have got a cumulative probability of cirrhosis higher than the persons who do not have a diabetes. And same thing, even HCC also, it's been shown that in the follow-up, those who have got a diabetes have got a higher incidence of developing the hepatocellular carcinoma as compared to the people who do not have a diabetics. So the importance is that, very proper management of a diabetes is very important. Two things. One is a proper management of diabetes, management of obesity in these people. If the person has been diagnosed with cirrhosis as a child at that particular time, and it has been shown very clearly that even the fibrosis also resolves in these people with the, if advanced fibrosis also has been shown to resolve with the lifestyle management, but it's a different thing. Only 10% of them, they follow this one, And another comorbidity is a cardiac, which normally we do not, this one. Now cardiologists, diabetologists, they have got a more search for NAFLD than hepatologists and then gastroenterologists, right? In fact, cardiomyopathy has been defined as a phenotype of a cardiomyopathy is NAFLD cardiomyopathy, right? Especially the heart failure with a preserved liver functions. So that has become very, very common. And also, fat is bad everywhere. Fat is bad even in pancreas. What we call as a chronic pancreatitis, the stellate cells are there even in the pancreas. So it is going through the same phase. Non-alcoholic fatty liver, NASH, cirrhosis, cancer. Even in pancreas, what we used to call, previously we used to ignore the fatty liver. Now everybody is taking cognizance of the fatty liver. Now bulky pancreas, especially in obese people, we don't take much of a cognizance of that one, but people have shown now that they are taking more and more interest. They are going to see what is the stiffness of the pancreas in terms of this one. And same thing, fatty pancreas, pancreatitis, and the Skirrus type is chronic pancreatitis. Stone formation is there because there is a duct is there for the pancreas, and carcinoma. So the other thing is that comorbidity like a pancreas in alcohol also must be taken care of, and especially the cardiomyopathies, whether it is an alcoholic cardiomyopathy or a non-alcoholic or a cirrhotic cardiomyopathy, and the precipitating factors in these people, sepsis, if it's undergone TIPS or a transplant, then the cardiac issues will come up very prominently. So ultimately what does it say? Do diagnostic and therapeutic paracentesis for early diagnosis of SBP and prevent in HRS. Appropriate dose, time, monitoring, usage of a non-selective beta blockers, early diagnosis of a nosocomial infections and appropriate antibiotics, and fluid restriction is not necessary for routinely uncomplicated ascites management, especially the two things which I have told you already. Pay sufficient attention to malnutrition, screen, assess and correct. Do not withhold an anticoagulant therapy in patients with an recent acute portal vein, especially partial portal vein thrombosis, to prevent decompensation, especially in the pre-transplant time. Judicious use of the proton pump dive, and do not underestimate the impact of comorbidities in the clinical course, especially diabetes and obesity. And the last one will tell you what are the do's and then don'ts. Patient presenting with an ascites, do perform diagnostic paracentesis on admission. Do not delay the procedures for coagulopathy or a transfused blood products. You don't have to transfuse routinely for these patients the blood products. SBP, start the antibiotic quickly and give albumin on day 1 and then day 3. Do not forget to prescribe long-term antibiotics for a secondary prophylaxis. And suspected variceal bleed, perform an endoscopy and start the therapy, and also give prophylactic antibiotics at the time of doing endoscopy. Do not forget secondary prophylaxis of prescribing NSBB and follow-up and subsequent, because they get done and they don't come afterwards unless you tell them. First time when they come for a bleed, they come. Afterwards you must tell them that we have to see that your varices are eradicated, and therefore coming frequently at intervals and see that they are eradicated, because that can be one of the decompensating features. Any bleed, ascites, these are the ones which are, and these are all preventable, provided they can be looked after one. Health maintenance, vaccination status, very important. Now, I think hepatitis E also they are coming with the vaccination is coming up in future now. And A is, in our country, we have to just assess the antibodies and then see for adults whether they require A vaccination or not. And don't leave these health maintenance patients to the primary care providers, or whoever is doing it has to do it. One pain management, and again very important, NSAIDs have to be avoided in these people. Do not prescribe NSAIDs in these people. They go with a knee joint problem to an orthopedician, and then they prescribe an NSAID, and on the third day he will land up to you with a complication, either with a bleed or with a HRS in your outpatient, or even to the ICU areas is there. Nutrition has told that do not restrict the protein and do give high protein diet in these patients. And alcohol use, screen alcohol for everybody, and ascites management, instruct the patient on self-management, salt restriction, weight recording, and the other red flags like a fever. And don't wait till the ascites become unbearable. Don't let it go to the refractory stage. That is important. Once refractory stage, it becomes very difficult because you can't do diuretics. If you use diuretics, creatinine goes up. Right? If you don't give diuretic, ascites goes up. Even otherwise also creatinine goes up with an ascites. Then your health cost increases. You have to give albumin to these people, and therefore do not allow them to go into the refractory as much as possible by your careful follow-up. HCC, screen the patients with the ultrasound and the AFP levels afterwards, especially if your hepatitis B and hepatitis C. If you started the treatment after the development of a cirrhosis of liver, they are candidates for the surveillance. And disappearance of hepatitis C RNA or no DNA does not promise that the hepatitis B will not develop. These have to be told that they have to do it. Hepatitis B is a very rogue virus, as you know, that it has surprised every clinician, if I know that, that coming with a large this one, even if you've seen about 6 months before, right? And liver transplant referrals, that the early referral is better. And these are the things which I thought I would say about how to prevent some of the complications, to keep them as much possible in health status as possible, whether they go for the transplant or not. And thank you very much for me giving the opportunity. Thank you.
Thank you, sir, for your nice deliberation. If there is any question on the house, you may ask.
Or comments? Anybody? Listen. Any one of you, Gaur or Akash, if you have any.
Sir, may I ask? Sir, here.
Yeah.
So what is the role of regular albumin in cirrhotic patient? Do they any mortality benefit if you give regular albumin to them? Suppose they can afford.
The question is only the affordability. This one. Albumin has got not only oncotic pressure related. There are lot of other the helps are there with the albumin. They are all. And therefore, in the trial, the Italian trial, everybody quotes that one, that there's clearly been shown that, give the albumin every week. They gave it for 1 year, and they've shown that they decrease mortality, and then the transplant is also pushed a little bit later, and then they are in a healthier condition. But providing that one is become more or less a normal practice. If the patient is affordable, we advise them on an albumin. Albumin has got 3 places. Now, one is HRS, and another is SBP, and another is maintenance long-term albumin.
And so, so role of rifaximin, how long to continue?
Yeah, please. No.
Absolutely. I think all the tenets that were mentioned, these are essentials for improving quality of care for patients with cirrhosis. Only one thing I think we can also add in is caregiver education. The patient relatives that are there, because these are not going to be acute problems. They are going to have these. They are going to land up in encephalopathy, and the caregivers are usually the first people who can understand these. So that discourse with the caregivers is sometimes we in our busy clinics tend to miss out on. But it has been already shown that if we optimize caregiver education very well, how to suspect encephalopathy, what not to give, how to take it, how to catch for falls. They tend to fall, they tend to fracture, everything goes wrong.
Right.
I think another important aspect of it is to involve those associated caregivers, because one hospital admission skyrockets the costs and breaks all the dreams that family has.
I always tell them the best patient for the transplant, he's never been admitted into the hospital, right? You know, and the best patient for the transplant is that he walks into the theater, right? You know, but unfortunately, they deny at that point of time. When they are healthy and when relatively their physical status is good, you advise them, no, I am okay, why should I undergo the transplant now? And by the time they reach us, we tell that you are not fit for the transplant. That is the timely rifaximin, his role is concerned. I think in diabetics, sometimes they get a lot of acute diarrheas, intermittent diarrheas. This is because of a SIBO, small intestinal bacterial overgrowth. Previously, we used to give ornidazole and then combinations like that, because they are associated with, the skin reactions and SJS syndromes. Now we stopped giving to these people ornidazole combinations. Best thing is to go rifaximin, and then very, very safety profile is excellent in these people. You can use them, especially in diabetics when they develop the. And another thing to encephalopathy. Encephalopathy, again, we've been giving lactose, anyhow it is there. And for secondary prophylaxis, rifaximin also is being given now.
There is dose and duration of treatment of rifaximin in this subset of patients, sir.
In diabetics, of course, it's a very short course. You give it for about 4 weeks, 4 to 6 weeks. There are no guidelines on that one. This is by own personal experiences which we are telling. That, what we have seen is that if you give them, the next episode of the loose motions is quite delayed. They won't get, Otherwise, they will be getting the colonoscopies done. They would not know why they are having the diarrhea. And the duration for this one, especially if the previous encephalopathy has already occurred, it has to be given lifelong. In a repeat, already occurred, not for the primary this one. If already he's got an encephalopathy, then we add rifaximin in these patients to lactulose.
If there is no more question, I think we thank you once again, sir, for your excellent lecture.
Thank
you.
We thank our speaker for his wonderful presentation. We request our honorable chairpersons along with the President of Hepatitis Foundation of Tripura, Dr. N.L. Bhomik, to please felicitate our speaker for today. Our President, Dr. N.L. Bhomik, shall be awarding our speaker with a lifetime membership to Hepatitis Foundation of Tripura. We request our President to please felicitate our chairpersons for today. They are being presented by Health Adda, written by Dr. Gordas Chaudhary. We thank our wonderful speaker and our honorable chairman. With this, we come to an end of our second scientific session. Now we shall adjourn for lunch. Our next session will begin sharply at 2 p.m. It is titled Our Hepatitis Session, featuring a multiple panels of discussion. Thank you.
Hello, 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 hello.
Good afternoon to all. I welcome you to the first session post-lunch, which has been named as the hepatitis session. This session is to be chaired by Dr. D.P. Chakraborty sir, Dr. Sagar Somrat Debbama sir, and Dr. Porimol Sarkar sir. I would request the chairperson to please take the dais. Our first speaker on the topic of diagnosis and management of reactivation of chronic hepatitis B. May I call up on stage Dr. Premashish Kaur.
Good afternoon, everyone. I welcome you all in this post-lunch session on hepatology, hepatitis. And the topic is reactivation of hepatitis, chronic hepatitis B. And this is a fairly matter of concern, actually, when we talk about reactivation, particularly in the setting of immunosuppressions or chemotherapeutics being given to patients, maybe for solid tumors, maybe in rheumatoid arthritis, Crohn's, number of cases when the virus can flare up. And sometimes the diagnosis is really tricky and management is equally challenging. It could be catastrophic at some times if we fail to diagnose this reactivation. To give an overview of all these points, may I now invite Professor Dr. Premashish Kaur, who is an eminent teacher and a distinguished faculty in the field of hepatology. And sir is currently the Senior Director and HOD of Gastroenterology of Max Super Specialty Hospital to start his deliberation. Over to sir.
At the beginning, I must thank Professor Dr. Pradeep Bhaumik and the organizing team of the Agartala Medical College and the Tripura Hepatitis Foundation for giving me an opportunity to participate in this scientific workshop. I have thought of talking on the reactivation of hepatitis B, which is an important clinical problem which we encounter in our day-to-day practice. You see, there are various guidelines by the American Association of Liver Disease, European Association of Liver Disease, as regards when to suspect, how to suspect reactivation. When should we suspect reactivation? In clinical practice, you would come across persons who have been carrying the hepatitis virus, HBsAg positivity, for a long time. But when you test them, they are E antigen negative, anti-HBa positive. So there is no active replication of the virus. But suddenly you find that a person who was DNA negative earlier, E antigen negative earlier, suddenly becomes E antigen positive and DNA positive, and the DNA viral load goes up. It would indicate that there has been probably underlying reactivation. There is an active infection in the concerned person. So, for HBsAg negative and I have told you HBsAg positive and anti-HBC positive patient, if you suddenly find the DNA levels are very high, you have to suspect reactivation. If you find, there may be a situation where a person is HBsAg negative, but he is anti-HBC positive. In this individual also, if you find that the DNA, which was earlier undetectable, becomes DNA positive, this indicates that there could be reactivation. Now, what is the spectrum by which this reactivation can manifest? One is, there could be a silent reactivation. Just you may find patients presenting with elevated viral load without overt hepatitis. That means the LFT, the transaminase, they may be normal, but the DNA is high and HbSAg is positive. So that is a silent reactivation. Or it can present with acute hepatitis B infection. So many times in our clinical practice we find individuals who present with clinical jaundice, anorexia, loss of weight, loss of appetite, and it turns out to be acute viral hepatitis. And you do the serological markers, the HbSAg is positive. And then you start thinking, is it hepatitis B? Or is it that there is, in the background of HbSAg, there is a super infection with other viruses like hepatitis A or E? To resolve this issue, if you do the IgM anti-HBC and you do the DNA viral load and you do the E antigen and anti-HBE, if you find that the concerned person who is presented like acute hepatitis B, his surface antigen is positive, his DNA viral load is high, his E antigen is positive, he may be IgM anti-HBC positive, but it would indicate that this is possibly acute hepatitis, this is possibly this is reactivation of chronic hepatitis B presenting like acute hepatitis B. So there is a sometimes difficulty to distinguish between acute hepatitis B and reactivation of chronic hepatitis B. But it's not so difficult because in acute hepatitis B, IgM anti-HBC is positive. In reactivation also IgM anti-HBC may be positive. What is the difference is the DNA viral load. The DNA viral load in acute hepatitis B is on the lower side. Whereas in reactivation of chronic hepatitis B, the DNA viral load is on the higher side, is high. So the high viral load would favor possibility of reactivation of chronic hepatitis B presenting like acute hepatitis B. The other mode of presentation can be acute hepatitis B can sometimes present as acute liver failure. Now, who are the people who are at risk of reactivation? There are certain host factors. If you are a male sex, if you are an older age, and you have already a predisposing disease like underlying cirrhosis or hematological malignancy, or you have associated risk factors, virological factors like high DNA, HbSAg and E antigen positive status, and absence of anti-HBs protective levels, and co-infection with hepatitis C, HDV, Delta virus infection, or HIV, you are at high risk of reactivation. The immunosuppressive agents, if any patient who is under immunosuppressive therapy, it also depends, various immunosuppressive therapies which are used, these category of patients are also at risk of reactivation, and therefore it is mandatory to test them for HbSAg before starting the immunosuppressive therapy. Now, if you have, this shows that when there are two categories of patients you may see. One is surface antigen positive. The other category which you may see is that they are surface antigen negative and anti-HBC positive. Now, in these two categories, what is the risk of reactivation? If you have a surface antigen positive person and you start them with this, they have a more than 10% risk of reactivation if you start them on one of these drugs, like anti-CD monoclonal antibodies, rituximab, steroid high doses, anti-TNF agents, anthracyclines, hematopoietic stem cell transplantation, direct antiviral drugs, they are at risk of reactivation. The risk is moderate, 1 to 10%, if the cytotoxic therapy is started in this category. Anti-TNF agents are started with lower potency, or the steroid is given for more than 4 weeks. The risk is low, chances of reactivation less, particularly with the drugs like methotrexate, azathioprine, low-dose steroids, or direct antivirals for HBV or ACV infection. Similarly, if the individual is HBsAg negative but anti-HBC positive, they are also at risk of contracting reactivation, particularly if you are starting them on all these immunosuppressive therapies. At some time or other, there is a risk of reactivation. So, what is the clinical implication? Even if the person is HBsAg negative and anti-HBC positive, if you want to start them on chemotherapy, immunosuppressive, they should be properly screened for any evidence of reactivation. You need to do the HBeAg, you need to do the DNA viral load, LFT in these patients. Now I am talking about the reactivation in cancer chemotherapy. When you have a person whom you intend to start the chemotherapy, what should you do? You should first screen him for surface antigen positivity and anti-HBC positivity. If you find the person is surface antigen positive, next step, see whether he has an active infection. So you need to do the DNA viral load, you need to do the E antigen, and the DNA viral load is high and the E antigen is also positive, LFTs are abnormal, then standard antiviral therapy should be started before starting them on chemotherapy. If, on the other hand, when you are screening them, you find that the HBsAg is negative, but the individual is only anti-HBC positive. A simple anti-HBC positive indicates a past marker of exposure to hepatitis B positive patient. Still, they are at risk, and therefore, they cannot be started on chemotherapy or anything without proper screening. You need to do the DNA levels, and if the DNA levels are positive, they need to be given the standard treatment of antiviral drugs along with the concurrent administration of the chemotherapy. And the antiviral drugs need to be continued 12 months after the cessation of chemotherapy. In some cases, it need to be even continued for 8 to 24 months. If, on the other hand, you find that the anti-HBC is positive, but the DNA is negative, what should you do? Such situations, you can give chemotherapy and monitor the ALT levels and the DNA levels and the E antigen every 3 months till 6 months after cessation of chemotherapy. In the individual where you intend to start chemotherapy, if you find that your serological markers for hepatitis B is negative, both HBsAg is negative and also the anti-HBC is negative, what should you do? Before starting chemotherapy, you can give them vaccination, the standard dose of accelerated hepatitis B vaccination. 3 doses to be given before starting chemotherapy, and you should check the anti-HBs titers 1 to 2 months after the vaccination. If vaccination is inadequate, you can revaccinate. Now, sometimes we need to start biologicals for non-malignant diseases. Now, even in this situation, you need to see whether your patient has any evidence of reactivation or any evidence of occult HBV infection. And even if you have to start these patients on rituximab or anti-TNF antibodies, they are at high risk of reactivation. The risk is also there when you use etanercept or abitacept and kinase inhibitors, and therefore you need to define their HBV profile whether the surface antigen is positive, the DNA load is high, the E antigen is positive, and then if they are positives according to standard criteria, you can start the antiviral drugs along with the biologicals. There may be a situation where the person has to be started on chemotherapy and he is a HBsAg carrier. This situation can sometimes come with, for example, inflammatory bowel disease patients, where you may have to start them on biologicals. The risk of reactivation is 20 to 30%, and therefore, even in a patient of inflammatory bowel disease who has a HBsAg positive carrier state, they need to be checked for reactivation by doing the LFT, DNA, E antigen status, and accordingly, they can be concurrently started if they are found to be positive DNA on tenofovir or entecavir or tenofovir alfanamide. It can be started concurrently, yes. Now, if they are negative, if the HBV serology is negative, then of course you need not give them antiviral drug, but since they carry the risk of reactivation, so sometimes the recommendation is that you can give them a double dose, accelerated schedule with double dose recombinant vaccine, 40 microgram, 0, 1 and 2 months. See the response, serological response, anti-H-based response after 1 or 2 months. Inadequate response, revaccination is recommended. So regular monitoring of the anti-H-based titers should be performed every 2 years. Booster recommendation is recommended if the anti-H-based titers goes less than 10 MIU. Okay. Since biological therapies are being planned for rheumatological, dermatological, and gastrointestinal diseases, if you are planning biological therapy for rheumatological, dermatological, gastrointestinal disease, where the drug therapy has to be continued for a long time, you have to make sure that your patient does not have any evidence of reactivation, and therefore they should be screened with the DNA levels, with the LFT, with the E antigen, and the viral loads should be done. And if you find that these parameters are abnormal, then they can be concurrently started. Biological therapy can be started concurrently with the antiviral treatment for hepatitis B. A situation, again I have told earlier, that we will find that the person is only anti-HBC positive and HBsAg negative. Here also, if the DNA is positive, you need to cover up the biological therapy along with the antiviral drug. If the DNA is negative, even the person is anti-HBC positive, you just need to give the biological therapy and monitor any changes in the ALT levels, HBsAg and DNA levels every 6 months. If the person is serologically negative for HBsAg, then in that case, and the biological therapy has to be given for a long time, in that case you need to give them you need to vaccinate them before with the 3 conventional 3 doses, the vaccine. And monitor the serological response to the vaccine every 1 to 2 months. So more or less, the ASLD, the EASL, they all recommend screening and starting antiviral therapy once you think of treating this, rheumatological diseases, your IBD patients, psoriasis patients. They should be all have a DNA levels done at the baseline to know whether there is any active infection. The other recommendation is that those who have, the EASL says that even if the person is HBsAg positive but DNA negative and you want to start the immunosuppression, you can prophylactically start the antiviral drug as a presumptive therapy along with before starting the immunosuppressive therapy. Now comes the reactivation in solid organ transplantation. Now it is been found that patients of decompensated cirrhosis who are HBsAg positive, they need to be given the antiviral therapy for hepatitis B lifelong. And it has been shown that if you give them antiviral therapy on a long-term basis, it reduces the risk of hepatocellular cancer. So, those patients whom you are contemplating for a liver transplant for decompensated cirrhosis, these persons should be on the antiviral drug for the hepatitis B, because in that case, the risk of reactivation of chronic hepatitis B following transplantation is much less, as well as the chances of development of HCC in the post-transplant patient is also reduced. The point to remember is that patients who have decompensated cirrhosis also has kidney involvement. In them, when you're treating them for hepatitis B, particularly you have to avoid nephrotoxic drugs. So you need to do the renal adjustment of the nucleoside analogs according to the GFR. Because these patients can develop renal failure, lactic acidosis, if you are not reducing the if you are not reducing the doses according to the requirement. Now, following the liver transplantation, post-liver transplantation, some of these individuals, you may find that how to suspect that there is a reactivation. Post-transplant, you may find that there is suddenly the HBsAg has become positive in the post-transplant patient. Even if the DNA is negative, you have to suspect that there possibly may be the possibility of reactivation. So circulating HBsAg, which was earlier negative, has just turned out to be positive in a post-transplant patient, should raise the possibility of reactivation. And these people should be put on the antivirals, entecavir, tenofovir, and the other things pre-transplant, and should be continued post-transplant. The whole idea is to prevent the risk of liver cancer in these patients, in the post-transplant patients. Earlier, when we used to refer the patients with the HBsAg decompensated cirrhosis for liver transplant, usually the surgeons used to prefer giving HBIG in the perioperative period with an aim to maintain high HBsAg titers in the first few months following liver transplantation, which had some beneficial effects. They used to continue giving HBIG so as to prevent recurrence of hepatitis B. But it involved a high cost, unavailability of HBIG, and also there were issues with regard to the dose and route of administration. Now, the various publications have come which says that there is no need for giving hyperimmunogamma in the post-transplant patients to maintain a very high HBsAg titers, anti-HBs titers. You can still do it only with the antiviral drugs like entecavir or tenofovir. They can be given post-transplant so that the relapse or the recurrence can be prevented. Yeah, tenofovir, entecavir monotherapy after hepatitis B immunoglobulin withdrawal is safe and effective in the prevention of hepatitis B in the liver transplant recipients. So these days, there's a change in the trend of practice. most of these patients, in the post-transplant patients, are straight away given antiviral drugs, antinucleoside analogs, to prevent recurrence in the post-transplant status. Right. Now, non-liver solid organ transplanted recipients. Sometimes, some patients with decompensated cirrhosis needs combined organ transplant. They may have a kidney disease and they may need concurrent kidney transplantation. So, hepatitis B positive decompensated liver disease patients need to be on prophylaxis lifelong. And it has been found that this people who have concurrent kidney disease also, it's important that this nucleoside analogs can be continued in these patients of chronic kidney disease, and it is quite helpful in reducing the risk of rejection. Renal, the second problem which has been highlighted is that if you have a patient who has anti-HBC positive patient and he wants to donate a kidney, he is surface antigen negative, he is DNA negative, the recipient has been found can safely receive a kidney from a anti-HBC core positive patients, and there is not going to be any bad effect. Can take it. Another issue which has been discussed is that those patients who need long-term steroid therapy, there is always a risk of reactivation of chronic hepatitis B. Therefore, the recommendation is for patients who have to be given steroids for more than 4 weeks of high doses, pre-therapy screening for HBV markers should be done, screened. Prophylactic antivirals need to be given to a person who is HBsAg positive, anti-HBsAg positive, but who is DNA negative. You can still give them prophylactic antivirals starting 1 to 3 weeks before corticosteroid therapy to 1 year post-withdrawal. Lesser dose of or duration of oral corticosteroid pre-therapy screening for HBV is not recommended. But for patients receiving intra-articular steroids or local steroids or inhalational steroids, pre-therapy for the hepatitis B is not required. Prophylactic pre-therapy is not required. Patients with CKD. Prevalence, those patients who are CKD patients on dialysis, 1 to 10% and up to 20% Asian countries, they have the risk of associated hepatitis B infection. So they should be always tested in a dialysis unit and retested at every 6 months for the presence or absence of HBsAg. If they are HBsAg negative, this dialysis patient should be vaccinated. Those persons who are not on hemodialysis, CKD patients, they should be vaccinated with standard 3 doses of hepatitis B vaccine. But those who are hemodialysis, they need a higher dose of hepatitis B vaccine at 40 micrograms, 0, 1, 2, and 6 months. And it is always mandatory to see that you are able to maintain an anti-HBs titer more than 10 MIU. Now, HBV prophylaxis for CKD and dialysis. Prophylaxis is required for HBsAg positive with DNA levels more than 2000 international units. And irrespective of the ALT levels, these patients of CKD should be either on entecavir or tenofovir or TAF. And post-transplant patients who are positive, HBsAg positive, should receive lifelong anti-nucleoside analogs. But the dose adjustment is required, taking into consideration the creatinine clearance. who are HBsAg positive with DNA less than 2000 interaction units with evidence for liver disease or with a high DNA should be treated immediately at the time of diagnosis. HBsAg negative, anti-HB positive patients do not require antiviral therapy and they should be monitored for reactivation every 6 months and treated only if there is evidence of seroconversion. Yeah. So what is the conclusion? Liver transplant patients, if you have, you start antivirals in patients with cirrhosis who have detectable DNA. So if you're contemplating transplant for a patient who is decompensating cirrhosis with HBsAg, start them on antivirals. Post-transplant, yes, you can either, to prevent the recurrence of hepatitis B, you can give either HBIG, hyperimmune gamma globulin plus antivirals, or you can even just continue with the antiviral drugs. Or you can stop the HBIG once HBsAg becomes negative and DNA becomes undetectable. Non-liver solid organ transplant patients who are HBsAg positive requires lifelong prophylaxis with antiviral therapy. Anti-HBC positive, HBsAg negative patients need to be monitored for any evidence of reactivation. But if you are to start chemotherapy in an anti-HBC positive patient, you could give them preemptive antiviral therapy before starting the chemotherapy. Steroids, patients who need to be on a steroid and long-term therapy, even for more than 4 weeks, needs to be screened for any evidence of HBsAg positivity. CKD patients and hemodialysis patients need to be screened for HBsAg. If they are negative, they need to be vaccinated. But if you find that they are HBsAg positive and DNA levels are more than 2000 international units, HBV prophylaxis need to be started. I think the message which should goes down is, most important thing is that whenever you find in clinical practice an individual is HBsAg positive, first and foremost thing in life is to determine whether he needs treatment or not. And for that, we need to do the LFT, E antigen and the DNA viral load. If these are abnormal, the patient needs to be treated. That is the most important thing. Needs to be treated with the antiviral drugs. If you need to, if the diagnosis of GI tract cancer has been made, or you need to consider the patient for any chemotherapy, for any situation, don't start the chemotherapy unless you have done the HBsAg screening. HBsAg is positive, you need to look for the active infection, and then if there is reactivation, concurrently you can give the antiviral plus the chemotherapy. If, on the other hand, you find that the person is surface antigen positive, anti-HBC positive, but he is DNA negative, still if you have to give chemotherapy, in that case, preemptive therapy with the antiviral drugs can be concurrently started in this group of patients. In a patient who has got kidney disease, they should be screened for HBsAg. If they are negative, you vaccinate them with the conventional dose. If they are positive, then you need to give them a higher accelerated dose of the vaccine. If the person, if a patient is receiving a kidney from an individual who is anti-HBC positive, but who is DNA negative or surface antigen negative, this is still allowed. The recipient is unlikely to have progression of the disease, even if he has received if the DNA is negative. So these are some of the guidelines which is there. We have to just remember broadly the basic thing is important to ascertain that HBsAg positivity should not be ignored. And we have to make sure that the patient requires treatment or not. And the most important thing is that in clinical practice we see many patients who are acute hepatitis B positive, who comes with jaundice, and you ask for the serological markers and you find the HbSAg positive. Don't jump to the conclusion that it is acute hepatitis B. There are two situations which can happen here. One is the HbSAg positive is turned out. It's possible that the person could be HbSAg carrier and there could be a superinfection with hepatitis A or E, which can be ruled out. If the A and E is ruled out, then there's a possibility that there could be a reactivation of hepatitis B. You need to do the DNA, viral load, and the E antigen status. If the E antigen is positive and DNA is very high, then probably it is an acute viral hepatitis B. And as I have mentioned, that acute hepatitis B can be distinguished from reactivation process by the simple formula that in acute viral hepatitis B, the DNA load is going to be very high. Acute hepatitis B, the DNA load is going to be on the lower side, but if it is a reactivation of chronic hepatitis B, manifesting like acute hepatitis B, the DNA load is going to be very high. That is a very simple thing.
Thank you, sir, for a very lucid presentation, making this very complex and perplexing issue quite simple for the audience. I don't think there will be any more questions from the audience. If there is, we can take only one. If there are no questions, I thank you, sir, once again. Please join me.
We thank our speaker for the wonderful presentation. Now I call upon Dr. Sheikh Mohammad Fazle Akbar for his speaking on immunotherapy against chronic hepatitis B.
Our next speaker is an eminent doctor. He is Dr. Sheikh Mohammad Fazle Akbar. He is an internationally renowned doctor and he works as a professor at the Ehime University of Japan. I now give time to sir to give his lecture.
Thanks for introducing, and I thank the Tripura Foundation, Hepatitis Foundation, for inviting and providing an opportunity to talk about something that we have been working for the last 3 decades or more. Well, just before, Professor Pramashish Kaur and the others also discussed about the management of the hepatitis B, and also in future we're going to hear a lot about the management of cancer by immune system. So here, Dr. Pradeep has asked me to discuss something about the immune therapy against chronic hepatitis B, which we are working for 3.5 decades, and also the containment of hepatocellular carcinoma, for which already some immunotherapy is available. Now just try to assess what we can do against the traditional concepts, because I am now standing on the podium of Hepatitis Foundation of Tripura, those who are trying to somehow eliminate or control the hepatitis B virus infection. So the thing is this: we will always come to the doctor, get something. Having an infinite treatment for whole life is not a practical option, and under these things I'll discuss about it. This discussion will also take part the elimination of hepatitis by 2030 in developing countries and in the world, a goal of SDG, Sustainable Development Goal of the United Nations. And so under the whole picture, how it looks like, that will be my point of discussion. So first, a bird's of view about the HBV and related pathologies. So just simply I'd like to tell that in this world there is 8.1 billion people. Out of this, about 200 million people has been infected with hepatitis B virus at some point of their life. And out of this, about 300 million people have been infected and also providing the hepatitis B surface antigen positive. That means the chronic carrier. And they develop cirrhosis of liver and hepatocellular carcinoma. And the point of intervention is near the chronic hepatitis B, which is about maybe the 15 to 20% of the people of the 300 million. So about 10 crore people would be the subject of treatment. And if we cannot block over here, when the patient develops the liver cirrhosis and liver cancer, we have little to do. So we will try to do these things, especially the foundations like Hepatitis Foundation of Tripura and others have this duty. Well, if we look at the life cycle, I'm not going particularly in different area. So the red colors places are the area which can be the subject of drug development for the virus. So, and only one area has been attempted till now for the commercial drug development. And the more complexity has come with the elimination of 2030. Why? I'm telling you. So you just see here that I don't have a pointer, I cannot show you. About the most of the people who have the hepatitis B virus infection does not know that they have the hepatitis B. So about 80% to 90% are unaware of their situation. And only 5% or 10% people is under some types of management. So what the Tripura Foundations or others, several foundations and World Health Organization and the state and the country like to do about the hepatitis B virus, they like to get all these patients, all these carriers, or the 80% and 90% of these carriers within 2030. Now it is 2024. We have started this in 2015, so almost 9 years has passed, but we could not do much of the things. And the 2030, the goal is not going to be achieved, it is going to be a failure. This is one practical situation. And even, the right side is written, even we can find this chronic HBV carrier, that means the 30 to about 300 million, then what we'll do? So the treatment guidelines say, so you can give the antiviral drug and other things, and there will be the lifelong uses of these drugs. Is it possible to give this thing? And if we think in the context of India or Tripura or Bangladesh, if we consider that 2% people is infected with chronically with the hepatitis B virus, can we give this infinite treatment for the whole life? And after that, the side effects, can we manage all these things? They will suffer from kidney diseases and the transplantation problem. Can we do this thing? No. So let us think what we can do and what we can do by research in the future. Well, so people, now you can see that there are various variables of the hepatitis B virus, entry of the virus, cccDNA, formation of protein, polymerase, and nucleophosphate assemble, and drugs has been developed for all of these things. And only one area, that being the nucleoside analogs that act on the HBV polymerase, is now used for the treatment. That is the, you say, entecavir, lamivudine, and all these things goes to this only one group. And the second thing, so just up to this, what I have told, that if we like to achieve the elimination of hepatitis goal by 2030, it is an impossible goal that has been set. And even if we can do, even the foundation like Tripura or the government of India, government of Bangladesh, do a vigorous work and find 80% of the chronic HBV carrier, how they will treat? They cannot treat this thing because this is an infinite therapy. So if you discover something in the age of 20, you have to treat for the age of the 60 years or at least for 10 years or something like this. And why this thing is not moving? So if you go to the left side, you will find the pharma industry has a revenue of $1 trillion in 2023. And the biggest pharma, all is from the developed country, and all of them have the $1 trillion budget. You just see one or two factors. The Indian health budget, so it is not very clear over here. If we find the Indian budget and the breakdown, we'll find the nature that the one pharma budget is much bigger than the national budget, even like the India or some country like this. And if you look at the nucleoside analogs market value, it's more than $1 trillion. So this is in billion. So, sorry, $1 billion. So this $1 billion industry will continue. And you know, just I am giving you another information about the cancer it will come. One drug has a market value of $25 billion last year, 2023. One cancer drug, immunotherapeutic drug. I'm coming later on, the impact of this drug. And that was the $25 billion market value. So there is a big market in moving here. And under this situation, how we can limit this thing and go for some the benefit of the people. And now we need the evidence-based drug. first of all, I like to say that antiviral drug is not an evidence-based drug. It is an evidence-less drug because, you see, for the hepatitis B virus is not a cytopathic virus. It cannot destroy a single cell hepatocyte. It doesn't have a toxin. It cannot invade. What happens actually, hepatitis B virus interact with the immune system, and the immune system take some forms, and then they destroy the inflammation, fibrosis, and the cancer. Hepatitis B virus has no power. For example, in the world, 2 billion people have been infected by the hepatitis B virus, and 30 crore, 300 million only will have surface positive, and maybe that 10 crore will have the hepatitis. So why this diversity? Because the virus is not responsible for this. So why we target the virus? The next thing, the immune system has the two roles. Number one, it can be protective or it can be pathogenic. And by experiment and by data, we have shown that it can be protected and this type of thing. So we decided to manipulate the host system to develop the drug for the hepatitis B virus, and that's the immune therapy for hepatitis B, and we'll move for that one. So immune system at the beginning, so there are the different immune modulator that has been written on the left side, that has been interleukin 2 to thymosin alpha. We also take part over here. And these all are the immune modulator, polyclonal, and it doesn't work. So immediately some activity was found, but it does not give the sustained activity, and then we move to HBV-specific immune therapy. And these are the publications from our one group, that not in my department, one group that we show that we need immune therapy, not the antiviral therapy. And it is not possible to discuss all this thing over here, but we have more than 100 publications to authenticate this system. Well, so what we found? We found that the immunity has two types. One is the pathogenic, other is the protective. So our target is to give the more protective and the less pathogenic immunity so that we can treat the chronic hepatitis B. And to do this thing, we produce a type of mice that is called the HBV transgenic mice. When the mice have fertilized the ovum and the egg, at that time we micro-injected the genome, and ultimately from that we got these mice. And another area was the antigen-presenting dendritic cell. It is not possible to explain all these things here. So we find a model how to do the immune therapy for the CHB patients. At this time, surface antigen immune therapy was going on, not only by us, but other group, starting from the America to every places, and ultimately found that it will not work because all the people use the conventional vaccine. In the next 4 slides, I will say that what we make the changes. So one changes I like to be simplified. We add core antigen, the dose becomes 10 times, the duration becomes 15 times, and we give by both nasal and the parenteral, and we developed a vaccine with the help of Cuba that is called the NASVAC. The NASVAC has come from the nasal, and it's not a therapy, it is not a prophylactic vaccine, it's a therapeutic vaccine to treat the patients who have the chronic hepatitis B. And this is the nature of that vaccine, just one thing. And we use the nasal route because we found that by giving the vaccine with this drug through nasal route, we got the antibody in the vaginal mucosa in the mice experiment. So it can work in a broad place. This is one of our criteria. And second thing was this, if we can do something nasal, this can be given very easily in the developing country because we don't need the injection. So all these things have been done in our group, and this is one proof that it works. Then we did, so this is a sum of the clinical trials. Later I will not show much of this data. So we did a phase 1, phase 2, phase 3 clinical trial in Bangladesh with Professor Mamunul Mahataf as the principal investigator. And also the trial was done in Japan. In Bangladesh, the treatment was treatment-naive patients, those who did not get any therapy. And in Japan, the treatment was done in patients who got maybe the 1 to 20 years nucleoside analogs. And finally, we have started another therapy that I will be emphasizing later on. So just this is the data. So in the first phase 1, 2, we find it is safe. And also we found that it is able to reduce the HBV DNA and also the ALT. Then we did a phase 3 clinical trial with a direct comparison with the pegylated interferon. And with this, we have the 80 with the NASVAC and 80 patients with the pegylated interferon. and it has been published, so I'm just going quickly. If somebody like to see, we can show that. We found it is better than pegylated interferon, and it works better for reducing the HBV DNA and normalizing the ALT. Then this is the 2-year follow-up. This is also the disclosure of the 2-year follow-up. This is the 3-year follow-up data, and this is the 3-year follow-up explanation, and this is the 5-year follow-up data, and this is the explanation of the 5-year follow-up. So what we find? We find that 5 years after a single dose of NASVAC, we found about 75% patients had HBV DNA negativity and control of the ALT. Then we looked for the fibroscan data, fibrosis, and we found that the PEG interferon group, 11 patients developed progressive fibrosis or something like liver cirrhosis, where the NASVAC patient, only 2 patients have increased fibrosis but no cirrhosis. So this is our clinical trial in Bangladesh, and we have just going to do the 10-year follow-up, and after 10-year follow-up, we'll be pushing for entering this drug into the recommendations by different organizations. Then in Japan, we did the same thing, and it was found that in treatment-experienced patients, they can reduce HBs antigen, and these are also safe, and they also induce the anti-HBs. So all has been published, and you can find who are interested. Also, at the same time, we developed a device for giving the vaccine better way in the nose. And also another study was done in 14 countries, including Australia, New Zealand, Korea, Singapore, and we found it was safe. But about the surface antigen negativity, there are some questions, so the AVIVAX does not move forward about it. Now the most important thing. So it is a general belief that we cannot stop the nucleoside analog. If we once use it, we do it. So we started a clinical trial in which we stopped the nucleoside analogs. It is a small clinical trial. So in 30 patients, on the 15 patients, we give the nucleoside analog as it is, and in 15 patients, we stop the nucleoside analogs and give the NASVAC. The other group, the nucleoside analogs continue, and the NASVAC was given. And these data say there is no flare-up, as it has been told, by stopping the nucleoside analogs. When the NASVAC was given, there was no flare-up, and there was the ALT was normal, AST was normal, hepatic fibrosis remained unchanged, and this is the trial design. And Q surface antigen was not significantly altered, but not bad. And with this, now we are planning to do a big trial in which we like to enroll several hundred patients and stop the nucleoside analogs. So this is the one way we are going to show the nucleoside analogs can be stopped before it was told, but must be replaced by the immunotherapy like NASVAC. Well, next come to the hepatocellular carcinoma containment. So one thing, so Dr. Pradeep told me to do this thing, and actually what they are doing, the mass vaccinations and ultimately all these things will reduce the hepatocellular carcinoma by HBV. And in addition to this, there is the birthday vaccinations and others, so we hope that something will be done. Now, there is a small important point which we will be discussing here. So we know that there is a treatment, there is excision, ablation, radiation, chemotherapy, then targeting the cell cycle. So this has been given, or we know that the sorafenib has been given, and now the checkpoint inhibitor is given either as a monotherapy or as a combination therapy for treatment of the progressive hepatocellular carcinoma. This is my point, where I like to tell. So we give the checkpoint inhibitor. Why? Because then the immune exhaustion or immune suppression star will be overcome by the checkpoint inhibitor. So the PD-1 blockade, PD-L1 blockade, or the CTLA4 blockade will do this thing. And then who will be working, who will be killing the hepatocellular cell? The autologous T cells. Is the autologous T cells efficient enough to do this thing? When a cancer develops, is the immune system is working in this manner so that it can bypass this thing? No. Already their cells is very much exhaustive, and these T cells, B cells, NK cells, they are not effective to this thing. So if we give the immune checkpoint inhibitor, they can go. And second thing, whether they can pierce the capsule or not. So there is a big question, but we get a 3 months to 4 months survival benefit in the progressive cancer, hepatocellular carcinoma, and also other cancer. So we use this thing. But theoretically, cancer is a thing when there is the exhaustion of the T cell, disruption of the B cell, non-working of the antigen-presenting cell, and so the cancer progresses. Then we like to give the immune checkpoint inhibitor. So we are giving something in a tired horse. So what can be done under this situation? So this is the adaptive cell therapy system. So we just decided that we do a different thing. What we like to do? So first we took a mice, and we develop the colon cancer in the mice skin in the outside. Then we disrupt the cancer membrane by ethanol. After 48 hours, we give the tumor microenvironment to give the ethanol effect out, and then added the antigen-presenting dendritic cell over there to take the mutant antigen from the cancer in situ. And finally, we check everything and try to do this thing and get the result. So what we found, that if this is done, if we disrupt the cancer and if we give the dendritic cell, then the immunity is induced over there, and that immunity is enough to block the death from 9 days to 24 days. This is the animal experiment. With this data, we went to a patient. So this is a patient with the advanced hepatocellular carcinoma, and we just injected ethanol in the cancer nodule in Japan. This was done in Japan. And after 2 days, we gave the antigen-presenting dendritic cell from the same patient which was collected before 10 days. And this patient, according to Japanese criteria, was supposed to live 1 month, and ultimately the patient survived for 9 months. But we are not sure how much this work has been done, but this is the area which can be explored in our country, in our situation, and we can get a better immunotherapy, because the immunotherapy with the immune checkpoint inhibitor is just giving the exhausted cells to do something. And this is the something that we are making the immune reactive T cell, B cell in the cancer situ by disrupting the cancer nodule. So it have a very good chance, but actually we could not do this work completely, and this work has again been started, and we hope that this will do. Now the thing is this, two things actually what I told, that the antiviral drug is not evidence-based. And the second thing, the ICI, immune checkpoint inhibitor, only one immune therapy of the cancer I took part, is not validated, is not evidence-based. But the FDA has approved it, all the country has approved it. So as just show Professor Kaur, so this has been approved by ISL, INASL, and also the ASLD. And now we are trying to do something. So where are we standing? So one of the philosophers, so I just have a great respect for this man, Arthur, he told that all truth passes through 3 stages. First, it is ridiculated. Everybody tell it is a nonsense idea, it's stupid behavior. No need to spend time to hear these kinds of bloody substances. Second, when you give some evidences, then it is violently opposed. So somebody tell, no, this evidence is not correct, something like this goes. And finally, it is accepted as being self-evident. And at the end of the day, this at the end of the maybe 50 years, maybe 30 years, maybe 40 years, but we have provided a model, and we are going to register the drug for the hepatitis B. And hopefully we can bring this to the market next year. And about the cancer, we are opposing the use of the ICI as it is. For the time being, it's okay. But this is not the final tool and final goal. The final goal is to get something much cheaper and much evidence-based for the human being. So, like the truth, maybe we need some more date and more time to get this thing. And these are, so you can see from 70 to 2020, within 50 years, I am graying as it is so. And I've been done this work with the collaboration of Professor Mamun al-Mahtab, and the Cuban collaboration, the Japanese collaboration, and the Beacon Pharmaceutical also is trying to bring Nasdaq to Bangladesh and Toko, and France and Germany, and the France molecular laboratory we are now conducting to improve these things. So more and more clinical trials are needed, and hopefully we'll be discussing more. And we're also trying to do something in over here in Tripura. We discussed yesterday with the Tripura Medical College, and today with that is the Tripura University, and today with the Tripura Medical College. So maybe the combined effect can bring a truth which has been ridiculously unaccepted for the time being, but maybe will be brought to the reality in some time. And we have to do this thing because we like to eliminate, and we are poor countries. We cannot afford so much money for treating the patients on something like this. Thank you again for providing the opportunity to talk these things. Thank you.
Thank you, sir, for presenting to us this complex topic in a very simple way. And I wish you all the best for your research, and hopefully the treatment protocol suggested by you will be very widely available. Now I give time to the house for a single question from the house, if any. I believe everyone is clear, sir. Thank you, sir.
Thank you.
We thank our speaker for the wonderful presentation. I request Dr. Premashish Kaur and Dr. Sheikh Mohammad Fazli Akbar to please return to the stage for their felicitation by our chairpersons. Thank you, speakers. Now I call upon Dr. Sudhamshu Kesi to present upon the topic Hepatitis E, Current Strategy of Management and Prevention.
Hepatitis E is a very common disease otherwise, but less often thought of or diagnosed. To discuss this, we have Professor Dr. Sudhamshu Kesi, who is currently the President of Nepalese Association of Study of Liver at Kathmandu. Sir is also the consultant hepatologist at Norvik International Hospital. Over to sir.
Thank you for kind introduction, and thank you Pradipda and Tripura Foundation for this excellent opportunity, and also thank you for giving me this simple topic, because after two very grilling discussion and topic, now I'm going to talk about this hepatitis E, which is very common in our part of the world. So these are my talking points. This hepatitis E, it was recognized in early 1980s, and this is the disease caused by hepatitis E virus, which is found in both enveloped and non-enveloped form. And HEV is the leading cause of acute viral hepatitis in developing world, but now it has crossed the border, and it is also the disease of West also. Every year, an estimated 20 million people suffer from hepatitis E virus, and it causes around more than 3 million clinical cases and around 70,000 deaths every year. And overall burden of the disease is highest in the part of the world where there is lack of sanitation and bad hygiene. And this is true with the genotype 1 and 2 disease. This hepatitis E, as a sporadic disease, it has caused in more than 63 countries so far. And in half of these countries, there have been few outbreaks also. This virus is a member of Hepviridae family, and it has 4 known genotypes. 1 and 2 genotypes are found in humans, and 3 and 4 are found in mammalians. This virus is relatively stable in the environment, but it can be destroyed by heat and chlorination. In developing countries, we have hepatitis E virus, genotype 1 and 2, and in this part of the world, it is appearing in younger age group between 15 to 40 years of age, while genotype 3 and 4 in Western countries, it appears in later age group, and the mean age is usually 50 years. And this HIV-infected individual exhibit wide spectrum ranging from asymptomatic infection to acute hepatitis, to chronic hepatitis, and even acute liver failure and death. Now, this is the global distribution. So you can see that in our part of the world, genotype 1 is common. In China and Russia, this genotype 4 is common. And in South America and in this part of the Africa, genotype 1 is still common, and genotype 3 is common in European countries, America, and then Canada also. And in Japan, genotype 4 is common. So these are the basic difference between genotype 1 and 2 and then 3 and 4. So one is found in developing countries, and other is worldwide distribution and more in developed countries. And population affected is younger age group in 1 and 2, older age group in 3 and 4. Transmission is orophycal route in case of 1 and 2, and it is usually waterborne. And then in 3 and 4, there is sporadic cases, and transmission is by food and then also by blood transfusion also. In 1 and 2, there is more mortality in pregnant women, but in 3 and 4, it is not much noted. And chronic infection is not common in 1 and 2, but it is found in 3 and 4. And severity is higher in 1 and 2, and in 3 and 4 it is less. Mortality is not described in non-pregnant usually, and in case of genotype 3 and 4, mortality is high, and treatment is not still common in 1 and 2. Otherwise, this 3 and 4 has some medicine like interferon and ribavirin for the treatment. So now clinical presentation. So we can have acute hepatitis, chronic hepatitis, and this can also be discussed in hepatitis E in pregnancy, hepatitis E in chronic liver disease, and extrahepatic manifestations. So acute hepatitis is indistinguishable from other acute viral hepatitis like hepatitis A or even non-hepatotropic viral infection. The incubation period ranges from 15 to 60 days with mean of 40 days, and there is a variable presentation, like it may be asymptomatic, acute viral hepatitis, and then there may be icteric hepatitis, anicteric hepatitis, even finally it can present sometimes with acute liver failure also. So the common symptoms are icterus, malaise, and loss of appetite, fever, low grade, and they may have hepatomegaly, and occasionally they may present with pruritus that confuses us with surgical jaundice. And this interestingly, immunocompromised patients often have mild symptoms and lower ALT and bilirubin level in genotype 1 and 2 patient. And elderly individuals have a relative high risk of symptomatic disease and even ALF also. And in rare cases, acute hepatitis E progress to acute liver failure, which is more common in 1 and 2 than 3 and 4. Now, other spectrum is chronic hepatitis E. Unlike hepatitis B, it is called chronic hepatitis E when the virus persists for more than 3 months, and it is mostly found in genotype 3. And there has been one case report in which a child of child was found to be infected with genotype 4. And most of the patients with this chronic hepatitis E, unlike acute hepatitis E, are asymptomatic and have mild symptoms. And this chronic hepatitis E is found in solid organ recipient, but sometimes it can be found in non-immunocompetent patient, non-cancerous patient and immunocompetent patient also. And it has been also shown, this chronic hepatitis E has been shown in HIV infected people and patient infected with COVID-19. The precise mechanism by which there is chronicity is still unclear, and there may be absence of HEV-specific T-cell response in chronic hepatitis E patient leading to chronic infection. Severely immunocompromised case may progress to cirrhosis and even develop liver cancer. In a study by Liu et al. On 55 immunocompetent patients with chronic hepatitis C, they did not show the development of cirrhosis or hepatocellular carcinoma in a period of 4 to 15 years. Now there is some thing different in pregnancy. Compared to non-pregnant female, the virus is differently acting on pregnant women. So, but the exact mechanism is not known. There may be some virological factors like they have very high viral load. There may be some immunological factors like the change in CD4 to CD8 cells. There may be hormonal factors like high estrogen level and high levels of progesterone during pregnancy. And there may be other factors like nutritional status. So what they do is the clinical manifestation, they have high viremia, they have high fecal shedding of virus, and the jaundice is also very prominent. So the outcome is that there may be maternal death leading due to fulminant hepatic failure. There may be fetal mortality, and even stillbirth, miscarriage and neonatal death are common. And if they survive, they have low birth weight, and then they may lead to vertical transmission in fetus. So different study, they have shown that the attack rates are higher in pregnant women when they are compared to men or non-pregnant women. So we can see that the attack rate is always high in pregnant women. So in similar fashion, in 3 studies, they have shown that the pregnant women leading to acute liver failure is high compared to non-pregnant women. So we can summarize that in case of HIV infection in pregnancy, they have clinical manifestation and they can lead to liver failure and even death. The mortality rate among pregnant women infected with HIV can be as high as 20 to 30%. And study from India has shown that the mortality rate was as high as 58% in one of the study. Now, HIV infection in patient with underlying liver disease. In 2006, we observed that 6 cases of chronic hepatitis, this chronic liver disease after contracting hepatitis E infection, they had mortality in 50% of the cases. So we, in 2009, conducted a prospective study and then saw the effect of hepatitis E on chronic liver disease patient. The mortality was 28% and morbidity was high. That was evident by longer hospital stay. So in meta-analysis of HIV infection in chronic liver disease, it has shown that the condition is always exacerbated and they may lead to liver failure, which we now known as ACLF. And conversely, the CLD patient, in the case of CLD, the symptom of the acute hepatitis E may be much more compared to other one. So now moving to the extrahepatic manifestation, this hepatitis E not only causes disease of the liver, it can also causes central nervous system disease, myocarditis as in heart, pancreatitis, even in case of kidney, there may be kidney failure. So these are the extrahepatic attack by hepatitis E, but the mechanism is still not known, and it is thought that it is due to cytopathic tissue damage that causes all these problems. And in particular, this is there is more neuronal disease and renal disease, and it is followed by pancreatitis. So in one of the systematic review of extrahepatic manifestation, they have collected data of around 328 patients, and what they have seen, 324 cases, what they have seen is the neurological cases was around 55%, followed by cardiovascular 35%, and then gastrointestinal 7%. And other are the rarer manifestation presenting there. Now the diagnosis, historically this disease was diagnosed by electron microscopy and detection of virions in stool sample. Then it was followed by detection of HEV RNA in blood by RT-PCR. And then in latest and in clinical practice, it is diagnosed by using anti-HEV, IgM, IgG, and even IgA. This anti-HEV IgM is widely used all over the world, and among all other kits, the one-time kits from China, they are found to be more sensitive and specific, and it is used worldwide. Now, further development of diagnosis, the HEV antigen is a new kid in the block, and in one of the study by Zhang et al. In China, they showed that HEV antigen was found to be an early diagnostic marker compared to anti-HEV IgM, because this HEV antigen appeared earlier. Furthermore, 70% of HEV antigen positive sera had detectable HEV RNA. So it was also correlated with the amount of HEV RNA present in the blood. For second study was by Zhao et al., and they showed that role of HEV antigen detection in detecting active viremia in the patient. In the study, in a study by Misra et al., they showed that when HEV PCR was considered as gold standard, overall sensitivity, specificity, positive predictive value, negative predictive value was higher in HEV antigen when it was done by ELISA method. So in this study, you can see that this HEV antigen, it appears before anti-HEV IgM in high titer in both, these are stool and blood sample in genotype 1 as well as genotype 4. So in this another study, they found very good correlation with this HEV RNA and antigen, HEV antigen in, this is in stool sample and this is in blood sample. So this is going to be a new addition in the diagnosis of the hepatitis E. And Hepatology published an editorial that, and they claim that urine is a place where HEV cannot hide. And in one experiment in China, they found that HEV infection was also demonstrated in urine. So they injected the urine into the monkey, and they found that the kidney was affected, and they found that HEV antigen was found in the urine in good quantity. So in the days to come, this HEV antigen can be a good diagnostic tool, and it can be diagnosed by simply urine test. So now moving next to management and treatment. So who are the candidate that we are going to screen? So all those who present with the symptoms of acute hepatitis should be screened. Those with unexplained chronic liver disease, immunosuppressed candidate with persistent abnormal liver enzymes, they should be screened. Sometimes Guillain-Barré syndrome, viral encephalitis of unknown origin should be screened for hepatitis E, and the cases that need to be differentiated from other liver diseases such as hepatitis A, DILI, autoimmune disease where the diagnosis is unclear, they should be screened, and those with abnormal liver enzymes after blood transfusion should also be screened for HEV. So treatment of acute hepatitis E, it includes supportive care. No drugs so far are used by any society or any organization, but there has been some odd case reports where ribavirin treatment was used for severe acute hepatitis, and they showed promising result with rapid normalization of liver enzyme and decrease in HEV RNA in shorter period of time. So treatment, during treatment of acute hepatitis E, the patient needs admission if they have persistent vomiting and are not able to eat, elderly patient or patient with chronic liver disease, pregnant women especially in third trimester, and then those with symptoms of acute liver failure. Now treatment of HEV-induced liver failure, these are all on line with acute liver management of the acute liver failure. And in those cases of acute liver failure due to HEV, ribavirin has been used in some cases. Otherwise, for conventional treatment, use of steroids and N-acetylcysteine has also been tried with good results. Now, treatment of chronic hepatitis E, ribavirin is the mainstay of the treatment. It is used for 3 months, and those who recur even after use of ribavirin for 3 months, they are again retreated with ribavirin for 6 months. And then pegylated interferon is also used in few cases where they are non-responsive to ribavirin. These are used in case of liver transplantation patient, but not used in kidney transplant patient where there may be chance of rejection. Now this is the algorithm given by Easel. So if there is chronic HEV infection, first and foremost thing they advise is a reduction of immunosuppressant, because they found that if the level of tacrolimus was less, the HEV clearance was high. So the first thing to do is to reduce the immunosuppression. Then if there is no hepatitis E clearance, then ribavirin monotherapy is used. And once, if they relapse after cessation of ribavirin therapy, then the 6-month course is used. And then if there is, even after 6 months is not enough for the treatment, then PEG interferon was used in some selected cases. Now, there are some trials with other drugs also. There may be some medicine used for treatment of hepatitis E. These are all case report based. So there has been use of sofosbuvir and sofo-lady combination. Ritonavir that is used in HIV medication has also some effect on hepatitis E. And while going through treatment, I found a few case report, interesting case report that use azithromycin and zinc as the treatment of hepatitis E, but these are all anecdotal case reports only. Now final slides on prevention. So in prevention, we have prevention of acquiring infection, control of source of infection, disrupting the transmission, and protection against protection in susceptible population. So we know that this hepatitis E virus can be detected in stool in large amount. So the hand hygiene is the most important factor to prevent acquiring infection. So maintenance of hand hygiene, and then proper cooking of the food. As we know that this virus can be destroyed by heating water for 70 minutes. The virus can be totally destroyed. the heating and having cooked food is the best thing. And we know that there may be some sexual transmission, and those are the reported case in case of genotype 3 and 4. So avoiding unsafe sexual behavior is also one of the factors. And in case of genotype 3 and 4, it can also be prevented by screening before giving blood transfusion. Now, control source of infection. So we know that the sewerage and water supply, if they go together, there is high chances of getting infection during monsoon period. So that they should be controlled by government, not by us. And then isolation of the infected individual is very important to control the source of infection. And asymptomatic HEV carriers and individuals with viral hepatitis E have been identified in the most common transmission source. So they should be confined when they are identified in the community. And occurrence of asymptomatic HEV viremia due to HEV genotype during epidemiology, we have seen that there is, even though we don't have any endemic situation, there is occurrence of the disease is very high. So what we have proposed that there is dynamic human reservoir who, although are asymptomatic patient, they keep on shedding their virus in the stool and they can cause infection at the time when there is flood or monsoon season. Now, disrupting the transmission of pathway is the next. So we can enhance the water and sanitation management. We can increase our environmental hygiene, good personal hygiene, and take the cooked food only. So we have seen that there have been some endemic foodborne transmission in France and Japan. So selective screening strategies have been adopted in regions where there is relatively high risk of infusion transfusion. So there have been strategy to check the hepatitis E along with hepatitis B, C, and HIV. Now, protecting the susceptible population, this can be done by vaccination. So regarding vaccination, a study was done in Nepal in 2001 where they included 2,000 volunteers, and after 3 years of follow-up, at the end of 3 years, they found that efficacy of 3 doses of vaccine was as high as 95.5%. But unluckily, this vaccine didn't go to the production, and GSK was the pharma which was responsible. They took their hands off from the market. And next vaccine was developed in China in 2011, and they showed that efficacy of vaccine was around 97% in preventing episodes of symptomatic acute hepatitis. And though this is the vaccine which was tried in genotype 4, there's still some trials going on. Dr. Premashishkar just told me that he had some trials with this vaccine and he is yet to get the result. So now to summarize, HEV is a global disease with significant mortality and morbidity. It is not only the cause of liver disease, but it is also responsible from some extrahepatic diseases. It has high mortality in case of pregnant women, especially in third trimester, and those with chronic liver diseases. Various modalities are available for the diagnosis, and some are emerging like HEV antigen and urine test. Although a self-limiting disease, it may need treatment in chronic hepatitis setting. Prevention is better than cure. Effective vaccine is available, but not available worldwide. Thank you.
Thank you, sir, for a very comprehensive talk on hepatitis E. It was very much clear. Still, if there is any question, you can take only one because of constraint of paucity of time. If there are none, I request everyone to join a big hands for sir. Sir, please stay back.
We thank our speakers for their wonderful presentation and our respected chairman for moderating this session.
Chairperson very
We shall begin our next session. We shall begin our next session, the complications of liver disease. I call upon our chairpersons, Dr. Birato Debbarma and Dr. Shomoresh Pal. The first presentation in this session shall be renal dysfunction in chronic liver disease, presented by Dr. Akash Roy.
Yes, Dr. Akash Roy, who is a renowned hepatologist from Tripura, he'll be presenting on renal dysfunction in chronic liver disease. So I'd like to request Dr. Akash Roy to start the presentation.
Thank you, respected chairpersons. Thank you, Bhomik sir. It's always a pleasure to be back home. I can see some of my seniors in the audience. The talk that has been assigned to me is renal dysfunction and chronic liver disease. How many of us here in this hall manage patients with chronic liver disease who have renal dysfunction? Can I have a show of hands? Do we have any residents out here? Yeah, we have one resident. Okay. So do you manage patients with chronic liver disease and renal dysfunction, or you leave it to the nephrologist to manage it? You do manage it yourselves. Okay. So what I would try to do is to take you through perhaps the most difficult part of any patients with cirrhosis, which is when that patient has renal dysfunction. The problem is renal dysfunction in cirrhosis has somehow become equal to hepatorenal syndrome, vis-a-vis equal to terlipressin. My message to you, which I would like to convey at the end, would be not everything of AKI in cirrhosis is HRS, and not everybody of cirrhosis with AKI needs terlipressin. It's a very wide thing, and we'll try to understand it step by step. So there are three core concepts of renal dysfunction in cirrhosis that you need to understand and address. Number one is pattern recognition. Is it AKI, which is acute kidney injury? Is it acute kidney disease? Or is it CKD? If it is AKI, is it pre-renal? Is it HRS? Or is it ATN? How do you differentiate it? There is a second component of time, because you would like to volume expand these patients and then start some other medicines. And the last part is those medicines which might change the course of the natural history of the disease. This sort of summarizes the entire approach towards acute kidney injury or renal dysfunction in cirrhosis. So the agenda would be understanding the evolution of definition, because there's been a lot of chaos and a lot of changes in terminology, which makes it very complex to understand at first reading, but I'll try to simplify it. And then we go step by step to understand recognition, whether it was what the original descriptions are and what today we understand it, what the pathophysiology was originally described and how today we understand it. Why do we need to predict this renal dysfunction early? How do you differentiate? How is the management changing then and now? And lastly, when do you resort to the help of the nephrologist for initiating renal replacement therapy? So this is 45 to 46 years back, the initial description of what was called as hepatorenal syndrome, or that was the proposal at Sassari. I just want you to know certain key things, that there are some components. One is you have a renal insufficiency which is judged by creatinine. There is a tubular function which is remaining intact. That means your kidney tubules and your glomerulus as a unit is intact, and this is more something which is functional. And these do not improve after you give some volume by whatever means. You give normal saline or you give whatever other modalities. So three key concepts which I alluded to is that dysfunction, intact tubular system, non-response to volume. There were lots of additional criteria which got changed sequentially. Hepatology is more of a late bloomer, but parallelly, nephrology had started to progress. This is where the problems arise, and the problems arise because two societies were going parallelly promoting their own definitions. 1996 was the first proposed term of HRS1, where you had a creatinine value, and I want you to remember this very clearly, that you had to have a cutoff creatinine top value, that you had to reach 2.5 to define HRS.
if those who are in internal medicine, you would be remembering rifle. By that time, nephrology societies had already improved or brought about rifle. Then the IAC criteria got in some changes. The capping of serum creatinine remained, that you still needed to hit that 2.5, but you have brought in something called albumin, because by that time, the trials of albumin of improving renal dysfunction were already positive. In the meantime, KDIGO as a society became very active in nephrology, and they brought in the Akin criteria. Response, you go on to 2015, where again an International Ascites Club parameter or definition was proposed. What was the basic or most important difference? That now they included a baseline creatinine, they staged, but what remained till 2015 was you had to hit a top level of 2.5. So this is how the evolution happened. The societies finally converged and tried to bring unison. Before we jump on to hepatorenal syndrome, you need to define acute kidney injury. This is the definition of acute kidney injury. You need to have a rise in creatinine, which in the 48 hours period may be 0.3 or more, or if you do not have that time period, it's a 50% increase, that means doubling within of 50%. Next, you need to stage it. Simple, stage 1, stage 2, stage 3. Stage 1, when you have got 1.5 to 2 times. Stage 2, 2 to 3 times, more than 3 times. Stage 3, or your absolute value is 4 or more, or you go on to have dialysis. That's it. And then you decide progresses or regresses and elements of response to treatment. This is the definition of acute kidney injury, which is mandatory to be made before or after you make any other diagnosis. So that makes us clear with what is acute kidney injury. Then, as per this definition had aligned, so there was a change of the definition on what was hepatorenal syndrome. So you had to have acute kidney injury, which you see on the left-hand side, those same things, that you had to have an increase in creatinine, or it was a doubling. But since patients with cirrhosis usually tend to have a poor urine output, and the dipping of urine output is very important in patients with cirrhosis, you added in also a urine output criteria. That is your definition of AKI. Now, patients with cirrhosis are on diuretics, so you stop the diuretics. You give them IV albumin. How long? 48 hours. How much? 1 gram per kg body weight. These are arbitrary, not based upon very good randomized trials. Plus, you should not have those other things. Like you should not have a shock, you should not be on nephrotoxins, and you should not have overt parenchymal disease. How do you know that? You should not have significant proteinuria, RBCs, casts. Your sonography should be normal, that you should not have features of CKD, and if you have biomarkers, that is good enough. So this was the definition which came into force when I was a resident as HRS and HRS AKI, and there was subdivision HRS AKI and non-AKI. Now, can I show of a hands again, how many of your cirrhosis patients have underlying diabetes, with mast cell becoming the most common cause? Where I come from now, my most common etiology is mast cell, not alcohol. So it's 60% mast cell. Out of them, at least 40% have diabetes. Out of them, again, a huge chunk have diabetic kidney disease. So according to this definition, if they have a proteinuria of more than 500, they can never have HRS. So these are thoughts that went on. In the meantime, your kidney society developed further. What they brought in is a concept which is currently used in kidney disease called acute kidney disease. What that means is that they have now also segregated into two broad phenotypes. You have a normal kidney, you have AKD or acute kidney disease, which is up to 3 months, and you have CKD, which is anything beyond 3 months. In that AKD, if this happening of AKI happens within 7 days, you call it AKI. Beyond that, you call it AKD. This is how the kidney people had evolved of the last 2 years. So you want to bring them in again, both of them together. And this happened this year with what is the current definition or the proposed definition of HRS-AKI in 2024. You see that the rise in creatinine persists. You can use either the 50% or a 0.3. Urine output persists. The change starts now. You had a cutoff period of 48 hours that you had to use albumin. That has been brought down to 24 hours. And it comes with another analogy when clinically indicated. And we'll come to that later on in some way down the line. Plus, all those things that I said, that if somebody has diabetic kidney disease, somebody has other glomerular disease, they will never fit into the definition of HRS-AKI. That gets thrown out of the picture, which says that there has to be an absence of a strong evidence for an alternative cause for the current episode of AKI. You might have diabetic kidney disease in background, you might have CKD in background, you might have IgA nephropathy in the background, you might have anything in the background. You develop a AKI on top of it, which meets the criteria of HRS. They respond to vasoconstrictors. It is HRS-AKI on top of whatever it needs to be. This is just this year. There are challenges with this definition too, which we'll not discuss now. But the bottom line is the major changes are that cutoff is down for 7 days that I said, that AKI or AKD. 24 hours is down to 48, and those absolute criterias are gone. So this is how we define AKI or HRS-AKI as of today. Pattern recognition, as I said, which was classic and which is contemporary. Before I jump to any pattern recognition, as our resident friend is there, you must have seen both these patients. Somebody who comes to the ward, 10 ascites, creatinine is around 2, bilirubin around 1.3, no shock, he's moving around, just has come with an AKI. And when you go to your ICU, you would be having somebody who has moderate ascites, but his creatinine is 4, his bilirubin is 12, his sensorium is borderline, slipping on and off out of encephalopathy, and is barely maintaining. So are these two people same? No. But can both of these have HRS-AKI? Possibly yes. So this is again the conventional teaching of that liver disease can present, or kidney disease in liver can present as CKD. That was only 1%. This is way back. This is going to rocket off in current studies, but that's not our current course of discussion, so I'll not go there. Or ARF. And then you have pre-renal, out of which HRS is a part, or you might be volume depleted. Intrarenal and post-renal. So let's see how it performs in today's cohorts of patients with cirrhosis. So if you take patients without ACLF, we had a lot of discussion in the morning about ACLF. So without ACLF, that old teaching still holds good, because these are patients who come to the ward. You've got hypovolemia, the most common cause around 60%, dot matching the numbers from Dr. Belcher's study. ATN, hardly, because they are coming, they're not exposed to any nephrotoxic drugs, they are not having shock, they are in the ward. You've got HRS-AKI, another 1/3, and then you've got others. you straight away move ahead to this side, where your hypovolemia suddenly is down to 40%, your ATN rates rocket up to 13%, your HRS-AKI stays there, and there is a huge proportion which is others, and we'll come to what those others are. The phenotypes are different, and the patterns are also different. When in your ward, you have patients who have more stage 1. When you go to your ICU, you have stage 1 still predominant, but look at the increase in those with stage 2 and stage 3. So in the ward and in the ICU, the patterns are different. Pathophysiology. This is the classical thought process of AKI in cirrhosis pathophysiology. You've got cirrhosis, you've got portal hypertension, it leads to splanchnic vasodilatation, reduction of the EABV or effective arterial blood volume. You get your vasoconstrictors which gets activated. That leads to constriction of your renal arterioles, and ultimately you get HRS-AKI. This is what has been there, the teaching since MBBS days. This is the current concept, that you have got acute insults. You develop acute portal hypertension. Your heart is failing. You develop cirrhotic cardiomyopathy, which is contributing to your renal dysfunction. Your bilirubins are your 40s and 50s, which is causing toxin-induced ATI. Your bile casts, as well as inflammatory cytokines, which is causing injury. You've got a suddenly tense ascites, which is causing you abdominal hypertension, leading to abdominal compartment syndrome. So when you see a patient with AKI and cirrhosis in ward, the classical theory holds true. But when you've got a very sick patient, go back and think about all these parameters. You will have to think about toxin-induced, which are generated, bile casts, abdominal compartment, cirrhotic cardiomyopathy, and the entire picture together. Do we have to predict AKI? What's the use of predicting AKI? You need to predict AKI because if you catch them early, this shows that a small difference between stage 1A and stage 1B of the Akin criteria, if you have those patients with stage 1A, sequential need of renal replacement therapy is 0. If you even go a slight notch up, it can jump up to as high as 9%. The same happens with degree of AKI resolution and in-hospital survival. What does that mean is that you should be careful to even the slightest changes of serum creatinine, and cirrhotics are thin and lean. In that cases, a good monitoring of the urine output. But since both of them are difficult, there are markers, and cystatin C is one of those markers. When a patient has not come with AKI, you're not treating AKI, but if its baseline value are higher, you might have been that patient to have a higher chance to develop an in-hospital or subsequent AKI. But these markers of nephrology, cystatin C, has been there in textbooks and in trials for at least the last 15 years. But somehow it never gets translated into practice. So what you need to focus into clinical parameters, because you will not have cystatin C at your bedside in most of the places. So you look at the patient carefully. Did this patient have a previous episode of AKI? Go through the charts. Is his bilirubin very high? Is he having dyselectrolytemia? For some odd reasons, even without a bleed or with a bleed, is his urea too high? Does his drug list give any indication to any nephrotoxic agents? Is this patient having SIRS as our morning patient was having? Does he have other failures like a circulatory failures? If he has any one of these, be sure somewhere during the course of his hospitalization, he is going to have a renal issue, and you have to be very careful about it. We said that pattern recognition is important. How do you differentiate the patterns? There are some ways to do it. Let's take it one by one clinically. If you have somebody who comes to you with shock, your chances of it being ATN is more. That doesn't mean that HRS-AKI or hypovolemia may not be there. Somebody may be hypovolemic, he can still come to you with shock. But the association is more with ATN. If somebody is on definitive nephrotoxins, definite ATN. Ascites, as we were discussing in the morning again, that if you don't have significant ascites, your diagnosis of HRS-AKI should be highly questioned, because it's a disease which doesn't start just like that. That has to be a hemodynamic circulatory response which will trigger those pathophysiologies. IV albumin response, if it improves, it was always hypovolemia. For our HRS and ATN, it should not improve by itself with IV albumin. Urine sodium, classic teachings again, ATN, it is greater than 20. FENA, it would be less in everybody, but in cases of HRS-AKI, your avidity for retaining sodium is much more. And NGAL is another marker, we'll come to it again, which if it is high, is very predictive of the patient having ATN. But I've put a disclaimer out there that this is not an all or none law. Somebody with HRS can show phenotypes of ATN. Somebody with hypovolemia can progress to ATN if you're not correcting their shock. And somebody with ATN itself can develop a superimposed HRS physiology. This is something whose art is gone down. Urine analysis is something which should be the first test that you order when you've got anybody with AKI. It gives you an idea about casts, whether it's granular or bland. It gives up ideas of infections. It gives up your ideas of proteinuria. But most importantly, in patients with ACLF, it gives you whether there are bile casts. And this is a specific entity which is called bile cast nephropathy or cholemic nephropathy, very difficult to treat, associated with worse mortality if they are combined with ATN. So whenever you have any patient with AKI, the first test that you order besides your creatinine is a urine RM. But talk to your pathologist or your lab person that what are you looking at. If you don't tell them that this is what I want to look at, they would not be very interested to giving you back those comments. It's a bedside test, takes hardly any time, but you have to prime your paraclinical and non-clinical departments to be attuned to what you're looking at. NGAL, as I said, if you have NGAL which is high, it's a very, very good marker to diagnose ATN. But in majority centers, you will not be using NGAL as an everyday marker. We move on. Management from classic to contemporary. This is the classic management of any AKI. As I've already mentioned, you hold diuretics, you give albumin, you wait for response according to the criteria that had showed early in the chart for AKI. If it responds, it's not HRS, you give vasoconstrictors and assess response. This is the way the teaching has been, and the vasoconstrictor for choice has always been terlipressin. How do you give terlipressin? There are still centers which use terlipressin as bolus doses. As of today, across guidelines, the recommendation is to use an infusion of terlipressin over 24 hours, which has been found not to be more effective, but more safe and maintain greater AUCs in these patients. You look for response again as per those criteria, and you escalate the dose if there is a less than 25% decline at 48 hours. And then you see that whether it's responding. If there is no response, you stop your terlipressin then and there itself because it's going to cause you more harm. Are there alternatives to terlipressin? There are major parts of the world, including United States, before this year did not have terlipressin. So for them, they had octreotide and midodrine. For India, most of you have access to octreotide plus to terlipressin, but if you've got a patient who you know has got a known contraindication to terlipressin, say somebody who is a cirrhotic and also has a coronary artery disease, somebody who has cirrhosis and has got peripheral arterial disease, these are patients you're not going to ever start them on terlipressin. For them, your best bet next choice is octreotide plus midodrine, 7.5 milligram 3 times daily, plus an octreotide at 50 microgram per hour. And then you can convert it to Q8 hourly. Is there another alternative? Yes, noradrenaline, more easily available, cheaper. This trial comes out from PGI Chandigarh, where it was shown that if you don't have, these two can be equally effective. But this is the only trial which has shown this. There has been subsequent trials which have said that NORAD is inferior to terlipressin, specifically if the patient has ACLF. So if you don't have access, you can use NORAD. If you've got contraindications, all that you can use would be your octreotide plus midodrine. We saw a change in the definition of AKI, that 48 hours had come down to 24 hours. You did not wait for those 48 hours to be waited at. Based upon that, this is ILBS study where they did not even wait 24 hours. They gave volume resuscitation for 12 hours. If you respond, you continue on resuscitation. If you don't respond, you add in terlipressin at that moment. This was presented at ASLD 2 years back, recently published paper, positive trial, but the only trial. In a similar way, what we looked at is the use of point-of-care ultrasound. As of today, all medicine units should be very, very well versed in point-of-care ultrasound. At least abdominal ultrasounds, bedside echo. I think COVID has made the access to ultrasounds very, very easy. Most places have extra supplies of ultrasounds now. So at least 3 things should be must in any training program. Normal liver ultrasound or abdominal scan, a baseline echo, and a lung ultrasound to check at lung parameters. This is done using IVC diameter and IVC collapsibility. When a patient comes to you, do you expect that when he's coming to a tertiary hospital that he'll still be volume depleted? Hardly. He must have been cared for in some center where they would have loaded him with volume, given FFPs, because everybody with cirrhosis sort of gets an FFP at the beginning, even if the INR is 1.3. So, and then he comes to you, and then you want to wait for more 48 hours to load him, and then wait for the response. Makes no sense. So use point-of-care ultrasound, simple things like IVC diameters and IVC collapsibility. You don't need to be a critical care expert for it. This is YouTube learning where everybody can learn. And if you find them that these are available at your bedside and you see that it is volume replete, start terlipressin at that time. So this is the evolving concept that you can use terlipressin early and you can use it based on point of care ultrasound. But terlipressin comes with some baggages. It has got side effects. Cardiorespiratory, embarrassment, specifically when you're using with albumin. Which patients have it more? When you have got more advanced grades of ACLF. In USA, even today, ACLF3 contraindication for use of terlipressin. So if you've got somebody with the 15 bilirubin already hypoxic, about to go on a ventilator, gasping for humping and pumping for breath, grade 3 hepatic encephalopathy, you need to look at other modalities beyond the terlipressin, or you need to be very, very cautious while using them. Why is it important? Because you need to predict response. We had seen how do you predict other parameters. Similarly, you need to predict responses. The higher the grade of ACLF, the lesser the response of terlipressin. Or, in simpler words, the more your degree of organ failures, the less your response to terlipressin. And if you've got anybody who is ACLF 3 and no delta change of your creatinine in 2 days, you can expect that this person is not going to respond to terlipressin. Think about the other modalities or your next step. So what is the next step? Your next step is dialysis. If you see data of dialysis, whether you bring it early, because you would consider early because liver disease patients who have got AKI are very, very sick. You would consider early, otherwise by the time your conventional time of dialysis comes, they would have already died. So this is 2023 NEJM trial which compared early versus late dialysis over general people. Found no differences, but more adverse events when you do it early. The classical criteria is potassium more than 6, pH less than 7.2, bicarbs less than 12, volume overload, respiratory failure, or an AKI which is persistent for more than 72 hours. The problem with this is a large trial, but it has very small fraction of patients with liver disease. To sort this out, ILBS has given some data. This is ASLD last year, where they've put these patients on CRRT and tried to find out who are the responders and who are the non-responders. The non-responders are the usually who have got very massive ATNs. But if you respond, then you tend to do good. But if you delay, every hour of delay, what they found was associated with at least a 7% increased risk of mortality. This hasn't come out in the press yet. We don't know what the final results are, but there is a thought process that specifically in patients with liver disease, because there are associated too many things, you might have a window by using dialysis early than what the standard criteria is. What happens to this group of patients otherwise? This is what happens to these patients who are very, very sick. Because if you put them onto standard RRT, 3/4 of them will never survive. And even if they survive, a very small fraction of them will go home with a good functioning kidney. So if you don't have the facilities or you don't have the resources, then if you find these patients who have got more than 5 organ failures at any point of time receiving dialysis or being candidates for dialysis, their mortality, and they have no options for transplant or anything else, they're 100% going to die. So it's more important to discuss goals of care and how to cut down on interventions on such patients, because that each day of stay escalates healthcare expenditure. I summarize the evolving paradigm of AKI and HRS. On the right, you have before AKI develops, keep a very, very close focus on development. Look at the urine output. Look at that PRO thing I said of SIRS, bilirubin, all of that, and biomarkers if you have. If you have AKI and cirrhosis, define them first, whether it is HRS, whether it is ATN, and stage the disease, whether it's stage 1, stage 2, stage 3 AKI based upon AKIN. Try to identify that does this look like a possible HRS physiology. I'm using the term physiology because you might not be always able to be sure that that is HRS because of the overlap. If it is so, use terlipressin early. The things that you have to use is your clinical sense, your patient as a whole, simple urine examination, and what's must is a POCUS or a point of care ultrasound to look at the hemodynamics. If there is no response to terlipressin, you can opt for renal support. How early? We don't know. What are the predictors of response? We don't know yet. Use renal replacement therapy as primarily a bridge to transplant. If there are no options and the patient is not improving, consider futility of care and discuss goals of care. On the left is what AKI in HRS was thought as. Black and white. All AKI is HRS, give terlipressin and forget about it. It's not the same. It's a wide canvas with multiple shades. It's like making a house step by step, where if you go wrong in one of those steps, that house is sure to crumble. Thank you everybody for your patient hearing.
Well, thank you, Dr. Akash, for this excellent presentation. Now this house is open for questions. Well, if there is no questions, then we'll move on to the next session.
Thank you, sir, for such a wonderful session. May I have a big round of applause for our respected speaker. We'd like to take this opportunity to felicitate our respected speaker. May I request our respected chairperson to kindly felicitate our speaker. May I have a big round of applause. Our next speaker is Dr. Jyotirmoy Pal. He will speak on the topic Interpretation of Liver Function Test. May I request respected Jyotirmoy Pal sir to kindly come up to the podium. Thank you.
So there is slight changes in the schedule. Jyotirmoy Pal sir will be presenting on interpretation of liver function tests.
Good afternoon, Chairperson, all the delegates, students. First, I am very much thankful to Dr. Bhaumik and his organization for inviting me. While discussing this topic, Dr. Bhaumik asked me, Dada, you talk some issue that is more relevant to bedside. Then I thought, apart from hemoglobin, TCDC, ASR and sugar, one of the most common test that the physicians and even the practitioners have to interpret, that is the liver function test. But liver function test is a big basket. So we will concentrate only on what is popularly called the LFT, on those issues. And I will discuss, I will not take 30 minutes, I am in hurry to go to airport, but 15 minutes in brief, as simple as possible, I try to explain. Basically this presentation is for the students. Liver is the largest gland in the body, both endocrine and exocrine, also have capacity for or function for metabolism of different nutrient. Coming to the microstructure, basically this is a central vein and portal triad. So there is a communication, is a sinusoid, beside two sides there is the hepatocytes, and there is a biliary canaliculi. So there is a blood flow between this sinusoid and bile that is produced, that is passed to the biliary canaliculi and ultimately reach to the circulation. Okay, and blood is go from the central vein to the hepatic vein, then IBC, and through biliary canaliculi it passes to the bile duct, then come to the intestine. This is a very simple issue of the hepatic microstructure, but this is not the today's issue. Today's issue is what the interpretation, the common test, what we do and how we will interpret. The function of the hepatocytes is, one is the exocrine function, gluconeogenesis, detoxification, deamination, storage of different glycogen, lipid, iron, metabolism, particularly the carbohydrate metabolism, protein synthesis, regulation of the cholesterol and regulation of the lipid level, immune function, detoxification of the anemia, vitamin storage and exocrine. So liver is the huge activity in our body. So when you are getting the deranged liver function test, you have to assess which of the function is deranged, whether all function or a particular function. That you have to assess from a deranged liver function test. So the popular liver function test consists the bilirubin, alanine transaminase, that is the ALT, aspartate transaminase, AST, alkaline phosphatase, ALP, GGT, LDH, albumin, PTINR. This is the common component of liver function test that we receive. Among these, all the component, remember these two is basically for the synthetic function. It is the albumin and PTINR. Others are basically present, enzyme present within the hepatocyte. So if there is a hepatocyte injury, these components from the intracellularly, it come out and we will get higher level in our blood. So function is basically these two parameters, they assess the synthetic function of the liver. Others assess basically the injury. So we are coming to these three enzymes. Alanine transaminase, aspartate transaminase. We are coming to these first 2 points. So this is the hepatocyte. The AST, aspartate transaminase, basically present in 2 places, in cytoplasm and mitochondria. And ALT is present in the cytoplasm. This is the basic. These 2 aminotransfers, that means they transfer the amine from one enzyme to other and catalyze the interconversion of amino acid to keto acid. This is the function of the two enzymes, one present both in mitochondria and cytoplasm, another present only in the cytoplasm. So this is the function of the 2 liver enzymes. They basically act as a catalyst and interconversion of pyruvate glutamate to keto product, ketoglutarate with alanine or aspartate. So basically this reaction is basically required for the energy production or within the mitochondria. Other is different metabolism of the amino acid to formation of the protein, formation of the glycogen within the cell. So energy production and formation of the glycogen and different protein from the amino acid, these 2 enzyme aminotransferase is required that is present within the cytoplasm. So these 2 enzymes basically involved in the metabolism of the hepatocyte. So we are coming to the alanine transaminase. Basically this enzyme is present mostly in the liver, in body, in other tissues also present such as heart, renal, muscle, but concentration is very low. So that is why ALT, if it is elevated, practically it is considered that the liver is damaged. There is hepatocellular injury. So if there is hepatocellular injury, these enzymes will come out from the cell and you will get the elevated blood level. So basically in other tissue concentration is very low. Basically I told before this enzyme is required for the energy production. And normal range of ALT is traditionally considered between 29 to 33 in case of male and 19 to 25 in case of female. But using this cutoff point, it has been shown that many of the chronic diseases are missed. That is why now it is considered that lower cutoff value, below 30 or below 29 for the male and below 19 for the female, increase the sensitivity to detect the many chronic diseases like chronic hepatitis B, chronic hepatitis C, NASH, this and so. So now below 30 for male and below 19 for the female is considered the cutoff value for ALT. And one point you remember, when you were getting the different LFT review, you remember sometimes you get that LFT from the normal is slightly 10 or 5 international unit is elevated, maybe 40, 45 or 50. This does not indicate always the liver disease, because this ALT release from the hepatocyte is vary from different time to time. Also the high cholesterol, aging, these also influence the release of ALT, the normal release. There is some normal release of ALT from hepatocyte to blood. If there is injury, there will be more release. So that is why when you are getting the ALT elevated, you have to interpret cautiously. When we will consider pathological, when we will consider physiological, we will come later on. Now we are coming to the AST, aspartate transaminase. Again, this enzyme present abundant in the liver, but at the same time also present in other tissues like muscle, cardiac muscle, renal tissue, brain, in other tissues also present. And their concentration is not so as minimum as ALT. That is why AST is less specific in diagnosing liver disease than ALT, because ALT in other tissue very minimum concentration found, but AST comfortably in higher concentration found in other tissues. Here also AST facilitates the amino acid metabolism and very much involved in the energy production because it is found within the mitochondria, and normal range is considered below 35. So this is about the AST. So raised ALT and AST level, if we come to the summarize, basically it is a marker of hepatocellular injury, whether due to the virus, whether due to the liver cirrhosis, whether due to the drugs, toxin, malignancy, whatever may be. If there is a hepatocellular injury, the enzymes present within the hepatocyte will come out and we will get the elevated level of AST and ALT. Now third enzyme we are coming to the alkaline phosphatase. Alkaline phosphatase basically required for different dephosphorylating reaction, and mostly it is found in the hepatobiliary tract and also found in bone and placenta. So that is why not only the hepatobiliary disease, if there is a disease of the bones, the ALP level will be elevated. So ALP level mostly found in liver and bone. So in both disease, it is found obstructive biliary disease and bone disease level is elevated. Normal range is considered 30 to 120. So how we will differentiate whether liver disease or bone disease will come later on. But one point to remember, in childhood, children, the cutoff value is higher because there is more osteoblastic activity. So normal cutoff value is always higher in the children and adolescents. So now will come the issue how we will differentiate the ALP elevated is due to bone disease or due to the liver disease. This is the GGT. GGT is the enzyme. It is found in the different organs of the body and involved in the glutathione metabolism. But GGT is not found in the bone. So in a patient, if there is ALP is elevated, at the same time GGT is elevated, that means origin is the liver, hepatobiliary tract. If the GGT is normal, ALP is elevated, that means it may be from the bone disease, not a liver disease. So if there is liver disease, simultaneously GGT will be elevated. So simultaneous estimation of alkaline phosphatase and GGT can help you differentiating whether the origin is the liver or origin is from the bone. Here also cutoff value is considered 0 to 30, but again remember in the infant the level is cutoff, upper level of cutoff value is very high. And also remember GGT very much used in the alcohol abuse. Even in the patient, if there is a heavy drinker, alcohol abuse, there may be other enzyme normal, but GGT may be only isolated, may be elevated. So GGT is a very important enzyme that can help you the disease whether in the bone or in the liver. Now coming to the LDH. LDH is a more non-specific enzyme, and 5 isomer is present and is present in different organ, maybe from muscle, heart muscle, skeletal muscle, different organ is present. So LDH elevation not very specific that the disease is from the liver, and particularly only the LDH1 is primarily excreted taken by the Kupffer cell. So if you estimate the subtypes, then only you can differentiate, but this is not easily available and not very specific or sensitive. So subtype estimation is not advisable. So liver injury, anyhow, liver injury and liver disease can cause the elevation of LDH, and it is a more non-specific marker for the liver injury. And normal range is between 140 to 280. Normal range is considered. Next coming to bilirubin, very common parameter, that is open C. Bilirubin is closely linked to the liver's conjugation capability and excretory function. Bilirubin is basically end product of the heme breakdown and initially bound to the albumin. Then in the liver it is conjugated and excreted in the bile. I am not coming to the details. The heme, there is unconjugated bilirubin bound with the albumin. Then it entered to the liver. From the liver it is conjugated. Then come to the bile. In bile it is converted to urobilinogen, then sarcobilinogen, and passes with the stool, causes the yellow color. Something is reabsorbed and excreted as a urobilin. So this is the bilirubin cycle. How from the heme bilirubin is formed. Not going to the details. So, but raised level of bilirubin in the blood can be due to the three reasons. One is the prehepatic, that means excess bilirubin production. One is the breakdown of the bilirubin metabolism because it is conjugated. If there is a damage of the hepatocellular hepatocyte, the uptake of the albumin of bilirubin unconjugated complex will not be there. So there will be accumulation of the bilirubin with the blood. So that is called hepatocellular jaundice. Third, the cholestatic. Conjugation is there, but the outflow is obstructed. So there is called cholestatic jaundice. So raised bilirubin can be due to the three reasons. So here it can be direct hyperbilirubinemia due to the defect of the exocrine defect, either obstruction in the biliary tract or cholestasis like the Rotor or Dubin-Johnson syndrome, or indirect hyperbilirubinemia, there is excess production like hemolysis or inadequate uptake due to the lack of receptor in the Gilbert syndrome or intrinsic liver injury. Or it can be due to isolated bilirubin rise without any LFT derangement. Third condition usually we get in the prehepatic jaundice like the hemolytic anemia and Gilbert disease. Here the other enzyme is normal because hepatocyte is normal. There is no injury to the hepatocyte. But there is a isolated bilirubin is elevated. It can be due to the hemolytic jaundice or Gilbert disease. Fifth, I am coming to the albumin. Albumin is one of the major protein in our blood and comprises almost 50 to 60% of our total protein in the serum. Albumin synthesis occurs in the liver. So this is basically considered a marker of the liver synthetic function. But remember, not all in the chronic liver disease or acute liver disease, there are other causes in which there may be albumin may be depleted. So stamping, if you get the hypoalbuminemia, before stamping that it is due to the liver disease, you have to exclude the other diseases like systemic inflammation. It is a negative inflammatory marker, protein energy malnutrition, nephrotic syndrome, protein losing enteropathy. You have to exclude the other causes that can cause the hypoalbuminemia. Normal range is 3.5 to 5 gram per DL. But here there is a clue. I have to remember that half-life is 20 days. So if there is a acute liver disease, immediately protein level may be normal because the albumin that is already produced, that is circulating for next 20 days. So basically decreased albumin is a better indicator of the chronic liver disease rather than acute liver disease. Next, number 6, we are coming to the PT-INR. Because liver produce so many clotting factors, so PT-INR basically reflect the coagulation cascade, particularly the extrinsic pathway. And these are the coagulation factors that are produced by the liver. So basically in the liver disease, there will be deficiency or prolongation of the extrinsic pathway. That is reflected in the PT, not the intrinsic pathway, because the APTT will not be prolonged because factor 8 is also produced by the other organ, multiple organ in the body. So even if there is a liver damage, factor 8 will be produced for the other part, and APTT that indicate basically reflect the intrinsic pathway, that timing will be preserved. So that is why in liver disease it is the extrinsic pathway that is deranged, or there is a prolongation of the PT-INR, not the APTT. And another point you have to remember that in case of cirrhosis of the liver, there is a prolongation of PT-INR, but it cannot accurately predict the bleeding risk because P-time do not consider the anticoagulant activity. Only it considers the procoagulant activity. So anticoagulant activity, as it is not considered by the PT-INR, and also cirrhosis can cause thrombocytopenia. So bleeding risk cannot be predicted, but PT-INR will be definitely prolonged prolonged in case of cirrhosis of liver. But remember, at least 80% production to be diminished before the PT-INR prolongation. So this is the one important message you have to keep in mind. So what we have discussed in chronic liver disease or acute liver disease, ALT and AST, suppose patient has a acute viral hepatitis, ALT, AST is very high, maybe 1000, 2000, 5000, suddenly it has come to the normal range. So two situations can happen. Either patient is improving or it can be a bad prognostic sign, because as there is all the hepatocytes is lost. So there is no liver enzyme. So two situations can happen if there is a sudden decrease of liver enzyme in a acute or chronic liver disease, particularly the acute liver disease. Either patient is recovering or patient has a very bad prognosis. Liver tissue is totally damaged. So now the interpretation of the LFT. Interpretation is the marker of the liver injury is the ALT and AST, marker of the cholestasis is the ALP, marker of the synthetic function, albumin prothrombin type, and marker of metabolism and excretion, this is the bilirubin. So this is the function that we assess from the LFT report. Now I am going very fast. AST is basically assessed along with ALT for monitoring of the liver damage. Normal ratio is 1:1. But as a rough guide, AST is more than ALT. If there is more chance of having the cirrhosis, alcoholic hepatitis. But if the ALT is more than AST, more chance of drug-induced hepatitis or viral hepatitis or chronic hepatitis. That means acute hepatitis, AST will be more than ALT, but chronic hepatitis, ALT will be more than AST. So pattern recognition, you have to pattern either hepatocellular or cholestatic. Two pattern you have to discuss. So there is one R value. So ALT divided by upper limit of ALT divided by ALP plus divided by, not plus, upper limit of ALP. So if there is more than 5, it is the hepatocellular pattern, 2 to 5, mixed pattern, less than 2, cholestatic pattern. So from the LFT, you have to differentiate whether hepatocellular or cholestatic. So pattern usually, not very absolute. If there is 10-fold increase of the ALT and less than 3-fold increase of the ALP, alkaline phosphatase, chances more the hepatocellular injury. So different way, there are different way, R value, this rough guideline, you can differentiate that whether it is hepatocellular or cholestasis. Opposite, less than 10-fold increase of the ALT and more than 3-fold increase of ALP suggests the cholestasis jaundice. Regarding hepatocellular pattern, usually ALT and AST is more disproportionately elevated than ALP and GGT. If there is 2 to 5 times elevation, it is considered mild, 5 to 15 times moderate, and more than 15 times is the severe. In hepatocellular pattern, this is first line is very important. Remember, in the alcoholic liver disease, always AST is greater than ALT because alcohol causes damage to the mitochondria. And in the beginning I told AST is basically found in both mitochondria and cytoplasm. That is why in alcoholic disease, AST is more released because mitochondria is injured. So AST-ALT ratio will be more than 2. Also in alcoholic liver disease, alcohol causes less pyridoxine supply to the body, not properly absorbed, and for ALT production pyridoxine is required. That is why in alcoholic liver disease ALT never exceed 300 to 500. If you alcoholic liver, you suspect the alcoholic liver disease and you found the ALT is more than 500, you think it may not be alcoholic liver disease, there may be possibly there is any other disease. Mild elevation usually found in the following disease: CLD, NASH, drug, and moderate to severe elevation found in infection, ischemia, and drug. Cholestatic pattern, basically we get the both in hepatobiliary and bone, and how we will differentiate with the help of GGT I explained before. So cholestatic pattern you have to suspect, you will get both ALP and GGT more elevated than the AST and ALT. So I am not, time is short, not coming. So now very brief coming condition to the abnormal liver function. So we are coming to the one is the NFLD, here liver enzyme will be normal, but NASH is basically fatty inflammation of the liver with inflammation. That is why we get ALT, AST elevation in case of NASH, but not in case of NFLD. Chronic viral hepatitis, we usually get the mild ALT and AST elevated, but acute viral hepatitis we get moderate to severe elevation of the enzyme. In chronic viral hepatitis, if AST is more than ALT, there is a chance of viral hepatitis without cirrhosis. But if the AST is more than ALT, it is with cirrhosis. And AST is less than ALT, it will be without liver cirrhosis. Ischemic hepatitis, here AST basically exceeds the ALT because AST is more present in the zone 3 of the liver parenchyma, and ischemia happens more in the zone 3. So AST-ALT ratio is more than 1, more suggestive of the ischemic hepatitis. Drugs, acetaminophen, paracetamol is the most common offending agent, and moderate to severe elevation of the all enzymes can happen. Though bilirubin ALP also may rise, but more elevation happens due to the AST and ALT. Acute liver failure, severe elevation of the aminotransferase, also bilirubin and ALP and INR, and decline of the liver enzyme can be due to either recovery or worsening of the liver function. Last time coming to this flowchart, abnormal LFT, first you confirm the report, the abnormal LFT is there, bilirubin is deranged, SGBT is deranged, ALT deranged, AST deranged, whatever may be some of the parameters are deranged. You exclude the alcohol, OCP intake, drug, herbal medication. If AST and ALT is elevated, think of the hepatocellular pattern and screen for the infectious and autoimmune diseases. If you do not get an infection autoimmune pattern, then you think of the genetic, exclude the genetic and metabolic diseases, and send the suggestive investigation, serology and imaging. Even if now serology and imaging is normal, but ALP is persistently elevated, ALP, AST, ALT, whatever may be the enzyme, then you go for the liver biopsy. And other side, if you get the ALP is elevated, you estimate the GGT. If GGT is elevated, it is a hepatobiliary origin. If GGT is normal, bone origin. And give the best practice of medicine for the patients. So in conclusion, elevation of liver enzymes is very common element encountered by the physicians. Similar enzymes can also be elevated in other non-hepatic diseases. Pattern recognition is very important for even for any internist, any house surgeon, student, practitioner, and proper differential diagnosis only can help you in planning the future investigation and management. Finally, I welcome all in Epicon 2025 in January 23rd to 26th. Thank you.
Thank you, sir, for enlightening us on LFT in depth. Since sir is watching his words repeatedly during his speech, so I think no question can be taken from the house. Let's help sir to be on time for the airport. Thank you, sir.
Thank you, sir, for such a wonderful session. We would like to take this opportunity to felicitate our respected speaker. May I request our respected chairperson to kindly felicitate our speaker. We also like to request Dr. D.P. Chakraborty sir and Dr. Sagar Somrat Debbarma sir to kindly come up to the stage and felicitate our respected chairpersons. We'd like to request our respected president, Dr. Renal sir, to kindly come up to the stage and felicitate Dr. D.P. Chakraborty sir and Dr. Sagar Somrat Debbarma.
Well, let's move to the next session of the day. The session is named as Community Hepatology. In this session, the moderator would be Dr. Arunabha Das Gupta sir, Dr. Shoma Shaha ma'am, and Dr. Sanjay and sir. The first speaker for this session would be Dr. Dinesh Jyothimani. He would be talking on the topic Management of Large Volume Ascites.
So let me invite Dr. Dinesh Jyothimani, and he will be speaking on a very important topic, and that is on management of large volume ascites. Sir, please go ahead.
Thank you.
And he's the director of hepatology from Dr. Rela Institute and Medical Center from Chennai. Sorry.
Thanks very much. Yeah, no issues. First of all, thank you for inviting me to this wonderful meeting, actually. So ascites is always challenging to manage for gastroenterologists, hepatologists. So here we're going to talk about what is large volume ascites, how do we define them, and how do we manage them, because not all ascites are the same, even in liver disease. So ascites defines hepatic decompensation. So somebody who with liver cirrhosis develops ascites, that means that they are not going to live longer. Very simple. The development of ascites is associated with very poor prognosis, with a mortality close to 40% in 1 year, and the 5-year survival reduces to 30%. So ascites is a hallmark of liver decompensation. Now, how do we define that as a clinician? You can talk about grade 1, grade 2, grade 3, but here this talk is about large volume ascites. So here we're going to focus only on gross ascites. I would like to say different guidelines say gross ascites equate to refractory ascites, but not necessarily true. Gross ascites can be different. I'll tell you why. So first of all, the large volume ascites or gross ascites, what we see in patients, the guidelines define as refractory ascites, but there are a cohort of patients who can be diuretic responsive in that group. So therefore, large volume ascites doesn't equate to refractory ascites. There can be patients with diuretic responsiveness within them. So why ascites becomes large volume? Why ascites doesn't respond to treatment? There are various factors you should take into consideration. The common things are non-compliance with diet. So we put patients on salt-restricted diet. So in contrary to what you say, they may be taking normal or increased dietary salt. So it's a non-compliance to dietary restriction. Dietary salt is very important cause of increasing ascites. The second cause is not tolerating the treatment what you're giving. So that means not tolerating diuretics. So that is diuretic intolerant ascites. So patients may develop side effects. This is a known entity. They may develop cramps, electrolyte imbalance, renal dysfunction. The third is the liver disease progression, where they develop diuretic resistance. So you may use high dose of diuretics, but they may not respond. If you look at it here, they are all different. They are not the same. You have one non-compliance with dietary salt, one not tolerating diuretics, one not tolerate liver disease progression. They all three are different. So this is important to understand as a gastroenterologist, hepatologist in the crowd, that your patient belongs to which category so that you treat them accordingly, because the treatments are very different. So let's talk about salt restriction, somebody who is non-compliant with salt. The allowed or allowance, salt allowance per day in a patient with liver cirrhosis and ascites is around 4 to 6 grams. That is equivalent of sodium of 2 grams a day. So somebody, look at this beautiful depiction here. So a patient takes, a patient takes 2 grams salt per day, roughly accumulates 4 liters of ascites per week. So if you give them diuretics, and they will not have much ascites because they respond to diuretics, and the urinary sodium will be around 80 millimoles per day excretion. So whatever salt they take, apart from losing with sweat and everything, they might still come out. Ascitic fluid sodium is very similar to serum sodium. So they have very similar amount of salt in both the ascites and in the blood, the sodium content. Whereas a patient who claims to take 2 grams per day on diuretics, if they require weekly paracentesis of more than 4 liters and they excrete more sodium, that means that the patient comes and tells you that they are taking low salt, but still they are requiring weekly paracentesis more than 4 liters in spite of a diuretics, and you check the urinary sodium, it's very high. So that means these patients are non-compliant. Did you understand? It's very important to understand this very simple concept actually. So if you have a patient with diuretics who tells you that they are not taking any salt, but the urinary sodium is very high, and they still require paracentesis every week, they are actually taking more salt. So this is a very important point to understand. On the contrary, if the urinary sodium is undetectable or less than 10, if you heard in the previous presentations, the disease has progressed. So various guidelines suggest that salt restriction and 22 grams per day of sodium, which is 88 millimoles equivalent, that is 5 to 6 grams per day. But in reality, it's very difficult to discuss that. So we refer patients to dietitian. So where they particularly sit with individual patients, talk about their individual diet, and then they formulate a plan. So this includes, you should not take pickles. These are the hidden salts. A lot of patients, our patients, take biscuits. How biscuits are made from, from the dough, it has to get bigger. The biscuits, while making it, becomes bigger by the addition of soda bicarb. So sodium is the important ingredient in making cookies or biscuits. So you should really understand what they take. So just because they take biscuits, you should not say that, oh, it's okay. It contains a lot of salt. What about bread? Bread contains more salt because otherwise the dough will not look fluffy. So you need to send them to the dietitian. Make sure this gets addressed very seriously. And what about diuretics? If you look at the guidelines, the diuretics dose recommended is 100 milligrams of spironolactone, followed by addition of furosemide, 40 milligrams, and you can escalate it. But that's not the dose what we use in reality, because most of our patients, even in the West, they do not tolerate the doses of diuretics. These doses were derived in the 1980s when the guidelines were formulated. So there are no much clinical evidence for this doses of diuretics. So what we do in practice is to give a combination of spironolactone and furosemide or torsemide, and double the dose if required. And you monitor their abdominal girth, you monitor their weight, all those parameters. So this is how we do that. So the next entity is patients who are not tolerating diuretics. Why? Because of cramps, they may have electrolyte imbalance, they may have kidney dysfunction. And I don't know whether you focused Akash's talk. There are a significant number of patients will have underlying chronic kidney disease which may not have been unearthed at that point when you see them. So because we do a lot of liver transplantation, we see some patients do not have kidney injury or have very mild renal insult in the preoperative period. Post-transplant, the creatinine shoots up. That's a hidden chronic kidney disease, particularly if you are diabetic and hypertensive, and that comes out. And these patients, we have various options for them. Say, for example, if you have somebody with hyperkalemia, you can change the diuretic. If they have painful gynecomastia, you can stop spironolactone. If you have somebody with hyponatremia, you have to fluid restrict to them and add tolvaptan. And there are a number of other newer modalities like albumin infusion, albumin plus diuretic, albumin plus midodrine, whatever you like the combination, you can try it out. I'll come to the last few modalities later. So that's a response to diuretic. So weekly albumin infusion has been shown very effective. In this Italian study, which is the initial study, 45 patients received 20% albumin twice a week, followed by every 2 weeks for 2 years. And this is a very small number of patients. They were MELD matched. If you could see here, patients who received albumin had lower incidence of hepatorenal syndrome, lower encephalopathy, reduced ascites complications, reduced infection, spontaneous bacterial peritonitis. That's very important. Very significantly reduced spontaneous bacterial peritonitis. And their overall survival improved. So this is why you have to diagnose patients with diuretic intolerant ascites. These patients may benefit from albumin infusions. But all these treatments are very, very temporary. There is no end to this because ultimately these patients will require liver transplantation. That you should understand. So long-term administration of human albumin improves survival in patients with cirrhosis and refractory ascites. This is more so with patients who have diuretic intolerance because you're not going to give them. And there are multiple other studies, ANSWER and MACT study, which also showed similar results. But if you look at it's all, we are talking about 18 months, 2 years like that. It's not a long-term solution. It doesn't reverse the underlying disease. It only stabilizes patients away from complications of ascites. What about albumin plus furosemide? That's also a good combination because albumin, we know, increases your oncotic pressure, improves your kidney blood supply to the kidneys, and therefore where your furosemide can act. So that's the principle behind this. You could see this study, again, a good number of patients, particularly in ACLF patients. You see that addition of lactic albumin with diuretics actually improved the development of ascites in these patients. If you reduce ascites, you're going to reduce the complications like HRS and spontaneous bacterial peritonitis. So therefore, this is one more combination we have. But these are very small studies in small numbers. What about midodrine? This is a new molecule that we are getting familiar with in the last 3 years. So there's a study here from PGI where they used 40 patients who received midodrine 7.5 milligrams 3 times a day for 3 months and compared with standard medical therapy. So addition of midodrine actually improved survival compared to standard medical therapy. So this is once again a different management than diuretics. There are also new drug, sodium glucose co-transporter, that acts on the kidneys, which the diabetologists use. And also that also has some diuretic effect. So that's something has been, sporadic case reports have come on these two molecules. And the ascites pathogenesis involves, that has evolved totally. Previous speakers spoke a lot about splanchnic arterial vasodilatation, there is bacterial endotoxins and all. So how do you reduce gut bacterial endotoxin? Through rifaximin. So can you add rifaximin and midodrine? Yes, there is a study on that. So every combination has some small studies for you actually. So that is why it's very important to define your patient, which part of ascites is he in. So not all large volume ascites are the same. That's a point I want to highlight. And what happens if they develop hyponatremia? You need to fluid restrict them and give them 12 aptans. So that's a very standard practice we all do. Of course, you stop diuretics. Can you add diuretics with acuretics? I don't know the answer, but some people do actually. So what about the other entity, your diuretic resistant ascites? So we saw 3 groups of large volume ascites, one who take more salt, one who do not tolerate diuretics. This is a third group who have diuretic resistant. Why they have diuretic resistant? These are the possible reasons. The first thing is ongoing liver failure, the progression of the disease. So the bilirubin may go up, albumin may come down, the INR may increase. So this is one cohort of patients. The other cohort of patients, they may have still a reasonable synthetic function, but they may have worsening portal hypertension. So that's a second cohort of patient. So they may have more ascites, more varices, varicose bleed, septic complications, etc. Patients may develop portal vein thrombosis, which can increase your portal hypertension, and patients may develop HCC, which again can cause portal vein invasion and then more complication. So each of them are very different actually, because how do you manage patient diuretic resistant ascites? If you go to textbooks or if you go to journals, if you go to meetings, people talk about large volume paracentesis, TIPS, transplantation. It is not like that. So that is why you need to classify where they belong to in this 3 group. If somebody, for example, if somebody has liver synthetic failure, doing TIPS in them is dangerous, because you're going to develop complications, you're going to develop cardiac failure, you're going to increase their pulmonary artery hypertension, increase the chance of encephalopathy, and you're going to convert a stable patient into an unstable patient. So you should not do that. So somebody who has liver synthetic failure, they should go for transplantation. Whereas somebody who has worsening portal hypertension, you can still consider them for TIPS, although transplantation is the answer. So you can still consider them for TIPS or large volume paracentesis like that. So large volume paracentesis is always a bridge to whatever you're going to do, that is transplant. Okay, so that you should understand. Large volume paracentesis is never a solution for a patient's problem. And there are controversies regarding portal vein thrombosis doing TIPS in them, but I'm not going to go into that. So all these patients will require liver transplantation ultimately. And the guidelines say your large volume paracentesis, you can do up to, anywhere up to 8 liters or even more than that. You should supplement with albumin, 6 to 8 grams for every liter of fluid removed. And we don't need to correct the INR and platelets in them. And also these patients can be on a low dose diuretic. So that's not nothing offense to start them on low dose diuretics, and sometimes they also become diuretic responsive, so it can be a little dynamic, these changes. So let's talk about TIPS. It's nothing but a shunt or a stent that connects your portal vein and the hepatic vein. By doing that, you reduce the portal pressure and you change the hemodynamics of the cirrhotic patient. So your cardiac output increases. Therefore, you have to measure the cardiac output before the transplantation. Make sure the echocardiogram is normal before the TIPS procedure. But if done, if the patient respond, by 6 months, 40% of them completely reverse. And 60% of them still have ascites, but they also reverse your kidneys, they also reverse your sarcopenia. So that's more important. That's the advantage of TIPS procedure. But you should choose your patient very carefully. Not all patients with refractory ascites will benefit from TIPS. TIPS can work the other way around as well. For example, if you look at the literature, it will say young patient with low MELD. TIPS acts as a better transplant-free survival. But let me ask you, if somebody with low MELD, the chances of them having refractory ascites is very less. Okay, but compared to large volume paracentesis, TIPS has a lot of better advantage. It improves survival in the short term. All these parameters or techniques were developed in a cadaver transplant setting where you won't get the organ on time. That's how it was 20 years ago in the West. But now things have changed. Organ availability is high. So what happens when you develop encephalopathy following TIPS? We give the next available organ, cadaver organ, for that patient. That is not possible in our country, where the organ donation is extremely poor. It's 0.4 population per million patients per million population, PMP, per million population. Whereas if you look at Spain, it's 32 per million population. So that's the difference. We are nowhere near the West in terms of organ donation, actually. So therefore, you should carefully choose your patients for TIPS. Patients with advancing age, high MELD, prior hepatic encephalopathy, presence of sarcopenia, or they come under high risk factors. So as I told you, if you do TIPS in them, their average survival is only 5 months. So you unnecessarily converted a stable patient to unstable patients. Complications of TIPS or kink, TIPS migration, rarely hemoperitoneum, but mainly hepatic encephalopathy, and not to forget cardiac failure, because patients with liver cirrhosis, particularly if they are decompensated, they are likely to have cirrhotic cardiomyopathy. Undiagnosed cirrhotic cardiomyopathy is a very dangerous situation because they can create problems for you. The liver transplantation is the ultimate cure for these patients. Therefore, these patients should be referred to a higher center, particularly if their MELD is more than 15. When they have ascites, they should be listed for cadaveric transplantation, or if they have a family donor, definitely they will go for living donor liver transplantation. Particularly those who develop spontaneous bacterial peritonitis, refractory ascites, HRS would require benefit from early liver transplantation. Now, let's go back 2 steps. Can we predict ascites development? Nowadays, answer is probably yes. There's a new entity called clinically significant portal hypertension, CSPH. It is a prognostic milestone in the natural history of liver cirrhosis. The stage before this is compensated advanced chronic liver disease. The stage after this is decompensated cirrhosis. So this is a stage where you can actually do something. These patients do not have any symptoms, but these patients can potentially develop varices, variceal bleed, ascites in the next 2 years with very poor survival, and also there is very high risk of hepatocellular carcinoma. And there are different ways you can diagnose this. This is based on your platelet count and transient elastography on your fibroscan. So if you develop CSPH, okay, you can start them on beta blocker, particularly carvedilol, which has been shown to delay the onset of hepatic decompensation. Actually, you don't need endoscopy to start beta blocker these days. So if they fulfill this criteria, you can actually start them on beta blocker, which delays the onset of hepatic decompensation. This is more with carvedilol than propranolol. So how does it work? Your non-selective beta blocker reduces the portal flow up to 35%, reduces your cardiac output by 20%. Therefore, it reduces your splanchnic arteriolar, or it causes splanchnic arterial vasoconstriction by 15%. So overall, it reduces the portal flow by 35%. In addition, very different from propranolol, carvedilol reduces the intrahepatic vascular resistance, which allows the liver to improve a little bit. However, there is a window. In patients with refractory ascites, by reducing cardiac output, you actually reduce the renal perfusion. So therefore, once they develop refractory ascites, you should withhold beta blocker. And also, compared to propranolol, carvedilol causes more hypotension. So the paradigm is, if you have somebody with clinically significant portal hypertension, you start them on carvedilol and eventually delay the onset of ascites and hepatic decompensation. And once they develop decompensation, you should think about transplantation. But in case if they progress to refractory ascites, you should stop carvedilol switch them to propranolol, that to low dose. So therefore, I complete my presentation here saying large volume ascites all are not the same. Some could be due to dietary non-compliance, many could be diuretic intolerance, and many are diuretic resistance. You need to know which category your patient belongs to, because if you don't know, every patient will go for large volume paracentesis, every patient could go for transplantation, every patient will go for TIPS procedure. That is not the case here. Okay, so you need to know exactly where that patient belongs to in your algorithm and then manage them accordingly. Ultimately, liver transplantation remains a cure for all these patients. Thank you very much.
Thank you, sir, for this wonderful presentation. Now the topic is open for discussion. So if there is no question, we will proceed for the next session. Thank you, sir.
We thank our speaker for their wonderful presentation. We request our honorable chairpersons to please felicitate our speaker for today. Sir. Our next speaker is Dr. Soumitra Ghosh, speaking on the topic obesity and liver disease.
Welcome, Soumitra. Welcome to Agartala again. So it is my pleasure to welcome Soumitra again to this platform. And he is a very known face here, so he needs no introduction from my end. Straight away, I'll be asking Dr. Soumitra Ghosh to carry on with his deliberation. Thank you, sir, for coming here.
Oh, respected chairpersons, my teachers, seniors, colleagues, and junior friends. So I'm thankful to Professor Pradip Bhomik for giving me an opportunity to discuss the most important topic of the conference, because at the end comes the most important and the most prevalent problem in the liver segment, that is the obesity. Because we are actually having two parallel pandemics now, other than this COVID pandemic, these non-communicable diseases pandemics, obesity and the chronic liver disease. Both of them are going very up and very high and going parallelly. And it is the most prevalent. It has surpassed all infective conditions, because hepatitis B is nowhere near this prevalence of this condition now. It has surpassed all infective causes. 30% of the world population is suffering. It is very difficult to find a family where no one is suffering from this fatty liver disease. Even the children, adolescents, and everyone is having some problems. 70 to 80% those who are obese or overweight. It is a multi-system disease, and it is a conglomerate of obesity, type 2 diabetes mellitus, hypertension, dyslipidemia, metabolic syndrome. So it is a problem involving multiple systems. 82% of the NASH patients are living with obesity, and 44% are living with type 2 diabetes mellitus. And obesity is the most important risk factor for this non-alcoholic fatty liver disease. In fact, type 2 diabetes mellitus and this cardiovascular disease are the two most important extrahepatic diseases associated with non-alcoholic fatty liver disease, and liver is the perpetrator of numerous cardiometabolic insult. So it is not liver alone, because it is a cardiometabolic insult. So obesity, non-alcoholic fatty liver disease, type 2 diabetes mellitus, cardiovascular disease, all are linked together. So whenever you think of these, you actually think of a bigger problem. Just it is the tip of this bigger iceberg. It is the cardiovascular disease, type 2 diabetes mellitus, NAFLD. They are all linked together. They are increasing the risk of another one in a comprehensive way. So cardiovascular disease is the most common cause of death in non-alcoholic fatty liver disease. It is not the liver alone. Advances with the stages of NAFLD, greater risk of cardiovascular diseases are there. CVD and the NAFLD have many shared risk factors. insulin resistance, type 2 diabetes mellitus, obesity, hypertension, dyslipidemia. Even after adjusting all shared risk factors, NFLD remains the independent risk factor for the development of the cardiovascular disease. NFLD is associated with a twofold increase in the incidence of diabetes, and diabetes development is the biggest predictor of the advancement of this disease and fibrosis of the NFLD. So it is actually they are associated, NFLD, obesity, dyslipidemia, hypertension, insulin resistance together, and actually it is the ectopic fat in the organs. When multiple ectopic fat are there in the multiple organs like the arteries, heart, liver, pancreas, muscles, kidneys, they develop this cardiovascular disease, NFLD, diabetes all together, and they increase the mortality in a comprehensive way. So, association of this NFLD, metabolic syndrome and type 2 diabetes mellitus, it is the manifestation of ectopic fat in the liver, and all these things are actually conglomerated together. And to focus on this problem, that it is not liver alone, it is the holistic approach, all other organs together. So there has been a new change to shift the focus of the patients as well as the physicians that it is not a liver disease, it is actually a metabolic dysfunction associated steatotic liver disease. So before the liver disease comes, the term has to be uttered that it is metabolically dysfunction associated disease. So metabolic dysfunction comes first, then the liver disease comes first. So the approach of the physician and the patients are actually shifted from the liver to the holistic thing that it is the metabolic dysfunction as a whole together. And this NASH, which was previous term, now it is called metabolic dysfunction associated steatohepatitis when there is inflammation. And this nomenclature is changed in just 23rd June in 2023, just not even 1 year back. So whenever there is a fatty liver by the diagnosis of ultrasound or whatever means, it can be a metabolic dysfunction associated steatotic liver disease or MASLD or steatohepatitis, whatever. When there is associated alcohol, so we'll have to divide whether it is a pure alcoholic liver disease or a person with metabolic disease like person having diabetes may also take alcohol. Which one is predominant? Whether alcohol is predominant, depending on the amount of alcohol patient is taking, whether it is 20 grams per day or 30, 40, 50. If it is on the higher side, then it is called MASLD with increased alcohol, MAT-ALD. And when it is alcohol only, metabolic conditions are not there, it is called alcoholic liver disease. When other conditions are there like drug induced or some monogenic, say lipodystrophy or some miscellaneous causes of injury, it is specific cause, and when no cause is found, it is called cryptogenic. So whenever we get a patient with steatotic liver disease, we try to find out whether there is any cardiometabolic criteria or not. If it is yes, we try to find out whether it is pure metabolic dysfunction associated and no other conditions are there, then it is MASLD. When alcohol is overlapping, then it is called MAT-ALD. When it is alcohol alone, then it is called alcoholic liver disease. When no cardiometabolic factor or alcohol is there, we try to find out whether other factors like drug-induced, lipodystrophy or some other conditions are there. When it is not found, then it is cryptogenic. So this is the simple classification. As Professor Jyotirmoy Pal was highlighting, so SGPT is actually more increased in these metabolic dysfunction associated problems, and SGOT is more in the alcoholic liver disease, more than 2, etc. And significant alcohol intake in males is 30 grams per day and in females 20 grams per day. And when there is overlap, it is called MAT-ALD. So to S7, or patient is on treatment for diabetes, or the BP is actually 130/85, or patient is on treatment of hypertension, triglyceride is more than 150, or HDL is less than 40 in males and 50 in females, then anyone, then it is metabolic dysfunction associated disease. So this is actually the cluster when these obesity associated liver diseases can be. So actually, as this is a new term, in many situations we can use the both terms interchangeably to avoid confusion. So MASLD, the cardiovascular disease is the most common cause of death. So liver is the diseased part, the cause of death is the cardiovascular disease. So there is a link, and it is very important. The hypertension, atherosclerotic disease, cardiac arrhythmia, structural diseases, all are very predominant and common. MASLD is an independent cardiometabolic risk and can be associated with other conditions, diabetes, etc., because atherogenic dyslipidemia, atherogenic lipoproteins, they are overflown is these conditions where the liver is fatty. So it is the citadel of all lipid formation. So when there is fatty changes, it produces all bad lipids and all are atherogenic, and that can cause gluconeogenesis and secretion of this, other glucose and lipid synthesis, and that can cause this cardiovascular disease. So different conditions actually give rise to the MASLD, the intrahepatic steatosis, de novo lipogenesis, hepatic inflammation, gut microbiota, bile acid metabolism changes, all are together, and when they are all together and the ectopic fat in the different organs, they increase the chances of cardiovascular mortality in different way or other. So in different publications, in presentations internationally, we have presented ectopic fat in the liver, NAFLD and the cardiovascular diseases, and it has been shown that CIMT is increased in NAFLD conditions, and this flow-mediated dilatation, it is a marker of this endothelial dysfunction. They are very much present in case of liver disease. So when we take it as a fatty liver disease, we should take it as a atherosclerotic disease or a endothelial dysfunction disease. And with the changes in the NAFLD, you see the how CIMT is increased very significantly. And with advancing changes in the NAFLD, the CIMT is increasing almost in a parallel way. And this flow-mediated dilatation, this endothelial dysfunction is also prevalent, and it is very important. With increasing grades of NAFLD, this flow-mediated dilatation is going down and down and down. So in another conference in Japan, we presented that this 78% of the NAFLD patients had increased epicardial fat, and with this epicardial fat, the diastolic dysfunction is present, and this diastolic dysfunction is also parallel with these increasing grades of this epicardial fat and the NAFLD. So NAFLD is not a liver disease alone. So significantly higher conditions. When this NAFLD is there, it increases the chance of diastolic dysfunction by almost 10 times. It is our study published internationally. So endothelial dysfunction and atherosclerotic vascular injury, they are very prevalent, and they are very much there in our body, even in the adolescents, and in these vascular injuries, prominent, and it was also highly appreciated in the young children and the adolescents. It is also prevalent. It is not to be in the middle age group or so much. Actually, in the children and this adolescent group, these atherosclerotic changes are prevalent from the very childhood. So what is the condition of the liver in MASLD? It is a part of the systemic disease. So whenever there is a spectrum, so healthy liver, NAFLD, then the inflammation starts, this cirrhosis, and then this hepatocellular carcinoma. So in the healthy liver, in the perspective of obesity, diabetes, hypertension, dyslipidemia, when hepatic steatosis is there by ultrasound and other means, evidence of hepatocellular inflammation is not there, it is NAFLD. When hepatocellular inflammation and apoptosis starts, it is hepatitis, steatohepatitis, and inflammation plus fibrosis, it is called cirrhosis, and then hepatocellular carcinoma when the malignancy starts. So MASLD is as such of more than 5% of the fat in the liver, and it can be divided into two, this MASL and MASH, depending on inflammation is there or not. So no inflammation, SGPT normal. It is this non-alcoholic fatty liver disease or metabolic dysfunction associated steatotic liver disease. And when this SGPT is just minimally raised, means inflammation is there. So minimally increased SGPT is the marker when the liver disease is progressed further. So it is in the above level. So don't take it very lightly. It's a very important factor. And this inflammation, when it starts, it goes into fibrosis, cirrhosis, hepatocellular carcinoma sequentially. So free fatty acid, insulin resistance, adipose tissue dysfunction, gut microbiota, they perpetually increase the persistent inflammation leading to fibrosis and cirrhosis. So MASLD, how to diagnose and stage. It is very important to establish the diagnosis, staging it, because assessing the reversibility is our task and treatment decisions has to be taken. So MASLD diagnosis, all four are required: demonstration of fatty liver, exclusion of significant alcohol consumption, exclusion of other causes of hepatic steatosis, and absence of coexisting chronic liver disease, other causes like hepatitis B, this hepatitis C, other autoimmune diseases, lipodystrophy, acute weight loss, malnourishment, abital lipoproteinemia, pregnancy-associated conditions like medications like steroid, amiodarone, methotrexate, tamoxifen, valproate, and HRT, etc. So we try to define it in the whether it is in the stage 0, 1, 2, 3, depending on the amount of fat there in the liver. And we try to define how much fibrotic changes are there. So it is actually the fibrosis stage F0 to F4. F4 is cirrhosis, F1 is mild. So we try to differentiate how much reversibility is. So F0 and F1 is very much reversible, and F2, 3, 4 are advanced condition. So every condition which we now plan is to define the reversibility and how much we can reverse. So we try to understand whether it is in the early stage we can reverse it, or it is in the advanced stage we cannot reverse it. So biopsy is the gold standard, but in many situations there are many limitations, we cannot do it. Clinical problems like we try to just do it by clinical methods, laboratory methods, imaging, cardiometabolic risk factor assessment, etc. And it is very much important because we try to just, clinical symptoms are actually not much. Patients mostly asymptomatic. Sometimes the vague conditions, fatigue and vague right hypochondrial pain, etc. may be there. Non-specific discomfort may be there. GERD may be there. But if we take detailed history, assess this obesity, waist circumference, the signs of insulin resistance, pre-existing diabetes, blood pressure, etc., etc., and we go for this laboratory testing, complete hemogram, lipid, etc., blood sugar, thyroid, and the conditions, secondary causes which may cause other fatty liver diseases, etc. But SGPT is a very good, important screening test. As I said, if the SGPT is increased, inflammation is there. So normal liver enzyme do not exclude these liver conditions because the fatty liver is there, but inflammation is not there, so enzymes will be there. So test for other common conditions like the hypertension, obstructive sleep apnea should also be there. Imaging studies like ultrasound, CT, MRI can be very good, but insufficient to detect earlier stages of fibrosis. USG detects steatosis, cannot quantify accurately. MRI proton density fat fraction can quantify, but it is very costly things. But ultrasound is a very important thing and very reliable, and they can classify stage 1, 2, 3, 4, etc. 3 radiologic findings sufficient for diagnosis of steatotic liver disease, and further test for other causes of hepatic steatosis and presence of fibrosis actually is not required. So it can, confidently grade 1, 2, 3 can be done. So what are the non-invasive tests? Because we do not want biopsy in most of the conditions. Non-invasive test, it minimizes the need of the liver biopsy. That can be serological and that can be imaging. Serological test can be direct and the indirect. Indirect test reflects the hepatic functions, and direct test actually funds this matrix turnover and the fibrogenesis, and they are the surrogates and not the biomarkers of biopsy. And these imaging tests, the elastography tests, etc., they measure the liver stiffness. So on the one hand, we try to find out the liver function, and on the other hand, they measure the liver stiffness. So non-invasive tests, basically to differentiate the significant fibrosis, as I said, the F2 to F4, and to differentiate it from the F0 to F1, to monitor, to assess the progression, and to predict that stage dividend, and to guide these treatment decisions, it is very important. So what are the serological tests? It can be just the tests of the SGOT, SGPT, the GGT, etc., bilirubin, as Professor Pal said. And it's very important tests are these FIB-4 tests, this fibrosis 4 index, very simple test, or NFA score, APRI score, etc. In this FIB-4 score, it is the UP. UP means age, AST, ALT, and the platelet. Very simple. And when this score is less than 1.3, then this fibrosis score is F0 or 1. It is minimal. So biopsy is not required. When it is more than 2.67, it is advanced fibrosis, and even in that situation, it is not required. And in our clinic, we have corroborated very well, and the waist circumference actually corroborates with this kind of tests very well in the clinic setup. This NFLD fibrosis score or NFS, where all these up, along with that these diabetes parameters and these albumin are required. And when this NFS score is more than 0.676, then the advanced fibrosis is there. And when it is less than minus 1.455, it is actually the minimal, the F0 or F1. And in our clinic, it is the corroboration with the clinical findings, where circumference corroborates very well. And the direct serological test, the matrix deposition, matrix degradation, it is actually very difficult to say. An enhanced liver fibrosis or ELF test actually assesses these three conditions from these three segments. So what are the imaging tests which actually sees these liver stiffness measures? This vibration control transient elastography, the brand name is actually FibroScan. This shear wave elastography, MR elastography, and the acoustic radiation or RF. They are very important, and the best validated scan is the transient elastography or the FibroScan, which measures this liver stiffness very well, but avoid in patients with pregnancy or those who are with the pacemaker. Alternative imaging procedures like shear wave or MR elastography can be done. What is safe biopsy? Safe biopsy means biopsy is actually not done. It is the combination of serology and the combination of this imaging, because safe means sequential algorithm for fibrosis evaluation. If you do these things, the serological and this, imaging, then this combination improves the accuracy, reduces the need of liver biopsy, and good accuracy is there, and stepwise combination does the important changes. So what patient need biopsy? No clear consensus. If there is unclear diagnosis, if there is unclear fibrosis staging, or the patient is in the intermediate group, we can go for it before bariatric surgery or to evaluate increased risk. In some situations we can do it, but in most situations biopsy is actually not required. Risk factor for the advanced fibrosis, identify the high risk group. So what are the high risk groups? In what situations we'll have to be focused? This type 2 diabetes mellitus or pre-diabetes, those patients who are obese, those patients with more than 2 cardiometabolic risk factors, fatty liver on imaging, and those patients with the increased liver enzymes. In those situations, we'll have to be very focused to assess everything. So whenever we get this high risk group, we try to assess this FIB-4 score, and if this FIB-4 score, we go for with liver, this stiffness assessment by this FibroScan, etc. And just low risk, intermediate group, and the high risk group can be easily identified by the FIB-4 score and the LSM, staging of this F4 to F2 to F4 and the F0 to F1 can be easily differentiated, and the NFH also, we can easily differentiate these two conditions. On the left side, when this, fibrosis score is less, we do not need biopsy. On the higher right hand side, when the fibrosis score is high, we do not need biopsy. So what should be the management protocol? It is a multidisciplinary approach. Liver-centric approach is insufficient. Weight loss is the cornerstone for most patients in NFLD. Control of diabetes and other cardiometabolic risk factors is the cornerstone, and diabetes is the major driver of the disease progression. So these are the 4 stages. Number 1, the diagnosis and staging, then weight loss, modifying the CV risk factors, and the liver targeted therapies comes next. Whenever there is a high risk group, the history examination and other clinical examination and this lab test has 2 motives. Number 1, to prevention of this cardiovascular disease and prevention of the further progression of the liver condition to cirrhosis. So management of obesity, diabetes, hypertension, atherogenic dyslipidemia, these are the most important things, and fibrosis risk stratification to the low risk and the high risk group is very important, and the cornerstones are weight loss, modifying cardiovascular risk factors, diabetes control, abstaining from alcohol is very important. All these comorbidities like obesity, metabolic syndrome, pre-diabetes, dyslipidemia, hypertension, CVD, and the OSA should be managed. Weight loss is the primary treatment recommendation. At least 5 to 7% weight loss is targeted, and this more target 7 to 10% when this inflammation has set in. Lifestyle modification is the mainstay, and the physical activity is important because preserving the muscles is the most important thing. Weight loss surgery may be considered when the condition is serious. No particular diet is superior to others. Target 600 to 1500 calorie deficit, calorie restriction, particularly fructose containing foods and beverages, because they are the most important factors for the fatty liver conditions. Saturated fat, refined carbohydrate, added sugar should be controlled, and both aerobic and resistant exercises, structured weight loss program, and modified high intensity interval training or HIIT may be helpful. and minimizing screen time is very important. But what is the role of the pharmacological treatment of this MASLD? No FDA approved drugs for this. Role of drugs in the diabetes when the diabetes is there, role of drugs for obesity when the obesity is there, and role of vitamin D, particularly those patients who are having inflammation and they are non-diabetic. So metformin, it is typically given in diabetes, but it is not effective in the fatty liver conditions, so it is not recommended. Pioglitazone improves fibrosis, inflammation, and steatosis because it removes the organ fat to the periphery. So it is actually very important, improves insulin sensitivity, and it prevents MASLD progression. SGLT, to limited evidence, not recommended, no effect on fibrosis. GLP-1 receptor agonist, liraglutide, less likely to have progression of this fibrosis. Semaglutide may be effective in the higher doses. Histologic improvement is there, but no significant improvement in the fibrosis stage. MASH without diabetes, you can give vitamin E 800 milligram per day, but has to be fibrosis stage 2 or above, and no diabetes should be there, because in many situations vitamin E is actually given, but it is not effective. No histological benefit. Do not use in patients with diabetes or decompensated cirrhosis, but in patients with CA prostate, don't give. Ursodeoxycholic acid have not been shown to be effective. Most misused drug. Obeticholic acid, so under study, it is still now not recommended. Omega-3 fatty acid, not recommended. Atorvastatin can give you the CV benefits, but not recommended for liver condition only. Probiotic supplement, not effective. Aspirin has a promising result in decreasing progression to the fibrosis because aspirin is an anti-fibrotic agent. So that is very important. So to summarily, pioglitazone and GLP-1 RS in persons with diabetes can be given. GLP-1 RS and pioglitazone SGLT to cover these cardiometabolic benefits, but not for the improvement of the liver. Vitamin E, particularly in those patients who have this inflammation and type 2 diabetes mellitus, and bariatric surgery in those patients with BMI more than 32.5. In those compensated cirrhosis, it can be still considered, but in decompensated cirrhosis, should not be recommended. But we should also remember that lean patients may also have fatty liver disease or the steatotic liver disease. Obesity of the liver, it is called, the patient is lean, like in lipodystrophy. In many situations, particularly in Indian setup, you will see the organ fat is there because patient is looking thin from outside, and more worsening of the fibrosis and progression to cirrhosis of the liver. So to conclude, the burden of obesity and the MASLD has reached to an epidemic proportion. Modern foods with fructose, altered gut microbiota are mainly responsible. Liver disease in obesity is simply the tip of the multi-system disease iceberg, like type 2 diabetes, hypertension, obesity, and dyslipidemia. Ectopic fat in multiple organs may occur simultaneously with the liver fat, and increased cardiovascular, hepatic, and non-hepatic mortality in these advanced fibrosis. Multidisciplinary treatment approach to prevent cardiovascular disease and to prevent cirrhosis, and currently no FDA approved drugs for this MASLD treatment. Current treatment modalities are lifestyle modification, weight loss, pharmacotherapy for type 2 diabetes mellitus, comorbidity treatment, and the metabolic surgery. Future landscape is optimistic because we have understood the situation, how much it is causing the disease, particularly in the background of obesity. So new name of this metabolic dysfunction associated steatotic liver disease gives us a better understanding and a better focus on these associations, and just don't target the liver. It is the associations, all are important, holistic management. So treat type 2 diabetes mellitus, obesity, hypertension, dyslipidemia, CV disease, because most patients die out of cardiovascular conditions. Treatment is not a liver centric and metabolic dysfunction associated multi-system disease. Thank you very much for your patient hearing.
Thank you, sir. Thank you for this wonderful and insightful presentation. Now I would like to ask audience few questions. If there is no question, we will conclude the session here. Thank you, sir.
Thank you.
Thank you so much, sir. So I would like to request our chairperson to kindly felicitate our speaker, Dr. Soumitra Ghosh, sir.
May I have a big round of applause for our speaker.
our Technical Director Dr. Ojit Chaudhary sir to kindly felicitate our chairperson.
May I have a big round of applause for our chairpersons.
All distinguished guests, kindly remain seated in your chair. We will be starting our inaugural program very soon. Our guests are on the way. Kindly bear with us a few minutes for the stage preparation.
Hello. Ladies and gentlemen, distinguished guests and esteemed members, print media personnel, good evening all of you.
We, on behalf of the organizing committee of HFT, welcome you all to the LIVERCON 7 and 5th Padma Ganga Gomati International Liver Conference in our International Convention Center of Hapania, Agartala.
Without any further ado, we'll start our inaugural program with dance by student of HFT Institute of Sciences. Thank you.
Thank you, girls, for your wonderful performance.
Today we have our guest of honor, Sri Shushanto Chaudhary, Honorable Minister of Tourism, Transport, Food, Civil Supply and Consumer Affairs, Government of Tripura.
Our guest of honor is Shri Kiran Gitte Sir, IAS Secretary, Health and Family Welfare Department, Government of Tripura.
Today we have Dr. Gaudash Chaudhary, veteran gastroenterologist and hepatologist of India.
Dr. Mamun Al Mahatab, internationally acclaimed hepatologist and researcher from Bangladesh.
Dr. Sudhamshu Kesi, senior consultant hepatologist from Nepal.
Dr. N.L. Bhaumik, President of HFT.
Dr. Pradeep Bhaumik, organizing chairman, HFT.
Dr. Major Pranab Kanti Datta, organizing secretary, HFT.
We welcome all of you in the dais. We would like to take this opportunity to welcome our guest on the dais with flower bouquet.
Along with that, we will also like to take the honor to felicitate our guests. I would like to request Dr. N.L. Bhaumik sir to kindly felicitate our chief guest of the evening, Sri Shushanto Chaudhary, Honorable Minister, Department of Tourism and Transport, Food, Civil Supplies and Consumer Affairs, Government of Tripura. Thank you, sir.
I would like to request Dr. Pradeep Bhaumik, organizing chairman of HFT, to felicitate our guest of honor, Sri Kiran Gitte, IAS Secretary, Health and Family Welfare, Department of Government of Tripura. I would also like to request Dr. Pradeep Bhaumik sir to kindly felicitate our Gaudash Chaudhary sir, veteran gastroenterologist and hepatologist of India.
Thank you, sir. I would like to request Dr. Major Pranab Kanti Datta sir to kindly felicitate Dr. Mamun Al Mahatab, internationally acclaimed hepatologist and researcher from Bangladesh. We would like to also felicitate Dr. Sudhamshu Kesi sir, senior consultant hepatologist from Nepal.
It's time for the lightening of lamp. May I request our respected dignitaries to come forward for lightening of lamps.
शुभम करोति कल्याणम आरोग्यम धन संपदा शत्रु बुद्धि विनाशाय दीप ज्योति नमस्तुते.
Which means salutation to the light of the lamp, which brings auspiciousness, health and prosperity, which destroys inimical feelings. Salutations to the light of the lamp. Thank you, dignitaries. Now, I would like to request Dr. Major Pranab Kanti Datta sir, Organizing Secretary of HFT, for the welcome address.
Namaskar and good evening to all the August gathering in this hall. It's a matter of pride and privilege to welcome all the distinguished dignitaries on the dais, as well as the eminent personality, both from nation as well as our teachers from across the border. Sitting on the dais, our beloved and respected Minister of the State of the Department of Food and Civil Supplies as well as Consumer Affairs, Government of Tripura, Sri Sushanta Chaudhary sir, and Kiran Gitte sir, our Secretary, Department of Health and Family Welfare. Your presence to this gathering is a testimony of recognition of our activities of Hepatitis Foundation of Tripura for last 20 years, and we are honored to have you in this evening among us. Sitting along with in the dais, Professor Gurdas Chaudhary, who has got a very bright and illuminating career as a teacher for more than 35-40 years as a teacher, and now is a renowned hepatologist who is actually guiding the research in the field of hepatic care in the Delhi. Sitting on the same row, Professor Dr. Mahmood Al-Matab from Dhaka. Sir, I've been working in the Bangabandhu Sheikh Mujibur Medical College in Dhaka. Along with that, he has got very bright career and history of carrying out research projects, particularly in the field of hepatitis B and C in Bangladesh, who has got international recognition. Your presence among us is encouraging in the fact that we would like to take guidance from you now as well as in future. Dr. Sudhamshu Kesi sir from Nepal is a new addition to this conference. Maybe our community activity in this state is getting much more bigger implications. Sitting on the dais, Dr. Anil Bhomik and Professor Pradeep Bhomik sir, who have been working since the day of foundation in the Hepatic Foundation of Tripura. Even though this conference signifies the medical, rather purely doctors, but we have been working since last 20 years in this state as a pro-people organization. Our community activities are much more bigger and much more widespread, starting from both communicable and non-communicable diseases. We welcome all the eminent personality of who are not in the dais, rather sitting on the audience, and like Professor Dr. Sanjeev Devarma, the pediatrician and Director of Health and Family Welfare, Government of Tripura, Professor Anup sir, and it's a very interesting to see our Dr. Vikas Rai, who have been fighting a good amount of health issues, but still he has got courage to be among us. It's a big blessing for this evening. And we welcome all of you, sir. We welcome all the students who have decided to be with us for next 3 days of our sojourn in scientific voyage. Your zeal to learn is a commitment to us, signifies that we will be doing better in days to come, whatever we have been doing today. Tomorrow is our better day, and future is for us. At the same time, all the paramedics and volunteers who have been working with us for more than 20 years, and this conference, which has got two implications. One is 7th LIVERCON of the Hepatic Foundation of Tripura, and of course 5th Padma Ganga Gomti International Liver Conference. Why international dimension is there? Because our activity is akin to the activities in Bangladesh, in Nepal, in some parts of Bhutan, and of course in Sri Lanka. We have been expecting delegates from Sri Lanka, but because of certain issues, he could not make it to come to our conference. We expect that in the next conference we will be getting a much more bigger international presence. We welcome all the corporate partners who have been happily, gracefully helping us in shaping our programs and conferences. We welcome all the persons from the media, both print and electronic, who have decided to disseminate the information about our activities. And again, I welcome the whole August gathering to this conference, Bon Voyage in Science. Thank you.
Thank you, sir, for your valuable speech. Now it's time for release of souvenir of HFT 7, LIVERCON 7 by the dignitaries on the dais. I would like to request for release of our souvenir. May I have a big round of applause. It's time for the speech of our organizing chairman, Dr. Pradip Bhomik sir. I would like to request sir to kindly give his valuable speech.
Good evening, everybody. At the very outset, I demand, I ask, I request blessings and guidance of all of you to each and every member of Hepatitis Foundation of Tripura, so that we can proceed, we can progress further to eliminate hepatitis B from the state of Tripura as well as from the country, what we have started as early as 2002, and to work for the people day in and day out with your support, with your help. and to get the support, to get the blessings. We have got with us today in this prestigious conference, in this inaugural program of 7th HFT LIVERCON 2024 and 5th edition of Padma Ganga Gomati International Liver Conference. As a chief guest, Sri Sushanto Chaudhary. He is not only a minister of the state of Tripura, but he is a guide, friend, philosopher of the foundation. And I am very thankful to him. Within a very short notice, he has accepted our invitation. And he very correctly said, I always try to attend all of the program of Hepatitis Foundation of Tripura. We are thankful to you, sir, for being with us today and Easter years. And we strongly believe in the coming years, you will be with us. You will guide us so that we can fulfill our dream and we can proceed further. We are very thankful to our Health Secretary, sir, Sri Kiran Gitte. He was just telling he is now more of Tripura, less of Maharashtra. And really, truly, we have got many chance to interact with him. We found his depth about the health care of the people. And he is always interested to reach out to the people to the deepest possible village or area of the state. At the same time, he was telling that he is interested to develop the best possible health care for the state. And I am not the proper person, he will tell in his own way when he will speak. We are really thankful to all of you who are here today and to represent our faculty members from the country and abroad. We have got here Dr. Gauradas Chaudhary, who is a teacher of teachers of the country, and he has given, I believe, many hundred lectures across the globe. And he was with us earlier also, and today he has given a very interactive lecture I heard, though unfortunately I could not attend, at Tripura Medical College students. And students are very excited and they are interested, and immediately they have requested foundation that this sort of program should be continued at Tripura Medical College. Sir, really it was very interesting what I heard, and really we missed it. But we have attended his today's morning class of our postgraduate students. That was very interesting, very nice. Dr. Mamunal Mehta, he's to us, he's not a faculty member, he's our friend. And for last more than a decade, when we have requested, he has responded to us. He has come, given lectures, not only of science, but many other issues, which has touched our heart. And the LIVERCON, when it was started in 2011, a liver disease conference, a single theme conference, he was one of our faculty. And since then, we are getting him times and again. We are thankful to you, sir. The concept of Padma Ganga Gomati is the brainchild of Dr. Mamulan Mehta. Since 2019, he and his friends, and many of them are in this auditorium today, has given it a shape, and it is continued till now in 2024 as 5th Padma Ganga Gomati International Liver Conference. Dr. Sudhanshu, he is very kind enough to be with us today, and he will be here for next 2 days to guide us. He has given a very nice lecture today on hepatitis E. And very rightly he said, most of the time we discuss many things, many high funda science, but we do not discuss the basic problem of our country still, which we do have, hepatitis E. And he has given a very interesting lecture on hepatitis E. And as my friend Dr. Pranab Datta said, Dr. Vikas Rai said is here, Sir Pranam আমাদের সকলের পক্ষ থেকে। And Pranav is there as a very dynamic organizing secretary of this conference. And we are very fortunate Dr. Renal Bhomik as the president of HFT. He's here, he's guiding every day and day in and day out. And we have got, as mentioned by our organizing secretary, many other dignitaries like our principal, our director of health services, superintendent, and all of you who are and registrar of Tripura State Medical Council, and a lot of you. I won't like to name everyone because it will take a lot of time. But yes, this is a history-making conference for all of us. We want to bring science to the people. And gradually, when we started our LIVERCON in 2011, it was a hard science conference. But this time, the conference is designed in such a way, we have thought about the very molecular level science. At the same time, we have designed a science which is directly talking to the people, the community hepatology. We want to bring this concept of community level science through our LIVERCON. Community hepatology, many people doesn't think about it or not interested because we are more acclaimed or we are more concerned about our hospital and hospital-based science, not to the level of people. And we want to make it, because Hepatitis Foundation of Tripura is basically formed not only with the doctors or doctor community, but every sector of community is represented in this foundation. And that is being reflected in his activity. Tomorrow we believe with all your advice, we'll be able to go forward and go further down to the community, and not only with the liver science, but with others which are directly and indirectly related to the liver. And hope that tomorrow will be a better day, and your guidance, your help will make us a successful conference this time, and future is in your hand, and we bring once again, we request your blessings and support. Thank you all.
Thank you, sir, for your valuable speech. Now, we would like to call upon Dr. Mamun Al Mahatab, who is an internationally acclaimed hepatologist and researcher from Bangladesh. Would like to request sir for his valuable speech.
Thank you very much. I'd like to start by thanking Hepatitis Foundation of Tripura for making me once again a faculty at this conference and making me feel at home again. দেশের বাইরে এসে বিদেশে এসে দেশের ভাষায় কথা বলতে পারা সৌভাগ্য আমাদের জন্য খুবই বিরল। আমি এতক্ষণে বুঝে গেছি যে এখানে যারা আছেন তারা বাংলায় শুনতে খুব বেশি বিরক্ত হবেন না, এবং মাননীয় স্বাস্থ্য সচিব মহোদয় যিনি একজন মারাঠি, তিনি আমাকে বলেছেন যে তিনি বাংলা ভালোই বোঝেন এবং জানেন, অতএব আমরা বাংলাতেই কথা বলতে পারি। যাই হোক, এই সম্মেলনটির সাথে আমার যোগাযোগ আসলে 2011 সাল থেকে। আমি অধ্যাপক প্রদীপ ভৌমিক এবং হেপাটাইটিস ফাউন্ডেশন ত্রিপুরা এবং এই সম্মেলনের বিকাশটা নিজের চোখে দেখেছি। আমি মনে করি হেপাটাইটিস ফাউন্ডেশন অফ ত্রিপুরা শুধু ত্রিপুরার গর্ব নয়, এটি পুরো ভারতবর্ষের গর্ব, এবং তাই সেটা ছাড়িয়ে আমাদের অঞ্চলের এবং আমাদের উপমহাদেশেরও গর্ব। এই ফাউন্ডেশন একসময় অ্যাডাল্ট ভ্যাকসিনেশন, অ্যাডাল্ট হেপাটাইটিস ভ্যাকসিনেশনের যে উদাহরণ স্থাপন করেছিল, সেটি কিন্তু আপনারা হয়তো জানেন বা কেউ যদি না জেনে থাকেন, সারা বিশ্বে সমাদৃত। ম্যানিলাতে ওয়ার্ল্ড হেপাটাইটিস অ্যালায়েন্স এবং এশিয়ান প্যাসিফিক অ্যাসোসিয়েশন ফর দ্য স্টাডি অফ দ্য লিভার, যেন প্রদীপ ভৌমিক, অধ্যাপক প্রদীপ ভৌমিককে এই জন্য যখন সম্মানিত করে, তখন কিন্তু সেই অনুষ্ঠানে আপনাদের মতো দর্শক সারিতে বসে আমিও দারুণ গর্বিত বোধ করছিলাম যে একজন বাঙালি এত বড় সম্মান পাচ্ছেন। তো সেই বিষয়ে আমি প্রত্যক্ষদর্শী। আর আমি খুব বেশি কথা বলতে চাই না। একটা নতুন কনসেপ্ট নিয়ে আমরা, একটা নতুন ধারণা নিয়ে আমরা কাজ করছিলাম গত 5 বছর ধরে, সেটি হচ্ছে পদ্মা গঙ্গা গোমতী লিভার সম্মেলন। আমরা যেটি মনে করি যে বাঙালি অধ্যুষিত পৃথিবীর যে অঞ্চলগুলো আছে, বিশেষ করে বাংলাদেশ, পশ্চিমবঙ্গ এবং ত্রিপুরা, সেখানে তো বটেই, এর বাইরেও বাঙালি লিভার বিশেষজ্ঞরা কিন্তু ভারতবর্ষের বিভিন্ন জায়গাতে এবং সারা পৃথিবীতে ছড়িয়ে আছেন, এবং তাদেরকে যদি একটি জায়গায় নিয়ে আসা যায়, সেটি বাঙালি এবং বাঙালির লিভারের চিকিৎসা এবং বিকাশে, গবেষণা বিকাশে দারুণ ভূমিকা রাখবে। সেই ধারণা থেকে আমরা আগাচ্ছিলাম। সেখানে কিন্তু আমরা প্রদীপ ভৌমিকের কাছ থেকে ধারণাটা গ্রহণ করেছি যে আমরা শুধু লিভার বিশেষজ্ঞদের প্ল্যাটফর্ম তৈরি করতে চাই না, লিভার বিষয়ে আগ্রহী বিশেষজ্ঞ যারা ইন্টারনাল মেডিসিন স্পেশালিস্ট বা অ্যালাইড সাবজেক্ট যারা লিভার নিয়ে আগ্রহী, এবং সেই সমস্ত ব্যক্তিবর্গ যারা লিভার নিয়ে গবেষণা করছেন এবং যারা কমিউনিটিতে লিভারের বার্তা পৌঁছে দিতে যাচ্ছেন, সবাইকে নিয়ে একটি প্ল্যাটফর্ম গঠনের চিন্তা থেকে আমরা এগিয়েছিলাম। এবং এবছর আজকেই আমরা চূড়ান্ত করেছি একটি আগরতলা ঘোষণা আমরা আগামী পরশুদিন আনুষ্ঠানিকভাবে ঘোষণা করব এই সম্মেলন থেকেই, পঞ্চম পদ্মা গঙ্গা গোমতী লিভার সম্মেলন থেকে, যেখানে বালিকা বা বাংলা লিভার ককাস বলে একটি সংগঠন আত্মপ্রকাশ করবে। আমরা বালিকার মতোই চাবো সেই বালিকা একদিন যুবতী হবে, একদিন পূর্ণবয়স্ক হবে এবং বাঙালি এবং বাংলার লিভারের চর্চায় বিকাশে একটা দারুণ ভূমিকা রাখবে। আমি খুবই আনন্দিত এবং গর্বিত যে আমাদের মাননীয় প্রধানমন্ত্রী শেখ হাসিনা তিনি এই বালিকার বিষয়ে, পদ্মা গঙ্গা গোমতী লিভার সম্মেলনের বিষয়ে একেবারেই ওয়াকিবহাল। 5টি সম্মেলনে কিন্তু তিনি বাণী প্রদান করেছেন, এবারও তিনি এই বিষয়ে একটি বাণী প্রদান করেছেন, যা একটু আগে মাননীয় মন্ত্রী মহোদয় যে স্মারকটির মোড়ক উন্মোচন করলেন তার প্রথম পাতায় ছাপা হয়েছে। আমার সৌভাগ্য হয়েছে সেই বাণীটি আমি সাথে করে নিয়ে আসতে পেরেছি। তো আমি আমার বক্তব্যের একদম শেষ পর্যায়ে চলে এসেছি, আমি আপনাদের সবার কাছে বিদায় নিচ্ছি, কিন্তু আমি প্রদীপ ভৌমিক দাদাকে একটু অনুরোধ জানাবো যদি আপনি এসে বাণীটি আনুষ্ঠানিকভাবে এই সংগঠনের পক্ষ থেকে সম্মেলনের পক্ষ থেকে গ্রহণ করুন। সবাইকে অনেক ধন্যবাদ।
Thank you, sir, for your valuable words. Now, we'd like to call upon Dr. Sudhamshu Kesi, who is a senior consultant hepatologist from Nepal. I would like to request, sir, for your valuable speech.
Dignitaries on the dais, ladies and gentlemen, it's my privilege to be here in Agartala, Tripura, to attend this conference. This is my first visit to Agartala, though I have been visiting India for the last 20 years in different conferences. So I enjoyed here thoroughly the kind hospitality of HFT and Pradeep Bhaumik sir. I thank everyone here present who attended the conference, and I think I'll be returning home with lot of knowledges, and also about the activities of HFT that I can also replicate in our country, and to make hepatitis free country. I'll also learn from Tripura. And lastly, I thank you once again for giving me opportunity to be here, present my lecture, and enjoy the beautiful place of Tripura. Thank you very much.
Thank you so much, sir. Today, we have Dr. Gaurav Choudhury, who is a veteran gastroenterologist and hepatologist of India. I would like to request, sir, to distribute his newly published book, Health Adda, to our respected dignitaries. Have a big round of applause for sir. We would like to request Dr. Gaurav Choudhury sir for his valuable speech.
Thank you very much for this very warm welcome, and it's a pleasure to come back to Agartala, Tripura every now and then. Pradeep is very warm in his invitation, and since everybody is waiting to listen to the two celebrated, celebrities, chief guests, I'll cut my talk very short. In case if you will help us, guide us. Sir, wo guide ke liye you have to read my book. So in case if you believe that, I have lost science and I'm writing only for public, it's a matter of pride that this month Springer has published my technical book on hepatology and gastroenterology. It's an international textbook which will be marketed all over the world. This book is meant for people, both doctors, patients, and common people, to get an idea as to what are we talking about when we use this big word called health. So it's a multidimensional, commonsensical book, but grounded in science. So I would encourage all of you to read it. If you don't like it, feel free to tell me that it was a big bore. With regard to what I have to say, only 3 points. Pradeep Bhaumik is an extraordinary person. You see, half the life that I have seen of people they spend, they never identify a problem that they want to tackle in life. So they drift all the way with the usual responsibilities. Pradeep Bhaumik at some point in time decided that he wants to chase a virus. Am I right? And that was, how long back was it? 2002. And I have known him from that time. Probably I was here in one of your early meetings, but several of them. So first is he identified a virus that he wanted to hit and kill. So at least he decided and identified a problem. Second is that he worked very hard to do it. So it means that for anything that you achieve, you need passion. You see, otherwise we move from one problem to another. So I have seen his passion when he invited me to the HFT program in Udaipur. And sir, I must tell you, if you need people to do your canvassing, he would be one of them. I'll tell you why. I was amazed. He woke me up at 7 in the morning and I went out and there were a whole lot of motorbikes and he was sitting on the back seat of a motorbike carrying a flag of Hepatitis Foundation of Tripura and going around all over the countryside spreading awareness on hepatitis. Amazing activity. That's passion. And the third, so first you identify the problem, then you have passion to solve it. And the third, he realized that he can't solve it as an individual. So his organizational capacity was fantastic. I mean, if you look at what he has achieved, the greater part of it is his organizational ability to involve all of you as well-meaning members into this foundation, and each one of you is a valuable contributor to the cause. And today I believe they have been able to solve or at least vaccinate 40% of the population of this state. Amazing. No other state has done it. Okay? And now he is tackling hepatitis C. Unfortunately, there is no vaccine for it. But the fact is that this is a major achievement. So with all that, big round of applause to Pradeep Bhaumik. And my earnest request to the people in power that, when good work is done, give him all the support. Thank you so much, sir.
Thank you so much, sir. Now, I would take the honor to request our guest of honor, Sri Kiran Gitte, sir, IAS Secretary, Health and Family Welfare Department, Government of Tripura, to say a few words.
Good evening. On the occasion of 7th LIVERCON and 5th Padma Ganga Gumti International Liver Conference, on the occasion of inaugural program by Hepatitis Foundation of India, on the dais, the chief guest of the program, Honorable Minister of Tourism, Transport, Food, Civil Supplies, Shri Sushant Chaudhary ji, distinguished guest on the dais, India's renowned hepatologist, Dr. Gauradas Chaudhary ji, who shared with me that he had a long association with Tripura. His father served in the judiciary of the state and he often used to visit the state, and he has maintained liaison with the state and now helping all of us. Dr. Mamun Al-Mahtab ji from Bangladesh, Dr. Sudharanshu Kesi from Nepal, Dr. N.L. Bhomik ji, Dr. Pradeep Bhomik ji, Dr. Major Pranab Kanti Datta, Dr. Bikash Rai ji, and all the senior health professionals and the young doctors here. I am delighted to be present on this occasion, and I am also grateful to the Hepatitis Foundation of Tripura for their continuous work, because I know that when I was Agartala Municipal Commissioner in 2009, from that time I know their activities and I have participated in their activities, camps, and tried to help them when I was district magistrate in Agartala. That time also we did a lot of work, and the burden of hepatitis in Tripura, they have a big role to manage that, and I think with all of you joining their efforts, I think we will finally succeed. Now that the vaccines are coming up for this disease of liver, we have a vaccine for hepatitis B. Now even other A and E are also being made available with the latest technology. So I'm an engineer, I'm not a doctor, so I don't understand much about the disease, but I know what it takes to handle the health care in the state. So I won't speak much on this issue, but as overall health, we have a very, very serious challenge at our hand, because when I took over in the month of February, I could work only for 1 month, and then there was a model code of conduct and we could not do much. Now again we are trying to do. We have big issues in the state like early marriages, infant pregnancy. You might be knowing, but just to share that we have highest infant pregnancy in the country. We are the highest. We have 21% of the infant pregnancy, and that gives to the issues of IMR, MMR. We had a very good trend of, say, decreasing IMR, MMR. Even still we are better compared to country average. But the way we were doing it now, somehow, I don't know what has happened, but we have to again get on the track. So for that, government has invested huge in the infrastructure of the state health infrastructure, especially after COVID. In last 4 years, we have seen every year 2,000 to 3,000 crore rupees infused in the health infrastructure of the state continuously. And we have 1,145 doctors on the government roll, only for 40 lakh population. So that is one doctor for, say, 4,000 population, you can say. We have good number of doctors, we have good infrastructure, we have a good presence of paramedical staff also. We have a very capable team of CHOs who have joined the community health in last few years. They are well trained also. And the quality of health infrastructure that we have in government, now it matches with the private, and at times it is better than private. This I am not saying as a health secretary, but many of the patients who come to us, many come to us early, many comes to us at the fag end of their extreme health condition, and they share their experiences about our doctors, about their skills. One thing I am convinced that we have a best doctors in the country. We have best, well-educated, actually their approach, attitude is very humane. Okay, I come from Maharashtra, we know Bombay, Pune, everything, but the commercial aspect is not there, and we have a very human approach, because at very odd hours, at very difficult conditions, I have seen doctors and paramedical staff working. Even when I was DM in Dhalai district, So Dr. Pradeep Bhomik was mentioning here that our doctors could walk with us for the health camps for 10 kilometers, 8 kilometers, along with the medicines. And we used to go to villages and hold a camp there and then come back. So now I think we have to make best use of the health infrastructure in the state. One more point which I would like to say, that government is now committed to bring in the super specialists. Now state government has sanctioned about 188 posts of specialists and super specialists. So, and we are hiring them not at a government fixed salaries, but we are asking them to quote the salary. And then we are adjusting our salaries and we are asking them to join us. And a few weeks back, a young doctor from Tripura who had done a PG in London on a knee joint and hip joint, he has come back and he wants to work with us. There are so many people who want to come back and work with us. So we have devised a very flexible policy as far as the super specialists are concerned. So our super specialty block has come up. Now 3 disciplines there. Nephrology has already started, urology we are starting cardiology also in the super specialty block. You will see that the state-of-the-art facilities are there, which are set up by the government. Regarding this organ transplant, we have signed MOU with the Sija Hospital for kidney transplant, and they will also go to the organ transplant very soon. So I hope that if everything falls in line, we will have the first kidney transplant in our state in July. So let's hope that we embark on this journey. Because we have heard here that liver transplant being most difficult and it's most challenging, but we will see our state also going on that. Apart from that, what health sector has to do, and there is no other way, is to go digital. Because still we know that doctors are very fond of writing on a piece of paper and prescribing in a handwriting that only they and the pharmacists can understand. There is more than the computer science, doctors know their own science of handwriting that nobody knows. But now we cannot afford that. We have to go digital. I mean to say that Government of India has come up with the concept of ABHA number, Ayushman Bharat Health Account. It is a Aadhaar. It is basically Aadhaar. It is masked. That you generate your, like a PAN card, you have a health account. Now we have about 16 lakh people in the state who has ABHA number. What this ABHA number will do is that right from your vaccination, your treatment, your annual checkup, your any of your ailment, which doctor has prescribed which medicine, you took which drugs from which pharmacy, who operated you, what is your CT scan, MRI scan, everything will be there attached to your ABHA number. And that wherever you go to Delhi, Bombay, America, that if you quote your ABHA number, no, they can access your health record. So you need not carry those plastic bags, files and no more. And more than that, we can make analysis of your health parameters. This is the biggest, benefit of having the digital health record. Now, once we do it, then we can analyze, because we are having different geographies, different ethnic groups, because I was reading this souvenir, it is mentioned that our tribal population is more prone to hepatitis C. So it may happen that the ethnic issues also come into picture. So we can do all this analysis and then we can devise our health strategy. Now, once the patient want to go to GB hospital, IGM hospital, right now, he has to go there and stand in a queue. And we have 2,000 plus OPD in GB and 1,200 plus OPD in IGM every day. So it is humanly impossible. So what we have done, we have now given their QR code that you need not stand in line. Now you can go to IGM GB and scan that, but you have to have ABHA number. Now, if you have ABHA number, then you can not only do a scan when you go there, you can do the scan at your home and take appointment of doctor, IGM or GB, and at that time you can go to the hospital. So you need not go to hospital at 10 o'clock and stand there for 2 hours. You can go just in time. So you can save your time, you need not be in a queue. Another thing is that when you go there, then you get a token, like say, now we all book our air ticket online and we will get a electronic boarding pass. So we'll get an electronic token of GB or IGM or Gomti Hospital or any, even at the PHC CHC, you'll get a token, electronic token. You can make an online payment. The doctor there, because we are now going to give them a gadgets, that they will also get a tab where they can just spell out the diagnosis and also mention the medicines. That will get automatically recorded in their gadget and that will be stored in the patient's ABHA account. Then if they want to do some diagnosis, they can mention about test, and test report also will also be coming to the ABHA number. So like that, no, we have to go digital. And third thing is that all this, there are so many portals, so many apps which have come up. Now we are coming with a single platform that with a single login, anybody can see the ASHA workers, CHOs, MOICs, CMOs, directors, they all can see your electronic record at a place. So going digital is another thing. Now in Agartala we have proposed, it is not yet decided, but we have proposed Agartala Municipal Corporation to open a civil hospital in Agartala. to bring down the load on the GB and IGM. And Agartala Municipal Corporation has agreed to set up a 50-bedded hospital which will be managed by the Agartala Municipal Corporation, like other corporations in the country. Well, if you do that, then our GB hospital and IGM can focus on a tertiary.
Now we have a beautiful dance by Priyanka Dev, nursing student of HFT. What a beautiful dance. Now we have the last performance. I hope you will enjoy this. It is a group song by our HFT nursing student. I would like to request them to come up to the stage.